Good morning, everyone. We are about to start this morning session. I hope with no further delay. And it's kind of devoted to a few problems which are beyond the usual scope of the interventional endovascular specialist. And I want to open with the first speech, which would be devoted on the chronic thromboembolic pulmonary hypertension. Later on, we will have a second short speech concentrating on the endovascular modalities for treating the Sept. Now, I will try to do a 10 minutes review for you and take you to this very exciting field. So please, can I have my slide? Sept is for chronic thromboembolic pulmonary hypertension. By definition, you need to have pulmonary hypertension, so your beam pressure in the pulmonary artery should be more than 20 millimeters mercury. And according to the European Society definition, what is peculiar to Sept is pathological lesions which are characterized by the organized thrombi tightly attached to the pulmonary arterial medial layer, which are replacing the normal intima. And that is the only potentially curable form of pulmonary arterial hypertension. It's a long-term complication of pulmonary embolization. The exact numbers are moving targets, so it's probably not so rare as we used to think of it. But not all patients with a Sept would have a history of pulmonary emboli. Roughly 1/4 will have anamnesis of pulmonary emboli, the other 3/4 will not. 5 per million per year, that's the prevalence, but probably it's underestimated. And rarely it can present as a pseudo-acute pulmonary emboli, that means acute patient with no acute thrombi. The risk factors are traditional factors for thromboembolization. I want to point out that roughly 20% of these people will have some antiphospholipid antibodies, lupus anticoagulant, and that's why new anticoagulation DOACs are not very suitable, at least if you not rule out lupus anticoagulant, because we know that new anticoagulations don't work well when we have antiphospholipid antibodies. We have a few risk factors like splenectomy, history of infected shunts, and indwelling catheters, but 95% of the patient will not have any. So we cannot rely on the risk factors to screen for this condition. Prognosis is roughly the same as the untreated pulmonary arterial hypertension nowadays. We have 60% survival at 5 years, and that is for the non-operated patient. In this nice study by the Czech group, you can see that if the patient is operated early with no residual pulmonary hypertension, then prognosis is very nice. And if the patient is inoperable and not treated, the prognosis is much worse. We have some new data coming from meta-analysis of Chinese group showing that with a patient which is not suitable for operation but still suitable for endovascular intervention, you can do a lot and improve the prognosis. But those are observational data. We don't have any randomized comparison. The problem with the Sept that you're not only treating the proximal vessels, it is two-compartment diseases. Very often you will have some disease of the microvasculature of the lung, both beyond the obstructed segments and also in the segments which are not obstructed. Like you can see in this slide, few vascular beds are non-perfused at all, and when you have perfused beds, you frequently have these lesions which are very comparable to the pulmonary artery hypertension. Depending on the severity of these lesions, you can predict the result of the treatment removal of the proximal thrombi. If you do a pulmonary angio in the late phase, you can see that some of the lung portions are completely non-perfused. You have relatively good perfusion in the lower part, and here, I cannot see my pointer, but you lack subpleural perfusion, which is also a sign of microvascular disease. There's a peculiar study done with the help of dual energy computed tomography showing that in comparison to the normal perfusion, you may have this kind of specific wedge-shaped perfusion defect, or sometimes you can have subpleural perfusion. The blue color is disease vessel. And even if you compare with the perfusion in the patient with pulmonary arterial hypertension compared to the Sept, you have this peculiar pattern with very bad perfusion on the periphery. Symptoms are usually dyspnea on exertion and syncope. In the later stages, you have right heart failure symptoms. Diagnosis, you have a few modalities. VP scan is very useful, but unfortunately not available in Bulgaria too. So most of the time you can rely on transthoracic echo and CT. Of course, pulmonary angio is a gold standard. On the CT, when the diagnosis is easy, what you see is a huge proximal defect, and this is a patient which are happy and they can be operated with a very nice result. Beyond this defect, you may see also enlarged bronchial arteries, which are very specific for these conditions, and of course you have mosaic perfusion. Pulmonary angiography is sine qua non. It can be performed in any patient. There is no such thing as a contraindication for pulmonary angiography if you perform it wisely. Most of the time it will reveal either this chronic situation like down below when you have occlusion and webs and bands and so on, or sometimes you can have both. You can have also acute and chronic. When acute situation you have contrast flowing around the thrombi, and it's very different compared to the chronic situation. Why it's important? Because when you have a mixed lesion, simple anticoagulation sometimes is doing a good job. That's a patient with a 6-month trial of anticoagulation, which went down with the peripheral vascular resistance almost twice after 6 months of trial. So it's important to assess all the vascular beds. So why do it invasive assessment? First of all, because we want to know which patient is operable, which is not. And then we want to select the patient for pulmonary angioplasty if the patient is not operable. That's the main reason. So first of all, you confirm the diagnosis, then you do a hemodynamic assessment. It is a cardiology job, and you have a nice predictors about prognosis and the effect of the operation from hemodynamics. You can assess thrombus accessibility, and you have a very distinct angiographic pattern of disease. I will show it later. And after you establish diagnosis, you go to a treatment pathway, and you select operable patient from non-operable patient, and later on you decide what to do with non-operable. We have this surgical classification of diseases. Type 1 is a patient with a very proximal disease, and type 4 is a patient with a very distal disease, and type 2 and type 3 are in between. This is a surgical specimen taken out by endarterectomy from type 1 disease. You see a number of organized thrombus proximal in the arteries. Those patients with most of the time with a very excellent result, and those are the patients who will live almost normal life after the operation. Type 2 is when you have this segmental lesion which are accessible by surgery but a little bit distally. You see this guy who was doing professional sport after the operation. Actually on the left have a type 2 disease, on the right have type 1 diseases, so on a different bed it can be different. And type 3 when you have only obstruction of the subsegmental arteries. And those are the patients when you discuss pulmonary angioplasty. Pulmonary angioplasty is something relatively new. It's pioneered by the Japanese guys, and it relies on the ability of the balloon to disrupt and destruct the substrate, I mean this membrane which you see down there in the segmental arteries, and to lower the resistance. It's very peculiar procedure. It's not always easy to see the lesions, but most of the time with the experience as it comes, it's possible. if you put eyeballs or some imaging inside the arteries, what you see is a pattern like this, plenty of organized lesions, like they say, like cheese holes. And when you balloon it, of course, it leads out to increase of the flow because you are removing an obstacle on the way. We have some peculiar angiographic characteristics of the lesion. Some of those are accessible for intervention, some of those not. It comes out of experience. And in my conclusion, maybe CTEP is more frequent than we think. And in every patient, we have a unique mix of large vessel, small vessel, and microvascular disease, which is not always easy to assess. Of course, surgical treatment is a treatment of choice if the disease is surgically accessible. So that's a very good chance of the patients. But in the rest of the population, we can achieve a lot by using drugs and simple balloon angioplasty. So that's for me. Thank you.
Thank you, Professor Velchev. Any question from the room? Thank you. Okay, we're going with the next presentation. Endovascular treatment of massive and submassive pulmonary embolism. Dr. Dobrev. Please, Dr. Dobrev.
Hello, colleagues. Thank you for the opportunity to present on the topic of endovascular treatment of massive and submassive pulmonary embolism. So we all know the distribution of the pulmonary embolism patients, and this is this is the situation. At the bottom, around 50% of the patients are those with low-risk pulmonary embolism. Around 5% at the top are the high-risk pulmonary embolism patients or the massive P pulmonary embolism patients, and in between them there are the rest, which are the intermediate risk or the submassive pulmonary embolism patients. We all know what the current guidelines recommend. For now, endovascular therapy is set as an alternative either to anticoagulation or systemic fibrinolysis. So there are two main branches in the endovascular treatment of acute pulmonary embolism. One of them is the low-dose supraselective fibrinolytic therapy, and the other is the percutaneous thrombectomy. I will try to be as brief as possible, just as introduction in the field regarding the following lectures. So I will show you only 4 devices which I think are relevant in the field. The first is a device that has been used for more than 10 years, is the ECUS ultrasound-assisted thrombolytic therapy. It's a well-known device which enhances the effect of the fibrinolytic by low power, high frequency ultrasounds directly into the thrombotic masses. The efficacy of this device is supported by several trials. First of them is the Ultima, Seattle 2, Perfect Registry, and the Optimize P trial, which all confirm these results: meaningful right ventricle to left ventricle diameter ratio reduction, meaningful mean pulmonary artery systolic pressure reduction, and significant reduction in the thrombotic masses measured by the modified Muir index. It should be mentioned that in all of these 4 trials there was only 1 case of intracranial hemorrhage, and the used fibrinolytic doses were as low as 8 milligrams TPA. Another interesting device that I feel should be mentioned is a device that was introduced 1 year ago. Is the Bashir endovascular catheter, which consists of a mesh-like basket that's introduced into thrombotic masses. It's open there and allows through these micropores that you see for the fibrinolytic to be applied directly into the thrombus. These are the results from the Rescue P trial that were published last year. The device was used in around 100 patients with intermediate high risk pulmonary embolism, and as you see, there was more than 30% reduction in the RV-LV ratio, more than 30% reduction in the PE obstruction index, and less than 1% adverse events and major bleeding events. What should be mentioned that is the total fibrinolytic dose in this trial was 14 milligrams TPA. So when it comes to percutaneous thrombectomy, I feel that two devices are most important in their class for the moment. We are all familiar with the Indigo thrombus aspiration system, but what's new is the introduction of the CAT-12 catheter with a 12 French larger bore catheter and the Lightning system. The Lightning system is something very interesting. It's a artificial intelligence enhanced system which allows the whole system to differentiate when it's in a thrombus and when it's not, and when the device senses that it's not in a thrombus, it stops the suction, which greatly reduces the blood loss. And this combination of this catheter and the Lightning system gave the confidence of the provider to call this system and this procedure computer-assisted vacuum thrombectomy, or CAVIT. I just want to mention two important trials using the penumbra. One of them is the STRIKE-PE trial, ongoing trial with 600 patients to be included, which will evaluate the effectiveness of CAVIT for the treatment of intermediate and high-risk pulmonary embolism patients. The results for the first 150 patients are encouraging. The other trial that has just started is the STORM-PE trial. What's interesting about this trial, it will include 100 patients, but it will be the first trial to compare a percutaneous thrombectomy device compared to anticoagulation for the treatment of intermediate high-risk pulmonary embolism. Another, for me, big game changer in the field is the FOLT-RIVER from Inari Medical. This is a very large bore thrombus aspiration device, up to 24 French, very flexible. It has an aspiration tube, and additionally it has this Nitinov self-expandable discs that help to introduce the thrombotic masses into the aspiration catheter. I will mention briefly two studies. First of them was the FLASH registry, which was a prospective multi-center single-arm registry which evaluated the efficacy of the device in 800 patients with at least intermediate risk pulmonary embolism. The primary endpoint was major adverse events composite of device-related mortality, bleeding, and interprocedural complications. In this slide, I just want you to focus on down to your left, the lytics contraindication percent. It's more than 30% of these patients had absolute or relative contraindications for fibrinolysis. Most of them were with intermediate risk pulmonary embolism. Around 8% were with high risk pulmonary embolism. Regarding the outcomes, the primary major adverse event composite endpoint was observed in 1.8% of the patients, 0 device-related deaths, 11 cases of major bleeds, but I want to know that these major bleedings were due to the suction force of the device. Later, additional blood saver add-on was added to the device, and which significantly reduced the blood loss. There were less than 1% interprocedural adverse events, and the all-cause mortality for the first 30 days was below 1% and 5% at 6 months. Regarding the hemodynamic responses, more than 20% reduction of the mean pulmonary artery pressure and the total pulmonary vascular resistance, and increasement of the cardiac index with almost 20%. So this is the next and final trial I want to focus on. I think this is a really important trial which will lead the field in the right direction. This is the FRAME trial, a prospective mood-centered non-randomized trial which compared the fault trigger device in high-risk pulmonary embolism patients compared to a context arm. What does the context arm mean? These are patients treated in any other way possible, but not with the fault trigger device. The primary endpoint was in-hospital composite of all-cause mortality, bailout to alternative thrombus removal strategy, clinical deterioration, major bleeding. The primary endpoint was compared to a performance goal of 32%, which was established from a published meta-analysis, which means the primary end goal and the point should be 30% events or less. And the trial was prematurely stopped due to interim analysis at 50 patients, which showed composite primary endpoint of 17% for the fault trigger arm compared with almost quadruple more cases in the composite primary endpoint in the context arm. The most striking difference was in the in-hospital mortality. You see less than 2% in the fault trigger arm and around 30% in the context arm. Regarding to the safety outcomes, just one stroke in the ischemic stroke in the fault trigger arm compared to 2 ischemic, 2 hemorrhagic strokes in the context arm. No fault trigger, no device-related adverse events were mentioned. And as a conclusion, I want to say that the field of the endovascular therapy of pulmonary embolism is progressing rapidly, hand in hand with the technological advancement. New and more efficient devices are being tested, accumulating the much needed clinical data for their everyday clinical practice utilization. And I think very soon the interventional treatment of patients with submassive and massive pulmonary embolism will be the preferred or probably recommended treatment of choice. Thank you.
Some questions from the audience. I have a question. Do you have more cases in the era of COVID?
We, my colleagues and the teams we work with, we have cases, but because of the short time of the lecture and its introductory characteristics, I didn't mention the case.
But yes, this is promising method, and I hope that we will have option to save the lives. Definitely. Yes. Thank you.
Thank you.
It was very interesting. Next one will be.
The next one is thromboaspiration device, Dr. Polonsky.
Може и часа да им кажем. Dear colleagues, thank you for the opportunity to present our work and excuse for the technical problem. So my presentation is quite similar to Dr. Dobrev's presentation according some devices, so I'll try to skip them. About the incidence of pulmonary embolism, you know that it's actually third cause for cardiovascular death worldwide nowadays. More than a third of patients present with sudden cardiac death at the presentation into emergency room. More than 50% of pulmonary embolism incidence was undiagnosed, and this is a reason for CTEP late after that. And unfortunately, the estimated incidence in the US about pulmonary embolism is 500,000 and even more in some series. And pulmonary embolism is implicated in more than 10% of in-hospital mortality. About the treatment, first of all, current guidelines divide the pulmonary embolism patient into 3 risk groups, 4 because the intermediate one is divided by 2. And according to that, when we talk about high-risk patient, it's mandatory to have a hemodynamic instability. Nowadays, the goal of treatment of any suction device, any thrombectomy catheter, is actually patient with high and intermediate risk with focus on intermediate high subgroup. Here are all treatments available for pulmonary embolism. Of course, cover filter are preserved for prevention, but anyway, systemic anticoagulation is a cornerstone, as we know. There are many devices for transfragmentation and ultrasound-based therapy. The presentation is focused on devices for percutaneous thrombectomy. There is one problem with such device, and this problem is that there is very small number of non-randomized or randomized trials. Here is the biggest known meta-analysis based on more than 8,000 patients treated with catheter-based technique. Not every technique is based on suction. There are also techniques based in ultrasound, etc. 8 clinical trials with huge number of patients and clinically significant lower mortality when catheter-based technique is used compared directly to fibrinolysis. Here is the biggest meta-analysis with mechanical aspiration with more than 500 patients. 3 devices are used: Inari Retriever, Indigo, and Rotorex and Aspirex devices. Technical success is achieved in 97% of the patients. In-hospital mortality is 3.6, and only 0.5% of major bleeding. However, we must discuss also the fact that in such a trial, thrombolytics are used by decision of the operators, and to be honest, they are used with small dose in most of the patient in case. Here are a short list of patients that are actually beneficial for treatment with suction-based device. In case of failed fibrinolysis, which is about 8% in the series. In case of contraindication of fibrinolysis, when we talk for absolute and relative contraindications, we may discuss more than 20% of pulmonary embolism patients as contraindicated for systematic fibrinolysis. Furthermore, we must take in mind patients with a high risk of bleeding. Even if fibrinolytic agent was used during treatment, the dose is far lower compared to fibrinolysis alone. So shortly about available thromb aspiration devices right now. Aspirex that Dr. Aspirex catheter is up to 11 French device. The catheter shaft contains a rotating coil, and this is important because two reasons. First of all, it generates vacuum in order to make the thrombotic suction, and furthermore, during the rotation of device, the thrombus that is already inside the catheter is macerated, so it can be very easily sucked with from the catheter. There are very good results in two European series available right now with complete thrombus clearance in more than 80%. Here is the biggest one. Number of the patients included is 16, with complete thrombolysis up to 90% since 14 of them, and total 1 year of survival of these patients, it's 30, which is very good result for high-risk patient. Another device that Dr. Dobrev already discussed, so I'll skip most of the info. It's a fault retriever. It's really a game changer and a favorable device anywhere. Very widely used in the United States. It's a combination between suction catheter and also trinitinol disc system that made thrombus engage very easy to be evacuated from the patient. In most of the trials, the ratio between right and left ventricle is measured as including catheter above 0.9 and also as result parameter. In fault retriever, 42nd day after procedure, RV-LV ratio reduction was more than 25% with a very low incidence of major events. Actually 6 major events, 4 patients was experienced such event, and major bleeding in only 1 patient. There is 1 death from reason not related with procedure or thrombonary embolism. What is more important, FLASH registry that is already discussed from Dr. Dobrev, just few words about it. Normal echocardiographic function of the right ventricle is increased from 15% at baseline at admission of the patients to up to 95% at 6 months. Also, there is an improvement in 6-minute walk test distances from 180 to almost 400 meters at the 6 month, and CTEP at the 6 months among all 800 patients was only 1%. Penumbra system, also already discussed. It is actually combination between the catheter and also separator, which is not mandatory to be used. However, the separator smashes the quote to smaller pieces and makes the suction of the thrombus very easy. It's designed for fresh and soft emboli predominantly. Here is the result about penumbras and 2 ongoing trials that Dr. Dobrev said, STRIKE and STORM-PE. What is very important for STORM-PE is that it evaluates the results from penumbral aspiration system among patients with intermediate high risk, but it's a randomized trial. So this is why it's very valuable. Angiovac is veno-venous bypass circuit. Info and outflow cannula was used. The system engaged the thrombus, use it, and then recirculate the cleared blood back again into the venous system of the patient. So there is a minimal blood loss. This device has a CE mark for treatment of caval thrombi, even right heart mass, even vegetations. Unfortunately, there is a low experience among patients with clear pulmonary embolism. In these 234 patients, only 13 was with pulmonary embolism at the beginning. So, a few words about our experience. We have 6 patients treated with high and intermediate high risk with penumbra system. 2 of them was contraindicated for fibrinolysis. 4 of them was with already done unsuccessful fibrinolysis, and 6 patients with Aspirex system. We have 0 intraprocedurally mortality, shocks index below 1 at the end of the procedure among all 12 patients, no mortality for 2 years follow-up, and drop in right ventricle systolic pressure with mean drop of 18 millimeters of mercury. Just faster 2 clinical cases. First of them is 24 years female, 1 week after cesarean section. 4 years before pulmonary embolism incident, she had post-traumatic subdural hematoma, which is actually the second contraindication for systematic fibrinolysis. During admission, the patient was with moderate tricuspid regurgitation, dilated right ventricle, and pulmonary hypertension. Here is the ECG with admission with the data for right heart. So what we see among CT, there is a huge thrombus into the left branch, mainly for the basal branches of the pulmonary artery, left pulmonary artery, and indigo penumbra system was applicated in both sides with this final result. Very lower thrombotic burden residual, and here are some of the thrombotic masses aspirated with the indigo system. Here is the ECG on the first day after that. There is no data for right ventricle overload. And another case with Aspirex, just after COVID infection, 57-year-old male with admission with data for positive troponin level, positive McConnell site, and measurement of right ventricle pressure above 60. Here the CT, pulmonary embolism on both branches of the pulmonary artery, mainly at the right, and measurement of systolic pulmonary artery pressure was 68. Here is the angio before. Some aspiration with Aspirex catheter. With reducement of systolic pulmonary pressure of 47 millimeters of mercury. So as a conclusion, I must tell that despite the fibrinolysis is golden standard in pulmonary embolism treatment, there are several nowadays there are several available devices for thrombus aspiration. Thrombus aspiration is the only way to immediately reduce the thrombotic burden, and according to our limited experience, they are safe and effective for treatment of pulmonary embolism. But according to clinical trials that published it in last year, actually probably they are big game changer into the treatment of pulmonary embolism. Thank you.
Thank you, Dr. Polomsky. Any questions from the room? Comments? Professor Vasiliev?
Maybe with a short comment. Is that working? It should be. Okay. To be honest, I started with thrombus aspiration in pulmonary embolism maybe just 12 years ago, doing manual thrombus aspiration, and we presented our results in 2017 during TCT about the technique. But unfortunately, maybe excluding we're using at the moment Penumbra in Vruh, and I think we have a little bit around 10 cases from for the last 4 or 5 months where we started. But my personal impression is that what really works in those situations, the thrombus aspiration works just in acute setting, just to a little bit improve the how to say, the hemodynamics of the patient. But what really works is fibrinolysis.
Yes.
Actually, what really works on thrombus, let's say it is our usual practice in massive pulmonary embolism to check the patients on the next day by angiography, and what actually we see that fibrinolysis is what really decreases the thrombus burden, because with 8 French, I don't know what is your experience with 12 French Penumbra. We don't have. We use only 8 French Penumbra. To be honest, even you can have on the table a huge mass of thrombus, but the angiographic picture is not so amazing, let's say so. And what really changing maybe will be fault river from Inari, but unfortunately the requirements from the company about the training is enormous. So I don't know what is your experience about the, do you have some with Inari? With the, you know, this is probably the only system which really can remove these huge masses from the pulmonary circulation. I don't know, Professor Bachvarov, what is your experience?
Unfortunately, we have no experience. We asked our colleagues from intensive care unit about mechanical thrombectomy, and they told me, don't worry, this is not so attractive option. We do thrombolysis. And this is, we don't have so hurry like in acute ischemic stroke. So this is good option, but we will talk about mechanic thrombectomy in the future. So in our hospital, we don't do this option. I want to do that, but you're right. Not always the angiographic result is excellent, but maybe hemodynamic also is important. Yeah.
Yes, actually with mechanical thrombectomy, the only purpose I see at the moment, after doing more than 100 personally, more than 100 mechanical thrombectomies, is just to improve the hemodynamics, acute hemodynamics of the patient, and to reduce a little bit pulmonary pressure and to improve the pulmonary circulation, and just to give an option for fibrinolysis to work. This is what actually, at the beginning I was very enthusiastic, and I spent 3-4 hours just branch by branch to aspirate, and finally, yes, you can be satisfied to some extent, but the truth is that what after these 12 years I can say, and in total my colleagues now are collecting the patient, and the truth is that at 9 months the mortality rate for these patients, what is rarely said, but for our patients, the mortality rate is, guess what is the number in Bulgaria for our patients? It's 50% in 1 year. That means, and this is not in hospital mortality. This is a mortality after the hospitalization. If you follow your patient, as you know, I like to do a little bit more research and science, and we follow this patient, and these are data from yesterday. I checked I asked 2 of our fellows to check at the moment the data, and these are the data from yesterday. We checked our patients for the last 2 years, and around between the median 10 years follow-up, the mortality rate of massive pulmonary embolism is 50%. And by the way, this is the same number if you look at the big registries. Despite the great results in mechanical thrombectomy, blah, 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 everything. But the truth is these patients have a very high mortality, very high risk of pulmonary embolism, and this is the main problem, actually.
This is very interesting. Dr. Dobrev, do you have our mortality for the last 3 years?
Може ли един микрофон такъв подвижен?
Групата от пациенти, които ние проследяваме общо взето по отношение на ранната смъртност, нещата същите. Особено при пациенти с субмасивна белодробна тромбоемболия. Масово те в рамките на първите месец, 2, 3, 6 са окей. И след това изведнъж има един пик на смъртността, като това в нашите анализи, което прави впечатление, че поне при нашите пациенти това много често свързано с онкологични заболявания. Тоест спектър на пациентите с белодробна тромбоемболия, според мои лични наблюдения, не само и от литературните данни, са, че се променят, тъй като това са главно белодробната емболия асоциирана с болничен престой. Тоест това са пациенти прележали в болница, които най-често поради това се покачва и процента на I'm sorry for speaking Bulgarian. These are patients hospitalized, operated for some reason, so on. So
After 6 months, mortality in our patient, do you have date?
I can't quote it, but I will check it.
Okay, thank you.
So it is the same.
Yes, maybe it's the same.
Maybe the same, and as I said, the problem is here not the acute event. The acute event is manageable. We have maybe for the last 2 years, maybe we lost only 1 patient in hospital. But this is not a, this sounds good for hospital care, but for long term, I'm not sure.
Yes. Any other question, comment, Dr. Polomsky?
There is actually a tendency for the clinical trials with mechanical thrombectomy to be focused on probably on the intermediate height risk patient. So and as a result, they mention most commonly CTEP on the first year. Nowadays, there is a clinical trial with 8 French penumbra catheter ongoing. In 2026 will be finished. However, there are both groups inside randomized groups. One of them is treatment with 8 French catheter. The other one is fibrinolysis. Probably the results from this trial will spotlight about this problem.
Actually, the only advantage if there is for the mechanical thrombectomy and for this is the local fibrinolysis, and this is the reduced dose of fibrinolytic. Because I don't know what is your protocol, but we use 50 milligram. I mean, we started with the 10 milligram left hand, right, 10 at the center, do some fragmentation, aspiration, and then we finish with 10 and 10 on the left and the right. So in totally we use 50 milligram. I don't know what's your protocol for fibrinolysis?
Little different. Tell about the protocol.
With focus on lower dose with application into the left and right with or without trunk fragmentation before the application, depending of the result from the CT.
But
unfortunately, most of the patients, to be honest, most of the patients are treated with trunk fragmentation using pigtail catheter and guide wire, and then lower dose of fibrinolysis.
In the same patient, we going with the infusion. we put on the balls on both sides 10 milliliters, and after that 30 milliliters for 6-hour infusion of the fibrinolytic.
With the crack McNamara or
No, from the pigtail.
with the pigtail?
Yes, we put the pigtail on the truncus of the pulmonary artery, and after that going with the infusion of the fibrinolytic. This we do it in the patient with distal part occluded from the thrombus pulmonary artery. In the mass of the case, we going the protocol for the thrombus fragmentation and balls 20 milliliter on one side and 20 milliliter in other side.
Yes.
Every patient we discuss about the date from the CT and take
Yes.
yes.
Because there is no approved protocol in the guideline or in the statement. It is actually every institution has adopted some protocol.
Yes.
Okay,
Okay.
so let's go further.
We waiting connection with Santana for the live case.
They're ready.
Hello.
Hello, guys.
Good morning from your university.
Hello, Dobry.
Hi,
Can
hi.
you hear us?
Yes.
Yes.
Okay. So, I would like to give you a short introduction to the case, but first I want to introduce my team. I'm here with Dr. Stoyanov, Eli, our guy from the anesthesia at Yuria. They're very shy, so they do not appear on the screen. And Dr. Kamburov, who will be presenting a few slides about the case that we are showing to you. Dr. Kamburov.
Good morning from University Hospital St. Anna. We are glad to be the first to present a live case on this year's Endovascular Academy.
No.
So this is a short overview of what we'll be doing. It's a middle-aged male with alcoholic liver disease for 2 years with a child PEC score of 9 points, which is a middle B, and no encephalopathy. And the main indication for the TIPS implantation is refractory to medical treatment as CIRRUS. The only striking abnormalities are anemia and low albumin. And we did a reconstruction of the abdominal CT for procedure planning, and the red arrow shows the path of the new track that we're about to create. It should be from the right hepatic vein to the right pulmonary, to the right portal vein. Okay, now back to Dr. Velchev.
Good morning from me. I'll show you where we are. Well, we started with four French femoral sheet for monitoring of the hemodynamic, and this is our usual way. And after that, we puncture ultrasound puncture of the jugular vein. After that, we insert 10 French sheet, 45 centimeters, into the inferior vena cava. And as you can see on the screen, we try to have a wedged contrast media injection to see where exactly is the.
Nikki,
is the
we don't see angio screen. Can you switch to angio?
I'll try to ask the technicians. May we have the
Okay, okay, now we see it. Okay.
Okay, great. This is our contrast media injection through the sheet in the right hepatic vein. We try to have this wedge injection to see where exactly is the portic vein, but that was not we were not able to see the vein. After that, we have several attempts to puncture the liver and to have a connection between the systemic and the portal veins. This is one of the attempts, and it was unsuccessful. and you see in a second.
Can you explain a little bit more in detail what is the intent of this connection?
The idea is to decrease the portic pressure, and like that we have decreasing of the portal pressure, and we if we have a patient with bleeding for portal varices, or as is in our case refractory ascite, this is the way to solve the problem and to reduce the complaints of the patient. And the idea is to have a good, nice shunt between the portic and the systemic vein system, and we provide this with through the jugular vein. We puncture directly the liver, and we connect the both systems. After that, predilate the tract, and the usual way is to implant a stent, self-expandable stent into the.
It is that. I will show you the instrument that we are using. It's a special needle. Can we have it on the screen here?
Yes,
To
we
zoom
can.
it.
The camera.
Yes, okay, we see it.
Okay, yeah, okay.
Sorry, W, you see the needle?
Yes.
A little bit like a septal needle. We have this fingertip pointing the opposite direction of the needle. And the out point of this procedure is we want to have the portal pressure down, because the portal hypertension is what we are fighting, okay? So we started with the portal pressure of 36.
Okay.
We measured it directly, and with the pressure in the vein, something like 16.
14, yeah.
So we have a porto-venous gradient of 20 or something. We can explain why do we have this refractory ascites. If you mention on the screen, our projection of the vessel does not abut the wall of the thoracic wall, because we have a lot of water. You saw it also in the city. So in this instrument, we are going through the parenchyma, we are puncturing blindly the portal vein, and then while removing this stylet, we're able to introduce a wire inside the portal vein. Nikki, can you just show?
Do you have some visual orientation or some signs where to puncture, or it is completely accidental?
First of all, we have a knowledge of the anatomy coming from the city. So that's a kind of a roadmap in our head. Next of it, we know that if we are positioned right in the right pole hepatal vein, that we have a specific, and the pointer will be pointing to our right. And once the pointer is pointing to the floor, that means that the upper part of the needle is coming from behind anterior, and we have a good chance of entering the portal vein. What you see on the screen now is a successful puncture of the portal vein. Can you see it?
Yes.
Yes. Unfortunately, this is it is something between 2 or 5 attempts until you get there. So not always a straightforward procedure. And then what happens usually, your wire is going in the peripheral branch. So you spend some time to redirect the wire to the portal vein, if you can imagine.
Yes.
Yeah,
okay.
and now we have the wire in the portal. We put a catheter over the wire, and now we have the angio. So that's the anatomy of our portal system. As you can see, we are rather centrally, or in the bifurcation of the right portal branch. And what we think we shall do now, we need to balloon it and to be able to place a stent inside. We are right at this stage, and we are ready to balloon, if you don't mind. If you have a question, we can discuss in the meantime.
Do you have you told that you have actually the roadmap in your head, but are there some more, a little bit, let's say, tips for orientation of the needle and for the puncture?
Yes, I'll show it later in my presentation. If the puncture is unsuccessful, if we are not able to do it, we can put a wire inside the hepatic artery, which is running along the vein, and we can puncture on the wire on the fluoroscopy. That's the one trick we know. Other trick is to have a balloon catheter and to do a wedge portography, but most of the time it's not very nice quality, so we try to skip these points. And we are happy when we reach this stage when we already are in the portal vein. But unfortunately, the puncture is kind of a blind most of the time.
Yes.
You can try to do it under echo control. Some guys do it, but we don't in our cath lab.
Okay. And what is the size of the balloon you use for the dilatation of this artificial channel you create?
The final projected diameter of the stent is 1 centimeter, 10 millimeters. So we're pre-dilating with a 9 millimeters balloon now. It's a big peripheral balloon. And you see it on the screen. Yeah. It's very important to us to know the indentation. So the waist of the balloon will be locating the entry point and the entry point in the vein. So we're starting to balloon now, please. Mm-hmm.
I suppose you use low pressure.
Not always so. You see, we have resistance in the entry point. Go back. So we are not able to really pre-dilate it. We try one more time. Nikki?
Yep.
And we save it for later because it's our main, how many atmospheres?
8.
We went up to 8, now we're going up to 10.
10.
Okay, we don't have any waste on the balloon now. So we will remember this position of the balloon, and that's how we're going to position the stent.
Do you have some preference for stent design, or you
Yes,
use?
we do, but we don't have access to the stents. Actually, the best stent is probably the cover stent of Gore, but it's not available now. That's why we are going to use a self-expandable Medtronic Protégé stent.
I mean, because we are now at the course, and maybe it would be useful just to discuss for the educational purpose, just to discuss the most appropriate device. We all know that we use what we have on the shelf. It's
the most appropriate
understandable.
Device, for sure.
The upper part is not pre-dilated.
Okay. Of course, the best thing is a PTFE cover stent, and the best dedicated stent that we know is a Gore stent.
Okay.
Yeah, but unfortunately, we don't have it. With the stenting, it's very important to stent the whole tract and to stent up to the confluence of the hepatic vein with the vena cava. So we need a long stent in order to be able to cover the whole hepatic vein. So we are going to choose 12 by 80, and then we're going to post-dilate it to a 9. So we will have a hourglass shape, and then we're going to measure a gradient, and if the gradient is fine, we're going to finish. Can we have the stent now?
So you use Protégé stent, 10 millimeter diameter, and what
12.
length?
12.
12. Ah, 12. Okay.
Length of 8 centimeters.
8. Okay.
8.
So we are trying to cover something 1 centimeter inside the portal vein and up to the ostium of the right hepatic.
Okay.
Because if you don't cover right hepatic vein, you very frequently have a stenosis on the follow-up.
What are the usual places for this restenosis? Just on the connection only, or there are some typical places for the restenosis appearance?
There are two predilections. One is inside the tract, when you have a entry in the portal vein, because you have a lot of fibrosis there. You can have a mechanical problem. And the other predilection for restenosis is inside the vein. And I forgot to tell you that we exchange over the ampla superstiff. So we're having ampla superstiff now inside the portal vein. And we are preparing the Protégé now.
What is the anticoagulation during the procedure?
If we are quick, we don't anticoagulate at all. but in situation like this, when we have live transmission, we shall be waiting, we put something like 3,000 heparin, 3,000 units of heparin inside. But
So-
most of these guys have bleeding and a lot of varices, so you don't want to have them heavily anticoagulated.
Exactly,
Because,
because those patients usually have some bleeding disorders, and
Yes.
this
Yes.
is why I'm asking. Just is it necessary to add some anticoagulation?
Now we are introducing the stent. And we're going to check the upper portion of the stent. We want to be very precise with the upper portion.
Vasco, this is a 10 French sheet, yes, if I remember
This is
well.
a 10 French cook sheet, yes.
So you have enough space.
I think that's something like this. It's going to foreshorten a bit after we try. Yeah, I think that's it.
Yes.
So that's the final positions. We will open it now. Thank you, please. Okay, you can appreciate that we're having the tract inside the liver parenchyma.
Okay, out.
Out, yeah, went out. And we now obligatory post dilation. We need to post dilate and to a pause. We are not going to 12 because it's too much. We're going back with the same balloon, and then we're going to measure the gradient again. And if our gradient is below 12, it's a good endpoint. But we'll show you now. We'll redilate, and then we put a pigtail, we measure pressure, and we put some contrast to see how it goes.
So the target which you pursue is a hemodynamic endpoint.
Yes, if the gradient is too low, it's beyond 4, it's a good chance for encephalopathy. So that means that you are bypassing the whole liver.
Okay.
If it's above 12, it's a good chance of rebleeding. And our patient is relatively consumed. Indication is, okay, the indication is ascites, so we don't want to have too low a gradient. We will be very happy if we have it around 10.
So this is the same balloon, 9 millimeter diameter.
Yeah, same balloon, 9 millimeters. We will have some post expansion of the stent after we finish. So we don't want to go up, but it depends on the final gradient. Go back.
8 atmospheres.
So I see that you don't take too much time for inflation. I mean,
No. But we do it several times. So we don't do a prolonged inflation, but we inflate a few times, like 3 to 4 times.
okay.
We're going up and back on the track just to be,
Is it,
sure.
is it necessary for the patient to take some antiplatelet therapy afterwards?
Now we have new data showing that actually it's beneficial if the patient is on no ARCs, no antiplatelets, but just Xarelto or something. We have better longevity, but that's something we don't apply very. Up to now, we never applied any anticoagulation after.
I mean antiplatelet, not anticoagulation.
Antiplatelet has the same risk for bleeding as anticoagulation. If you have a variceal bleeding, and the mortality is something like 25%. So don't really want to expose your patient to aspirin. Back. And now we're going to introduce a pigtail and measure some pressures for you.
Out.
At least on angio, it looks quite well. The stent is very well open now, even on
Yeah.
this kinking.
typically we have this kinking. Sometimes if you're very central, you're happy and you don't have it, but most of the time you have this kinking. Actually, it's not a big problem as long as the gradient is okay.
This diagnostic 5 French catheter?
It's
Or?
diagnostic 5 French pigtail,
Okay.
and we are going to measure the pressure in the portal vein. Once again, remember it was used to be 37. Now we're going to 0.
Can we see the screen with the pressures
Uh,
to see
can
the?
you
Is
control
it
the
possible?
standard pressure?
Is it possible to for the technician
Yeah, you can
to?
turn the camera on the screen.
На най-десния монитор, горе с червената
Милет,
линия.
може ли да въртиш само малко монитора? Да.
It will be interesting for the audience for sure, just to see the gradient and how it looks like, because actually this is what we are pursuing at the moment. Okay, so this
We have
is
a
the
pressure of 24, and now we're going to measure the pressure inside the hepatic vein, and we can tell the gradient just by simple extraction. Shit.
so you flush.
Yes, that's it's not a right atrium, it's hepatic vein. It's a little bit higher than the right atrium because we have an ascites in the intra-abdominal
Yes.
pressure is higher.
Can we see the pressure? Sorry, because we are now we are looking on you.
Okay, can you turn the pressure?
You're very beautiful, but maybe the pressures will be more interesting.
Милен.
Can you switch the screen to the camera?
Yes, yes, just a second.
Oh, great.
So now we have this situation, we have a very low gradient, it's something like 4 or 5 millimeters of mercury, and we don't going to populate any further because it's even lower than we want it to be.
It's
So
around
we're
20,
going to
20.
rely on,
The mean pressure is around 22,
yes,
just at the
Pressure.
middle of the A wave.
and I'm going back to the portal.
In those cases, if you don't have automatic measure of the mean pressure, you can use the mean pressure of the A wave. You take
So,
the
yeah,
amplitude
the
of the A
gradient is
wave,
quite
and the
low.
middle of the A wave is the mean pressure.
About 5.
You can, yeah, probably we can have it on the screen, but
It's around 24, 25.
25. And now we're going to give you some contrast.
25,
Apnea?
24,
Do you want
it's
to
quite good.
Just
There is no gradient at the moment, practically.
practically gradient is very low, something like 2 millimeters.
Yes, exactly.
So that is the charm of the bear stent, that will for sure have some hyperplasia, and the gradient is going to be a little
Can you
bit up
switch
after
on the angio? Sorry, Vasco,
Yeah.
can you switch on the angio?
Guy, can you switch on the angio?
Okay, great.
So we're now going to embark on the heavy therapy to protect from encephalopathy. So we need to have regular stools, and there is a specific treatment called HEPAMERZ. It's amino acid
Acid.
Hmm?
Acid.
acid, yes. which is
Excellent.
HEPA.
Very good. Congratulations.
Congratulations.
But that's it. So we finished the procedure just by taking everything out, nothing special. So that was from us.
That was a perfect demonstration how to do tips, really. Congratulations, guys.
Okay, thank you.
Do you have something more live? Or,
No, we have next live case in the afternoon.
okay. So thank you so much. And now is Dr. Bochvarov.
Yes.
Okay. I have only comment. In our practice, we don't do tips every day, but we navigating the needle under ultrasound control. It's really easy because we do also a lot of non-vascular interventions of the liver, and it's very easy to find the portal vein. The wall of the portal vein is too thick. There is fibrosis vascularis, and when it's need more force to apply to puncture the vein. So back in the lung, we continue the embolization of the bronchial arteries. This is life-threatening condition. There is no strict definition when we do perform embolization. In some articles, it's written more than 240 milliliters for 24 hours. In other, 500 or 600 or liter. It depends from the condition of the patient, of course. And is this patient hemodynamic stable or not, hemodynamically stable or not. Also, we have cases of pseudohemoptysis. We have to differentiate these conditions. The causes for hemoptysis is too long, but often we have patients with neoplasms, of course, and after inflammation with bronchiectasis. These are usually the groups with patients with bleeding. When we do embolization, we need to know the anatomy of the bronchial arteries. They typically arising from the descending thoracic aorta at the level of the carina. This is very easy to find this marker when we are working, but also we have a lot of abnormalities, and we, in some cases, it's necessary to put contrast into the subclavian arteries, descending aorta, and so on. Non-invasive imaging is really important, and nowadays we have excellent option, multi-slice CT, with the possibility to create multiple now reconstructions to realize the origin of the vessels. Not in any case is possible, but it's important because when we do embolization, not in any case patient can stay in prone position for a long time because it's coughing. It needs expectorate blood during the procedure. There are a lot of movements, so for 2 minutes I think it's more than enough to perform CT angio to see what's happened with also contrast. Amount of contrast is important. Excellent example for 3D reconstruction of the bronchial artery with side of this pointer. On the right picture, you can see the dark areas with bleeding. Branching pattern we assess using the Caldwell classification. It's important to be sure that you are not in costal artery, intercostal artery, and to be in some branch of the bronchial artery. And sorry. Here we can see the different examples, and always we try to see some pathological network, some area with more contrast. Don't forget, these are breathing patients, and there are a lot of artifacts using digital subtraction, so it's not in any case easy to be sure that this is the right place. Of course, this patient underwent before our procedure bronchoscopy, we do CT, so usually we're able to find the area from which we're expecting to see blood. Of course, this is minimally invasive procedure. Clinical success is high. Recurrence of hemorrhage is low. This is really important. And if we compare the endovascular treatment with surgery, we can see the real advantage of this procedure.
In our institution, we do for embolization of the bronchial arteries only femoral approach. We're talking that in some cases, maybe when we see the origin of the bronchial arteries, that maybe transradial, transbronchial axillary access could be better. But in this situation, there is a risk for instability of the catheter, and we are push the catheter to go into the descending aorta, to the abdominal aorta. So usually we do femoral access. We're looking for stability of the system. This is key moment. Usually 4 and 5 French catheters, vertebral catheters, Simon catheter with different curves. In patients, other patients, when the aorta is relatively large, then it's not easy to achieve this stability, to enter deeply into the origin of the bronchial arteries. And with RED, this is really important to assess the neurological status of the patient before embolization. Yes, we can do also coaxial technique, but it's important to avoid migration of the particles into the radicular branches, and to avoid ischemic events of the spinal cord. This is really a big problem. Because of this reason, usually the size of the particles is between 200 to 250, but I will show you a case where we use 700 micrometers particles. Also, you can use gel foam or anything. It's important to control, to stop the bleeding. Very small particles, they should always be avoided because there is a risk of spinal cord infarction. Example for different size of particles. Indication, of course, to control the bleed, to stabilize patient, to avoid some hemodynamical shock. Spinal cord ischemia, this is the biggest problem. Fortunately, in our practice, we don't have case with spinal cord ischemia. Don't forget post-embolization syndrome. This is pain, retrosternal back pain, and fever, dysphagia, and so. Migrated particles can cause esophageal ulceration. Of course, you can see bronchial infarction, but this is less problem. Why I'm showing this picture? Left down is our old unit. In the middle, our unit now from 2019. We have new room, and on the right down is mobile system. It's necessary to have a mobile system, and now only 2 cases. This one is 8-year-old girl without any history for previous disease, and with hemoptysis therapy at home, but she was admitted in our hospital with huge hemorrhage, expectoration. Hemoptysis was intubated. You can see shadowing at the right lower lobe, and we perform embolization. You can see at the periphery of this angio the site of bleeding, and after on the right you can see the effect after embolization, 700 micrometers particle. Final result, the child was discharged from hospital without any complications. Excellent example to convince you that this is good option. But this is a young man, 18-year-old, also with severe hemoptysis was intubated, and because this patient was not stable, we check all the angiographic mobile system, and we organized angiosuite into our intensive care unit, reorganized everything, removed the other beds, and we performed embolization next to the bed of the patient. We take the patient and only put it over our table. Here you can see the embolization, and that was final result. We were so happy that we can see that, but unfortunately this patient was with very rare type of T-cell lymphoma, and he died. This is important option, endovascular embolization for unstable hemodynamically patients, and this is good option, well tolerated. It can be performed in such situations. Thank you for your attention.
Well, that was spectacular. Thank you for presentation. So, questions, comments? What is the most frequent reason for hemoptysis? I mean, it is from bronchial arteries, but this is usually not the primary
Yes,
reason.
usually these are patients with bronchiectasis.
I see.
Not, and tumor patients also. These are two groups. And there was, I think we have a time situation that I saw my wife has bronchiectasis. I have Nissan Patrol, good machine for off-road trips, and I was in the middle of the forest, in the middle of the mountain, about 60 kilometers away from Varna, when she started to bleed to hemoptysis. And I was worried. I didn't know what to do, to travel to Burgas or travel to Varna. I decided to go to Varna, to hospital. It's awful to see some person who filled a bottle of liter and a half with body materials. It's awful, but this bleeding was controlled with conservative treatment, and she stopped. And now when she coughing, I ask her, do you have some blood? It's unexpected situation. Yes, you have, but many of us has some parts with bronchiectasis, and it's a very important session talking about pulmonary hypertension, because these patients are in critical condition because of the pulmonary hypertension, and if they have also bleeding, then the situation is really difficult to be controlled. Yeah.
So, actually, the pulmonary hypertension is an additional risk factor for bleeding in...
I think no. It's difficult to work with these patients on the table.
I see.
This is the big problem. Because it's easy when we talk, we will push a catheter, we will push some particles, but navigate in patient who is moving, who needs intubation, not in any case in our practice is intubated. It's not easy to find a kit for intubation. You know, in our intensive care units, there are not so many anesthesiologists, so it's difficult to organize all the process or steps.
I see. Okay, so Zoran?
Okay.
Yeah.
The time is for coffee.
Coffee.
and
Okay,
20
maybe,
minutes.
okay, some coffee break, and after 15 or 20?
20.
20 minutes.
So we can
After 20 minutes, we'll come back.
For
Just
the next representation.
Yes, time for refreshment.
Second part.
Second part of our session. So now, Professor Nikolov, I would like to ask him to give his talk about the endovascular treatment of deep vein thrombosis.
Okay, good morning, dear colleagues. It's my pleasure to present our initial experience of endovascular treatment of DVT with pharmacomechanical thrombolysis. We all know that the goals of the low extremity DVT treatment is to reduce the severity and duration of the DVT symptoms, prevent pulmonary embolism, minimize the risk of recurrent venous thrombosis, and prevent the post-thrombotic syndrome. And the main treatment modality is anticoagulation in these patients. Anyway, only anticoagulation is insufficient to reduce the severity and duration of the DVT symptoms. This many times needs time, and also to prevent the post-thrombotic syndrome. Why anticoagulation is insufficient? It is because anticoagulants by default block the new thrombus formation, but restoration of the venous flow is a result of inner pathways of fibrinolysis, which is a very slow process, and many times it is incomplete with anticoagulants only. This results usually in residual venous obstruction, like is shown on the picture. This is the pathologic findings months and years after DVT, and many times venous valvular injury and reflux. So, because of that, the early thrombus removal strategy is well known, and it is thought that rapid restoration of venous outflow can be decreased with decrease the valvular damage and post-thrombotic syndrome if the thrombus is removed early in the DVT. It can be achieved with surgical thrombectomy and or with endovascular techniques, including catheter-directed thrombolysis, pharmacomechanical thrombolysis, or entirely mechanical thrombectomy devices. If we look at the guidelines, well, we know that it is recommended in iliofemoral DVT this strategy to be used, the early thrombus removal strategy, and should be considered, and this is level A evidence. And in opposite, when the DVT is limited below the inguinal ligament, it is not recommended. This is based on several randomized controlled trials, including CAVENT, ATTRACT, and CAVA. All of them show benefits for the patients, usually after 1 or 2 years, in reduction of post-thrombotic syndrome, and it is more prominent with the time in all of the trials. But the problem is that there is increased bleeding in all these cohorts. In one meta-analysis, including all of the RCTs, showed that PTS risk is reduced, and it's even more prominent if we set the outcome as moderate and severe post-thrombotic syndrome. Then the benefit is even bigger, especially for the iliofemoral DVT. But again, the bleeding risk is higher in the population of actively treated catheter-based techniques compared to anticoagulation. So how can we reduce the bleeding risk? It's clear that it is a result of the use of thrombolytics, so maybe entirely surgical thrombectomy can do this job. This is one of our last cases of surgically performed thrombectomy in a 28-year female with left side iliofemoral DVT. She gave birth 2 weeks earlier by cesarean section, so she was relatively not good candidate for thrombolysis. So it's clear that there is a May-Turner syndrome here. We performed open thrombectomy from the groin. You can see it was not very easy to pass the May-Turner point, but with wires and over-the-wire thrombectomy with Fogarty catheter. This was the underlying disease. It's clear that we need a stent here, but before that we had to supply good inflow from the femoral vein. This thrombectomy is sometimes very difficult against the valves, so we used different technique. We punctured the posterior tibial vein, pass a wire up, and after that over the wire perform again Fogarty thrombectomy with this pleasant result for the popliteal vein, femoral vein. After that we put a stent in the common iliac vein, and this is the good final result. So the other way to reduce the bleeding is to use percutaneous mechanical thrombectomy or pharmacomechanical thrombolysis. From April this year we started using angiojet for DVT treatment. Angiojet can work in two modes: thrombectomy mode, in which high-speed saline jets can distract the thrombus, and also it creates a vacuum effect which aspirates the thrombus. The other mode is power pulse, in which thrombolytic can be forcibly injected into the thrombus. We use angiojet Zelante DVT catheter, which is relatively new, with a bigger hole for aspiration of big amount of thrombi. So it is 8 French system. This is our first case, a 60-year-old female, 2 days of symptomatic left iliofemoral DVT. This lady had undergone ligation and stripping 25 days earlier with massive edema. We tried conservative treatment initially, but it was with no improvement for 2 days, and decided to go on with pharmacomechanical thrombectomy. It was not a good candidate for open thrombectomy because of the relatively fresh scar, about 1 month of age. So in prone position we punctured under ultrasound control the popliteal vein and performed phlebography. You can see the stop, total stop at the level of common femoral vein, and this is after passing of the occlusion. We switch to 9 French introducer and perform local power pulse injection of Actilise wait for 30 minutes, and after that perform 4 passes in thrombectomy mode. The result was not very good for the common femoral vein. We repeat selectively here, and this was after additional 4 passes at this level. After that we found that in fact there is not occlusive thrombus at the level of the whole femoral vein remaining. So additional 2 passes. In this first case, we in fact do a long procedure. Some hemoglobinuria started, and we decided to stop and to put catheter-directed thrombolysis for additional 16 hours, and this is the result on the next morning, which is satisfactory, I think. At that time we did not have IVUS, so just on phlebographic images we decided to stop. This is the Doppler sonography on the next morning. The patient was left on rivaroxaban for 6 months and second-class compression stockings, and she is doing very well for 4 months till now. The second case is a 61-year-old male with right leg phlegmasia, very huge edema. This patient has almost 3-week duration of symptoms. When he was admitted in ICU for treatment of urinary sepsis, the rivaroxaban was discontinued. He was stented 3 months earlier. Venous stenting of the common femoral external iliac vein because of a huge compression secondary to hip joint prosthesis. You can see this is the initial treatment we have done several months earlier, and in fact the patient presented with this stent thrombosis. This is wall stent in the common to external iliac vein. So on the CT you can see the iliofemoral DVT, including the stent thrombosis on the left side, huge edema of the leg. Again, in prone position, popliteal access, total occlusion of the popliteal femoral vein, and after several passes with angiojet in thrombectomy mode, we achieved some flow. Again, we left the patient with catheter-directed thrombolysis for 24 hours, and it was clear now that there is a stenosis of the external iliac vein over the previously implanted stent. It was confirmed by IVUS. It's about 70% stenosis at that level. So we came back and implanted one more stent at this region. This is the final result. There was a very rapid improvement of the symptoms, and the patient was discharged 2 days later. I will mention one contemporary trial. This is the clear DVT trial, which uses, like in our series, PMT, 8 French Zéland angiojet catheter with standard dose of thrombolytic, small dose, only in acute iliofemoral DVTs up to 14 days of symptoms. And IVUS is obligatory in this study, and venous stenting is performed if patient has over 50% residual stenosis. For 1 year in these 35 patients there is no post-thrombotic syndrome and only 4% of mild PTS. Nowadays there are many other modalities which can be used for rapid extraction of thrombosis in DVT. Many of them are in trials, and the time will show which one is the best. In conclusion, early thrombus removal strategy is effective in reducing post-thrombotic syndrome. Bleeding risk can be minimized with reduction of the thrombolytic doses. Patient selection is crucial for good outcome. Only iliofemoral DVTs are nowadays indicated with severe symptoms and low bleeding risk. New devices have the potential to overcome most of the limitation of the catheter-directed thrombolysis. Thank you for your attention.
Thank you. Thank you very much for a very interesting presentation and very informative. In fact, I want to ask you, in most of the trials there is a combination therapy between thrombus extraction and fibrinolysis, like in your practice. Do you think there is a potential of reducing the dose of systemic thrombolytic in order to reduce the bleeding risk in these patients? And second question, also more practical, in case of residual thrombus, residual stenosis, sometimes external compression, what is the role of dedicated venous stents?
Well, it's clear that in any way, if we can reduce the thrombolysis, it will reduce the bleeding risk. So this is the main direction in which the industry is working, and the development is expected in the field.
What is your reduction? What is your practice? How much you reduce the systemic dose of thrombolysis?
We have up to now 4 patients, and in all of them we used additional thrombolysis, and the whole amount is up to 50 milligrams.
So more or less half dose.
Yes, including the intra-procedure about 15 to 20 milligrams TPA, and depending on the result, for not more than 24 hours additional thrombolysis by catheter with McNamara. Yes.
Excellent.
And yes, of course, dedicated stents are the way to go. It is clear from recent studies that the results are much better if the underlying disease, many times by compression or by chronic stenosis of the veins, can achieve better patency and better outcome with the post-thrombotic syndrome in the future.
And what about post-stenting regime, antithrombotic regime? Anticoagulation or antiplatelets? Or combination?
Our strategy is anticoagulation with 2 to 3 months anti-aggregation combined, if stent is implanted.
Excellent. Questions, comments? Okay, thank you. Thank you very much. Okay, we are going next. We will start with an interesting symposium, definitely very, very important for us. Dr. Silvio Leal is starting. This is the Penumbra Satellite Symposium. Tips and tricks in treating pulmonary embolism with penumbra.
Well, good morning, dear colleagues. My name is Silvio Leal. I'm interventional cardiologist at Lisbon, Portugal. And it's for me a real pleasure to be here in your excellent meeting, showing a bit of our practice in acute PE treatment. My talks stay a lot more simple after these morning sessions, where many of these topics were already discussed. But I will resume it. Well, as you know, venous thromboembolism is the third most common cardiovascular cause of death after stroke and MI. And its incidence keeps increasing in parallel with the aging of the population. Despite all the advances in diagnosis and in therapeutics, the in-hospital mortality still is very high, in 6 to 10% in most series, being very concentrated in the most severe subsets of patients, the high-risk patients and intermediate high-risk patients according to the ESC guideline classification. Well, in trying to overcome, to decrease some of these mortality numbers, several devices have been developed in the last year, several percutaneous devices. But they can be reduced to 2 main mechanisms: the thrombolysis, the intrapulmonary local administration of a thrombolytic agent, or the thrombus extraction by fragmentation, or more properly by aspiration. Well, when you look to the evidence, we can reduce the nowadays devices to three: the ECHOS device from Boston, the float river device from Inari, and the Penumbra Indigo device. Well, even before some of these studies have been published, our ESC 2019 guidelines already recommended CDC treatment for acute PE in the most severe subset of patients. In fact, in high-risk patients, it is recommended since 2019 in patients with contraindications to thrombolysis or in patients with failure of systemic thrombolysis. And in intermediate-risk patients, as an alternative to systemic thrombolysis in patients with signs of hemodynamic deterioration while on anticoagulation. Last year, a consensus document between DSC and the APCI was published, and he has gone a bit further than the guidelines. Concerning the high-risk patients, things are not so different. So patients with contraindication to fibrinolysis, and remember that high-risk patients are not only shock patients, but also patients with systemic persistent hypotension. But in intermediate high-risk group of patients, now we also recommend the use of CDT in patients with lack of improvement. Before there were only the patients with hemodynamic deterioration. Now we have the patients that just don't improve on anticoagulation, and this is an important difference. Well, this consensus also brings us this diagram. It's important diagram that resumes many of the that must resume many of our practice, but I would underline 2 points: the need for PERT team management support. So PERT teams are multidisciplinary teams, pulmonary embolism response teams. You can call it that way or any other way, but the most important thing is to have a team that is capable of discussing the patient in a fast mode, to give CDT treatment as early as possible after the decision. Because treating an acute PE is not a technical issue, it's most of all an organizational challenge. That's the difficult part when we want to start a PE program. Well, let me present you a simple case. It's not a fantastic case. Instead of that, I bring you a regular case. It was our last case last week. It's a 44-year-old female in oral contraception, presented with a 24-hour dyspnea of acute onset and a pre-syncope. At clinical examination, he had hypoxemia, normal blood pressure, but very tachycardic, 130 beats per minute. And at lab tests, he had increased troponin and BNP with almost normal lactates. She performed an angio-CT scan that demonstrated bilateral proximal thrombus and an enlarged right ventricle. And following that, a transthoracic echocardiogram that confirmed the severity of the PE by showing a dilated RV with reduced ejection fraction and LV D shape with the systolic pulmonary artery pressure around 40. Well, like we always do in these intermediate high-risk cases, we wait. We usually wait for 24 hours in the cases where hemodynamic deterioration is not occurring. That was the case. The patient didn't deteriorate, but simply didn't improve. 24 hours later, her echo was absolutely the same. And so our PERT team decided to advance with percutaneous thrombectomy using a Penumbra Lightning 12 French system. These are the diagnostic angiograms. We have thrombus in both sides, both in main right and main left pulmonary arteries. Hemodynamics were invasive monitoring were a systolic pressure of 42, very similar to the echo, mean pressure of 23. We advanced it with the procedure, first at the right and then at the left with this 12 French system. For those who can be not so familiarized with this system, it has a vacuum pump that is continuously aspirating blood and thrombus. I will show you in a few minutes. And the final result, we have some improvement of angiography, not a normalization. We never have a normalization. We want an improvement in both pulmonary arteries and a slight decrease in pressures for 37 systolic and 18 mean pulmonary artery pressure. Most important, we remove significant amount of thrombus, and the patient only with 200 cc's of blood loss, and 24 hours later the patient was stable. Her echo was absolutely normal, and 2 days later she went home. So let me talk a bit about this Lightning 12 French system. Well, it has some particularities that make it a bit unique. It has this 12 French catheter that was a very good evolution from the previous 8 French, not only in its caliber but also in its torqueability. Then we have the separator. Let me point to this. We have this separator. It's this small olive that will remove the thrombus in the tip of the catheter. Then we have a continuous aspiration pump. This is called penumbra engine, and this is different from the other devices. But most important, he has this device that makes what penumbra says intelligent aspiration. I'll show you in a video. It's not more than a microprocessor that is connected to the aspirated tubing, and this microprocessor has the ability to detect changes in flow in the catheter and in the tubing. And through visual signs and through sounds, we know when we are aspirating free blood or when we are aspirating thrombus. And it also will automatically control this valve to close it when we are aspirating free blood, leading to a very lower blood loss. Well, in fact, I would say it's rare to aspirate this kind of amount of thrombus, but probably it's not needed, because if we look to the studies around penumbra, and I remember that extract PE is a study with the 8 French system, not with the 12 French, and with the 8 French system, that was, I must say, limited in the amount of thrombus it could aspirate, but it already showed a significant 27% reduction in RV-LV ratio with a very low rate of complication, 1.7%. When we compare this data with the other 2 trials from the other 2 systems, principal systems in the market, we see at least similar results, maybe a bit better results in efficacy and also in safety. And once more, this is the old system. What about the 12 French system? We don't have already published data, but the Strike PE is ongoing. Strike PE, it's a non-randomized trial that is evaluating not only RV-LV ratio and complication, but also clinical endpoints, mortality, readmission, and also quality of life and functional parameters. And this is new in Strike PE. Their goal is to reach 600 patients. Right now, I think we are about 280, so half. Probably by the end of next year, we'll have the study completed. But we have already these interim results from the first 87 patients were released some days ago, and we can see a clear and significant reduction in RV-LV ratio, also in pulmonary artery pressure with the device, with a low rate of adverse events, 2.3%. And in functional analysis, we have a great decrease of dyspnea score, a great increase in 6-minute walk test distance, and a great improvement in quality of life parameters. Now, Penumbra is about to launch the Storm PE. The Storm PE is completely different. It's a RCT. It's the first randomized trial with Penumbra devices. It will use the new 16 French flash system that is not, we don't have it in Europe yet. It's being already used in the USA. But it will compare with the 16 French. It will randomize patients to thrombectomy or only anticoagulation in intermediate risk patients, in search not only for RV-LV ratio differences, but also for clinical endpoints and functional and quality of life parameters. I think that it will be a very, very important study. Probably in 1.5 years, 2 years, we'll have the results. Well, let me just share a bit of our experience. I'm running, in fact, two programs of acute PE in 2 near hospitals in Lisbon. We started 4 years ago, and we are receiving patients from a big part of our country. It's not a big country, but it's a big part of it. 334 patients were already discussed, not performed, discussed, okay, from 22 different hospitals. And we can manage that because we assembled a large PERT team. The PERT team is a very important step to start any program because it allows us to discuss in, we use a WhatsApp forum. It's a very easy way to discuss a patient at any time of the day or the night and to reach a decision. According to following our indication that are in fact the same of the SC guidelines, we already treated 85 patients from those 332, most of them intermediate high risk, almost 80%. And as you can see, we have a lot of different techniques. 2/3 of the cases perform thrombectomy or isolated or in combination with intrapulmonary thrombolysis, 90% only intrapulmonary thrombolysis. About the devices, happily we have access to all the 3 devices, but our biggest experience is with Penumbra devices, most of all with the 8 French, because the 12 French is only in the market about 1 year. And these are our results. So we reached a success rate above 19% at 48 hours with a number of adverse events around 9%. At 90 days, the results are also good, I would say. Systolic pressure has decreased in almost all patients. More than 90% have a normalized echo, and more than 90% also are in New York Heart Association Class 1. So I would conclude by saying that intermediate and high risk PE still carry a great morbidity and mortality, and so it's mandatory to develop PE programs and to start using this kind of devices. Use the device where you feel more comfortable, okay, but get experience with that. About Penumbra Lightning. Well, it's a good device. It is simple to use. It has already proved efficacy and safety, and we are expecting, of course, more data to see how will it place in the future. Thank you.
Thank you very much. Any question? Okay, we go now with the last presentation. Dr. Stoyanov, please.
Hello everyone. It's a pleasure for me to be in front of you. I'll wait for my slides. My topic is going to be about the balloon angioplasty for the patient with chronic thrombectomy. I'm influenced already from the previous talk. It was incredible talk. For the chronic patients with chronic thromboembolic pulmonary hypertension. Yeah, I'm really influenced. And after the incredible overview of Professor Velchev this morning, my job is almost done, and I'll try to give some technical aspects about the procedure. And yeah, I want to say that the CTEP, this is chronic thromboembolic pulmonary hypertension. Thank you. It's a really complex disease. It's really underdiagnosed, and really we don't know the real number of the patients with CTEP. And we have in this condition, we have patients with really high pulmonary arterial pressure, with high pulmonary vascular resistance, and this caused to really progressive right heart failure and decompensation and death. The prognosis for these patients is really poor if they are not treated. As you can see on the slide, you can see that the 5-year survival rate in the patient with mean pulmonary artery pressure of more than 40 is less than 30%. If we have a higher mean pressure, it's less than 10%. This is incredible high rate, mortality rate. As Professor Velchev said this morning, we have a curative treatment. It's a surgical treatment, pulmonary endarterectomy, and they have incredible good results. But I want to underline this, that this tool is working in really experienced centers, in really experienced hands. And they published that they have only 2.2% in hospital mortality rate, but this for really experienced surgeons. And something that should be underlined also is that only 63% of the patients with CTEP are eligible for this surgical procedure. And then another interesting thing is that we have a data that the patient experienced operation, between 17 and 30%, they have a recurrent of pulmonary hypertension after the surgical operation. And here is our place. This is really interesting and method of choice for a patient that they're inoperable. We have a lot of patients with comorbidities and also with really high pulmonary vascular resistance, and they cannot be operated because the risk is incredibly high. And this is matter of choice, of course, for the patients with the post-surgical patient with recurrent pulmonary hypertension. And in Japan, also in our country, we have a lot of patients that declined open surgical procedure. And we have a lot of data that BPA, balloon pulmonary angioplasty, it's method of choice, and we can we have a improvement of hemodynamics and also of cardiac function of our patient with really good long-term results. On this slide, you can see the different types. These angiograms of our patient from our institution, and we can separate the lesions to 4 different types. On the left side is the classical band or ring type lesion, and also we have webs, subtotal occlusions, and total occlusions. How to select the lesions to treat? It's really highly recommended to, when you start your BPA program, to start with simple lesions, webs and bands, and to avoid treatment of subtotal or chronic total occlusion, because the complication rate is really high and the success rate is much lower. We have some data that it's better to start with right lung, because the manipulation of the catheter is easier, and to perform BPA in the lower lobes because we have a larger blood flow in these regions. And what about the equipment? It's really simple. We have it in all of our cath labs. We need only 6 or 7 French long sheets, also guiding catheters with different shapes, but regular catheters, multi-purpose Judkins-Wright catheter, or Amplatz left 1 or 2, workhorse wire, and regular PCI balloon catheter. I'll show you one of our cases. We are starting usually with puncture of the femoral vein. We have a few cases through the jugular vein, but our way of working is through the femoral vein, because we are really familiar with this approach. We are starting with small amount of contrast media injection through the pigtail catheter to navigate our procedure after that. Of course, we have CT angio before to have a plan how to treat and where to start. And we are doing this injection with diluted 50% to 50% with saline contrast media by hand. After that, it's required to have a selective injection through the guiding catheter, this multi-purpose guiding catheter, through the 6 French long sheet. And this is how we place the balloon catheter. The really important thing here is to ask the patient to take a deep breath and stop breathing, because it's straightening the pulmonary tree, and we have it's easier to treat the segment. After that, you can treat whole the artery and to proceed for the next branch. And you can proceed for all the branches that you decided in front. And this is the result in this segment. When to stop? This is really important to know when to stop in the interventional procedures, and it's recommended to have a cut off. It's a mistake. It's not 350. It's 250. We have a cut off of contrast media. It's diluted 50-50, but this is our way to decide when is the proper time to finish our procedure with the contrast media. Also the radiation exposure, but this is not so important in our practice. And what about the complications rate? Why this procedure is not so common in every cath lab? Because the physician that perform this and the institution for the BPA should have really the experience with pulmonary hypertension patient, management of this kind of patient, and the complications rate, it's quite important. The reperfusion pulmonary edema is the major and the fatal complication in the really early stage, and we should take care of this. And if we have the newly developed cough or hemoptysis or progressive hypoxemia, this is alarm signal, and we should know that we should stop or to check for at least for perforation or lung injury, because this is the most common complication during the procedure. What about the long-term results? We have nowadays excellent data from the Japanese colleagues and also from Europe, from France. And the 1 and 3 year survival rate in these treated patients is more than 95%, and this is really promising for us. And I want to finish with this, because the surgical operation is a matter of choice for the patient with accessible lesions, proximal lesions. For our patient, we can provide our endovascular procedure, and mainly these patients are inoperable or the patient that declined thoracotomy. And at the end, we have excellent data with the short-term and long-term results for our patients treated by BPA. Thank you.
Thank you.
I have a couple of questions. What is practically what is the indication in your cath lab for doing this procedure? I mean, patient had a pulmonary embolism, then there is some residual changes. There are some residual changes of pulmonary vasculature. Do you take into account the pulmonary pressure, because there are a couple of patients with a normal normal pulmonary artery pressure, but changes in pulmonary vasculature? So, is that the patients which are indicated for BPA, or only patients with the pulmonary hypertension?
You mentioned this patient that they're with normal pulmonary pressure and pulmonary changes.
Normal or upper normal
or
borderline.
Most of our patients they are referred to us with pulmonary hypertension. We are treating only really high stage pulmonary hypertension patients who third and fourth group, really EU patient. And in the past, we didn't have options to send a patient for PIA, and we treated this kind of patient. But nowadays, we have a surgeon, and we are a team, pulmonary hypertension, Sept team, and we discuss all the case by case, and decided the best treatment option for our patient. But we are treating only the patient with pulmonary hypertension.
Okay, what is the cutoff value of pulmonary pressure? Because pulmonary hypertension is a little bit tricky diagnosis.
It's tricky diagnosis, yeah. The definition is to have a mean pulmonary artery pressure more than 20 millimeters of mercury. And this is, in general, pulmonary hypertension.
Invasive pressure
for sure.
Mean more than 20.
For sure.
I just want to explicitly say that, because I see a lot of patients which sent for some procedures with based on echo. On echo, it is not possible to do a diagnosis pulmonary hypertension. This is why I'm this discussion just to be clear for the audience.
For the audience, the workflow for this kind of patients, we have a symptomatic patient with detected pulmonary hypertension by echo. After that, we have in 100% of the cases right heart catheterization. This is gold standard. After that, we are having CT. And we decided case by case how to treat this kind of patients.
So the pulmonary hypertension is diagnosed invasively, not based on echo. I think that because a lot of people nowadays are doing some interesting things just based on only on echo. This is not a proper way to do that. This is why I'm just yes, Ivo.
If you allow me, yeah, in fact, very interesting and very practical. Thank you for this presentation. It's very important for the endovascular community because it's not so frequent in intervention. So we have some details, and I would like to ask you two questions. First one, we saw and we see in the conference is BPA in relatively small vessels. Up to what diameter and up to what proximal segment are you going with BPA? This is the first question. And the second one, in generally it's indicated for chronic cases. Do you allow yourself also to do the procedure even in some subacute cases after fibrinolysis or thrombin fragmentation? And if you do you apply the procedure as additional intervention too in order to improve the result of the flow of the pulmonary vessels?
I'll start with the last question. We don't do it in acute settings or subacute settings. Our patients are clearly with chronic disease. And for the second question, we are treating the more distal lesion. We are starting with really small balloons. This is a Japanese way to do this kind of procedure. Really small balloons, distal vessels, not hold the segments. We are having 6, 7, 8 procedures per patient, depends on the pulmonary pressure and the symptoms. And for the really proximal disease, we don't have such a patients because it's a bit tricky. We know that there are some reports, case reports for treating from the Japanese colleagues, but we don't have such experience in our practice.
Do you have some cases which are pressure wire or IVUS guided?
Yeah, this is important question. The both techniques are really impressive, and if you use FFR wire, pressure wire, to guide your procedure, probably you're more precise, but it's really costly, and we don't do it in our daily practice. And for the IVUS, you can see the wall because we have a lot of changes in the wall of the artery. You can also guide your procedure with IVUS, but we don't do it.
Yes, because IVUS actually gives an information about the. Actually, are there some changes in the wall? Because, for example, for webs, it is very difficult and tricky to say is this a web or just insufficient injection of contrast by hand. To do procedure, I highly recommend the guideline which was published from the European Society of Cardiology. It was published maybe 2 months ago, something like that, where there are very detailed technical description of the procedure. So we can finish this session. Thank you so much. And now, Ivo?
We have the next session is MedTech. MedTech supported session. And I would like to ask Professor Traikov, Professor Velchev, and also Dr. Perchinska, Alex, MedTech Europe. Albrecht, please join me. Professor Staneva from the Bulgarian Association of Physicians, and I would like to ask the staff to give Professor Staneva, she has, and Dr. Perchinska. Okay, Professor Velchev. we are going to speak about is it active? During this session we are going to speak, yes, absolutely. We are going to speak about healthcare. I would say about modern healthcare. Cardiovascular disease is #1 cause of death in Bulgaria. Generally speaking, do you have already the presentation? In fact, we have a piece of news from yesterday. Not only that was the World Heart Day, but without nothing behind. In fact, yesterday the MedTech Europe was registering the Bulgarian chapter of MedTech. So it was quite an important event. So it's very important to mention what are the European and the Bulgarian facts. They are not in our favor. They are not in favor of the Bulgarian patient and the Bulgarian population. Unfortunately, the Bulgarian problem regarding cardiovascular disease is definitely huge. I mentioned this morning that myocardial infarction and stroke are the #1 cause of death in Bulgaria, with some peculiarity. On a European level, this is the myocardial infarction. In Bulgaria is the stroke. So ischemic stroke is the #1 cause of death and #1 by a population point of view disease in Bulgaria. So we have we have to do something. And it's extremely important to gather professional organizations and also the institutions to be together in order to help our population regarding improving the prognosis. And the trends in the markets are very important. Why? Because the aging population, we live longer. We physicians, we treat better the population, and because of that, the population live longer. Unfortunately, the aging population diseases are more complex than younger population, and because of that, the treatment of such kind of patients needs more technology, more devices, more digitalization. So all this is fruit of development, and we cannot stay apart. Bulgaria, we cannot stay apart. We have to be online with the trend on the world and European level. And both the European Commission and MedTech Europe, they have memorandums regarding the implementation, early adoption of the modern methods of treatment and modern technology that are already in the guidelines. I don't speak about trials and I don't speak about experiments. I speak about early adoption of methods of treatment that are already approved by the guidelines. Unfortunately, the history is showing that it takes at least 10 years for some interventions. For example, like for interventional treatment of stroke, it takes more than 10 years for the Bulgarian authorities and the Bulgarian institutions to implement this kind of modern treatment on our territory. And definitely there is a huge gap to be covered. It's my huge personal hope the institutions, the European institutions, to support us and to help us regarding the implementation of the National Society of Bulgarian Cardiologists to implement our plan. We, in fact, published our plan 1.5 years ago, and this is extremely very well elaborated plan that is in fact on basis of all the guidelines and all the consensus documents on European level. by historical point of view, more than 15 years ago, we, the Bulgarian cardiologists, we approved, in fact, to implement the European guidelines directly in Bulgaria. So we follow, absolutely by purpose, we follow the European rules and the European guidelines because they are based on the medical evidence base. And this is the truth. And we have, it's our honor to have Alex Albrecht, that is the cardiovascular chapter of MedTech Europe president. Thank you, Alex, for coming. Thank you for your support. And I would like also the MedTech Bulgaria guys, Alek Michev and also Ms. Yocheva, to participate in the discussion. And in case you take a look at the program, I put these topics in the agenda of this session. So what is the need? What is the, in fact, the pathway? What is the pathway to resolve all this problem? What is, in fact, the collaboration that we need on a European level and national, interdisciplinary, and interinstitutional level to improve the situation, and to improve the situation not only of the particular patient, but to improve the situation on a population base. Because you know the demographic crisis, the demographic catastrophe, I would say, is awful. So all we need to be together in order to succeed, in order to achieve the goals of the national cardiology program for a reduction of cardiovascular diseases. And after this introduction, I would like to ask Alex to share with us your experience on European level and what could be your help in this regard. Alex.
To start, first of all, yesterday was a quite important day. We had the World Heart Day, and because of that special day, we've published our manifesto on a European level. That is a collaboration of industry with basically 3 questions to the European policymakers. First of all, that is the creation of a European cardiovascular health plan. A second point is funding, sufficient funding for the cardiovascular health plan and the stimulation of innovative technologies that would help the detection of cardiovascular diseases. And thirdly is knowledge centers on cardiovascular healthcare in order to share experiences, cross-border knowledge sharing, and so on. So these are 3 things that we are asking to the European level, and we already see, because of previous engagement that we have done with European policymakers, already some success. So we see on the European Parliament side that reports are coming out on so-called non-communicable diseases. Within those, we see points like data centers, knowledge centers already implemented. We see regular health checks that would serve, as indicated by the professor, early detection. So we see that already developing. Another point is on the council side. We see developments there as well. So as perhaps some of you know, the council has a rotating presidency. And the presidency now is Spain. Next one will be Belgium and Hungary. And these 3, they come together in a so-called council presidency trio. And there we have seen first publications of cardiovascular health being a priority, and more specifically under the presidency of Hungary. Now, to answer the question specifically, is this something that we can do alone? Absolutely not. We have to have the European level, of course, to stimulate that, to make policymakers aware of the fact that not only in Bulgaria the numbers are against us when it comes to cardiovascular health, it is actually across Europe. So 1 out of 3 will eventually die of cardiovascular diseases in Europe. And about approximately 60 million people suffer from cardiovascular diseases in Europe as well. So this is something that we need to message towards European policymakers, because the awareness is not at the point where we would like it to have. And we do this on the European level, but this needs to be done on the country levels as well. So we see quite a lot of country initiatives already being put into place. So we see successful implementation in Germany, for example, the Netherlands, Belgium, and Spain. We see similar initiatives, and this helps as well. Local governments need to be aware of the problems the cardiovascular health is actually putting forward, especially given the burden that it has across a country on multiple levels, not only on a health level, but on socioeconomic level as well.
Thank you very much. As Dr. Obrecht mentioned, you have heard it's a top #1 priority on European level. So it's not only in Bulgaria. On European level, the cardiovascular health is definitely #1 priority. And I would like to ask Professor Trajkov to share with us how we reached, how we in fact elaborated our national plan. What are the goals? What do you think about the implementation on, I would say directly on the level of Ministry of Health? Because in fact, my opinion, this plan has to be part of the Ministry of Health strategy. Otherwise, our professional opinion will not result in any significant change.
First of all, thank you for the invitation. It's really great to be here and participate in this forum, because we are partners, and the Bulgarian Society of Cardiology is supporting all the events that are directed towards improving cardiovascular health. And congratulations for picking up the date, 29th and 30th of September, the World Heart Day. We all celebrate, is a hard thing to say, but we try to raise the awareness of cardiovascular disease. Certainly much has been said already by the previous speakers about the health plan and the way Europe is moving, and I think it's important to say that Europe is changing, and the way we do healthcare would change dramatically over the years, over the coming years. So it is very important that now Council of Europe and the presidential trio are very much prioritizing this issue with the cardiovascular health plan. And just let me give you some brief history of how it all started. A couple of years ago, European Society of Cardiology, which we are partnering with, Bulgarian Society of Cardiology is a partner to the European Society of Cardiology and a member, of course. European Society of Cardiology, along with other organizations, including MedTech Europe, have started an initiative called EACH, European Alliance for Cardiovascular Health. This initiative, this alliance, was created to design and issue a European cardiovascular health plan. So just some figures were already given by the previous speaker, but let me tell you a few more things. Each year, out of cardiovascular disease in Europe, we lose population close to the size of Vienna. So 1.8 million people die because of cardiovascular disease. It's a huge issue. So we need to, everybody realize that this should be a focus. And therefore, the European Society of Cardiology has created this plan along with EACH. And now, as I hear, ESC is trying to be an advisor to European and to European institutions and to the presidential trio regarding this plan. And the idea behind this whole initiative was to create the plan on the European level and then transfer it to all the countries who are member states. And they should implement, they should adapt the plan according to their local requirements and then implement it. For that, of course, as already said, we need support from the institutions, and that's the most important thing. So we have started this process. We have made the steps already in the previous term and in this term of the board of the society. And what we have up to that point is a couple of events trying to raise the awareness on the plan, asking and inviting institutions to join and discuss. And we are just at the point when we would like to establish a larger initiative, a larger thing than only involving us, not only us, but also other institutions, I mean, and organizations mainly, to create such a plan based on the European one. And then, so we are at that point, and this is probably going to be finalized next year. For that, we are in constant contact with institutions, and we are trying to urge them to pay more attention to this and turn this into priority. I'm very happy that European institutions are also focusing on that, which means that we have the chance to get this going here in this country. Because if the European institutions kind of support this, there's no way that the Bulgarian ministry would not respond. So we have already asked for a meeting at the ministry. I hope that this will be quite soon, so that we can sit down and discuss our idea. Up to that point, we have only a conceptual plan with some major points like prevention. This is something very, very important. Also, early access to treatment, as was already said. But what is more important is that we should stand together with the cardiology community, all the stakeholders involved in cardiology care in the country, also industry, business, if you like, those organizations who are the work providers, the Bulgarian Chamber of Physicians, Bulgarian Red Cross. So there are many, many organizations, some academia, if you like. There are many, many organizations involved in this process. So we'd like to involve them all in one piece, you know, and create the plan and then go for the institution. I think this is how it should go. And we very much like to invite all those stakeholders to participate. And also we are very happy that we have the support of industry on your behalf and in the face of MedTech Europe and also in the pharma. And not only, of course.
Excellent. Thank you very much for your comment. You already mentioned that we need, in fact, a real collaboration between different stakeholders, including not only professional organizations, but also societies and organizations of patients. Because, in fact, the final goal, the final target are the patients. And because of that, people like Mr. Taushanov and Durina are here. Thank you for joining us. Because in fact this is in interest of the patients. And in case you want to say something, please do that. I think we have a microphone. And also the collaboration between societies, not only cardiology but also vascular surgery, angiologists, cardiologists, cardiac surgeons, and also general practitioners. All physicians, we have to be on that, because this is really a huge mission. It's a national mission. And having said that, the national mission is also supported by the Bulgarian Association of Physicians. This is also very important. I will ask Professor Staneva to tell something about it.
Thank you for your invitation. It's a great pleasure for me to be here and speak about this very important problem, that cardiovascular diseases. Bulgarian Medical Association strong supported all on activities, Bulgarian cardiology societies and other cardiology society about national cardiovascular plan. We think that it's very important and all activity, it's that we, sorry, in November, one activity about our support, that November this year we will be a Bulgarian National Congress of Bulgarian Medical Association with foreign foreign guests, and we have a joint session with Bulgarian Cardiology Society about this plan and about prophylactic. And there will be Professor Pinto that supported through our that will be support our plan, and we think that it's very important to be make a lot of things that Bulgarian plan of cardiovascular disease will be more activities with different organizations, and one of them is Bulgarian Medical Association.
Thank you. Thank you very much. I think that endovascular intervention is, I would say, that one of the symbols of the development and up-to-date medicine and modern medicine. And in fact, without the last advances in the digital and technological in fact, inventions and all these innovations, we cannot do early, efficient treatment. This is part of the plan. So it's definitely prophylaxis, early diagnosis, early, efficient treatment, and of course, after that, rehabilitation. And I would like to ask Professor Velchev to speak about the early adoption. I would say not early, timely adoption of the present modern treatment in Bulgaria.
Okay, thank you, Ivo. Unfortunately, we are doing some political talks now, and there is no politicians in the room. So, what we cannot discuss without having the opposite side. And the question is that we need to gain the most from the little money we can spend on the medical devices. That means that we have to ensure that the proper device is going to the most sick patients. And it unfortunately can be overcome only through the instruments of financing different medical specialties and clinics. For example, quick access to medical technology, that means a center of excellence. That unfortunately we are struggling for this for years, but still we have absolutely equal financing to the whole level of the medical care. And most of the time, it is not that the insurance company don't want to reimburse the device in question. They just cannot assure that the device in question will be coming in the hands of the best trained physicians, and finally in the bodies of the patient that needs this most. Because we are not deciding on the demography crisis, we're going to get less and older, that's for sure. But we are just trying to prevent premature morbidity and to have older people able to work lately in their lives. So that's the sad situation. So I think that it's impossible to have this conversation without having the people from the insurance company, the ministry with us.
Yeah, in fact, we had in the early this day, I saw a representative from the National Health Insurance Fund, but I don't see her now. Nevertheless, it's our mission to translate all these, let's say, messages to them. I think it's quite a good sign that the Minister of Health was during the morning session about stroke intervention. And in fact, he expressed his support about this method of treatment, and he shared with me that they are willing definitely to collaborate with the professional organizations, and this is very, very important. In fact, these two institutions are very important, the Ministry of Health and the National Health Insurance Fund. And because the model of our healthcare is such that we are totally dependent on them. And I think, Alex, it's probably, I don't know, it's probably strange for you, but we have in fact, the conclusions from the past several years. They listen more the voices from abroad and from the European institutions compared to our voices. So, and definitely in this situation, your support is crucial. And it's very important not only for devices, it's very important for implementation of registries. It's very important about implementation the digital healthcare, remote and telemedicine. So all these methods of application of healthcare are very important on a national level. And because of that, we need definitely these voices to be loud and louder. And for those of you who are interested, in fact, I will present our Endovascular Society first registry that is already, in fact, prepared and ready for use. This is the registry for TAVI implantation. The next step will be, probably this is the plan, this is the idea, to be a registry for aortic interventions, and it will include not only endovascular but also surgical approach. And next step will be a carotid intervention. So our dream is from now, in not more than 1 year, we have to have covered these three vascular territories as on a national level registry. And what is your opinion, Alex, about the registries? What is the role of registries on national healthcares?
Well, you touched on three very important points in the in your discussion, and starting maybe with the national registries, and then I can go back to the digital healthcare and the importance of policymakers in this and local policymakers in this. The registries are a big step forward because of the reason that they start to aggregate data on all of this that can be used for scientific research and development, for new therapies, solutions, and so on. So that is already one important step. Is especially in this digitized world, we are producing data at an incredibly fast pace. It's incredibly fast. But doing nothing with it, then it purely remains data. We have to turn that into information. And doing so, we need to have strong infrastructure on IT levels that starts to aggregate this data. Then we can see the larger trends that's coming into play. And this taps into the digital healthcare, because if this is not being done, that's the first fundamental step. It's the brick of a house, if you will. It's the first brick that has to be put in, and then the infrastructure is the cement in order to build this beautiful house with a view on the seaside and so on. So everything that you would like it to have. And there's again a collaboration, but I'll talk about it a little bit after, is how the European instances and on the local level, how data sharing and data governance is being done in order then to go to the next step, and that is artificial intelligence and so on, and really have that digital healthcare, the future of healthcare, if you will, to go to that personalized medicine, to go to that medicine that is more cost effective, the one that is more personal as well, where you as a medical physician can again give more attention to the patients instead of a computer screen, and have that automation done well. But the last point I wanted to touch upon first is, as the colleague here next to me said, we don't have policymakers in the room. And it is not an exception. We see that quite often. And even in Europe, it's difficult to grasp that attention of the policymakers. We have very strong numbers with cardiovascular, unfortunately. A lot of people dying, as I mentioned already in the beginning, plus the fact that there are highly important inequalities when it comes to cardiovascular health. We see differences between men and women. We see differences between West, Central, and Eastern Europe. We see differences between social status and income, for example, when it comes to cardiovascular health. And I think these numbers we really need to push forward to policymakers. Now, to do that, we have to build a very strong message. And building a strong message is not something that we can do alone, being the physicians, being the industry, being the patients, you know. If we come together, and that is something that we do on a European level with the European Alliance of Cardiovascular Health, where I have the honor to be in the secretariat, there the main goal is to collaborate as much as possible and to have a united voice towards policymakers to say, listen, this is an actual problem. This is not a problem that is limited to physicians, not limited to patients, and not limited to industry. And if we have that united voice, policymakers are inclined to listen more to the important message that we have to bring. And if we start discussing that, we can come from the European level and we have it from the country level. And we can share experiences and best practices and so on. And I think it's very important as well. If we collaborate, then we can come together and then we can start working. There are huge examples as well from other pathologies that were very successful. And that will in turn lead to the financing that is needed to have that change in the patient pathway, if you will, and then we can start integrating the digital aspects and so on. But I really want to urge on the collaboration between all stakeholders, and I mean all of them, insurance bodies as well, depending on how the country is organized in terms of financing of healthcare. But that is the major point that is really important, and everything else will come later. And then we can do something for patients that will truly make a difference in terms of quality of life, in terms of longevity and so on.
Excellent. Thank you. Professor Trajkov.
Just to add to that, which was really brilliant, intro to what each does. I think and you even have called that we need a voice. On the European level, in the European Society of Cardiology, this is called advocacy, and this is what we need. And for the advocacy, and this is again something that you can help us with, that ESC can help us with, and it is working on this matter. But for the advocacy locally, I think patients are most important, and this is of course they should be involved in this whole bulk of institutions and organizations that are going to be involved in the alliance that we would like to create, just following the each initiative. However, it's important to note that we are now changing the perspective. We can treat effectively and safely many cardiovascular conditions. However, the whole thing is now overturned in terms that we're talking about cardiovascular health. And this is important to note. We are seeing the tip of the iceberg only. The rest part of the people who need prevention is huge, and I think this is also another focus that is in there. So I think this is how the advocacy can work. So we have to focus on positive sides, so the health, not the disease, and involve also those who are somehow affected by the cardiovascular conditions.
Thank you very much for raising all these questions. They are definitely burning questions. And Dorina, please share your experience about ischemic stroke.
Yes, thank you very much, Professor Petrov, for inviting. My name is Dorina Dobreva. I'm the founder of the Association for Stroke and Aphasia in Bulgaria. Founded back in 2020, a young organization, managed to sign the European Declaration for Stroke Action Plan in 2021 in turbulent political times with temporary government. We still remember those guys because it was our first time to step into the Ministry of Health. But this year I was really ashamed because we still have no national plan for stroke in Bulgaria. And when I was invited in Riga as a national coordinator, I was asked, why 45,000 per year? You're number one. It's a shameful question. I can't answer this question. Of course, it's prevention. It's the proper treatment where you, the cardiologists, are now disrupting the industry. So there is another way to treat stroke, which in my case was the question in the ambulance to my mother and me, where shall we take this lady? It's a shameful question again. It was a shock for the family. It's still a lady who is having rehabilitation in a very strong way by the family paying. Me backing up the family and business to be along with mother and trying to voice raise the voice and the awareness for stroke. Because in Bulgaria it's really very sad statistics. But it's very good to have these forums and understand that the industry and specialists and cardiologists are entering. So where you have cardiologists in the country prepared to treat the stroke, it's already a happy statistics because many more people will be surviving and treated in a proper way, so they will not get back at home by being a burden for the society. And actually it was the European study, the stroke burden for societies, and the comparative figures between each European country can take that I translated, and this was the first document I sent to the ministry. That's why they accepted the importance. It's very important to know that these documents, they have cooperation between themselves, like we, the persons. And this reminds me one interesting, important fact. On our very own parliament, there is a saying, unity makes strength. And I think this is the way to talk to the industry, talk to the policymakers, talk to the local people. All of the mayors in Bulgaria, they already have an information point in the municipality of even small cities with 150 people in Bulgaria. It is just a very innovative way so that it's not shocking, but it says which are the symptoms of stroke, how the people can change their life, and they can grab a brochure and understand there is the patient organization. So thank you again for this. We rely on you, of course, because you're the specialists, and it's all of these domains. It's the prevention, not to have the strokes. It's the proper treatment, you, the professionalists. The secondary prevention, no one is talking about this. We started talking. The rehabilitation, a topic which is underestimated. A lot of things, digitalizations, virtual reality, all of these innovative things. And life after stroke, it can be very long. On that level, we are trying to work as a patient organization and make people understand how they can live happily and fulfill their life. Not to be the same person, but try to change. Like the Grete in Norway, in our SAFE organization, she's on a wheelchair. She used to be a lawyer. Now she's running the patient organization in Norway by advocacy. So we try to learn from European practices, and I will be the one to be nominated in Bulgaria to really change the life of stroke survivors. Not because of my personal story, but because the statistics is really very frustrating. So thank you again for giving the floor.
Thank you. Thank you. Thank you for being your mission. Please, you have to know it's also our mission. So we
it's
are
a
going
common
to.
Mission, yes.
Absolutely.
Thank you.
Thank you as well on behalf of Bulgarian Institute of Cardiology, because I think you're completely right. What I see here is a big fragmentation. Everybody suffers. I mean, patients from different conditions. We suffer because of lack of good communication with the authorities. And I think this is exactly what the plan does. Defragment the field and unite us together to be stronger. I think this is the major message. And this is why stroke is a vascular disease, right? So it has to be also in this plan. And everything that you raised, the European Health Plan has those pillars, if you like, that you raised. Rehabilitation, primary and secondary prevention, digitalization, registries, everything. So it is in there. So we have to adapt it and we have to promote it. And then if we're all together, I don't think that the authorities would stay silent. If everybody says we need that, I don't think couldn't imagine how they would say, no, that's not acceptable, especially if advocacy also comes from Europe.
Absolutely. It's in fact not only stroke. We know very well that regarding the sudden cardiac death, also there is a huge gap on national level. So it's open burning question. So the education of population and installation of automatic external defibrillators is also one of the ways to reduce the sudden cardiac death on a national level. So we have really many topics in which the institutions have to assist the population to be more efficient regarding the early recognition and early interruption of possibly deadly disease, stroke, sudden cardiac death. These are one of the main causes of death in Bulgaria, and it's directly touching the digitalization, the application, the remote control and remote data sharing. So all this is very important to be discussed and to have the right decisions on the right moment. Alex, you wanted to share something.
Yes, because that data sharing is extremely important. We're focusing heavily now on the Bulgaria cardiovascular plan, but you touch upon something very, very important. That is, people travel. And it's unfortunate, but cardiovascular diseases are not something that happen and then go away after a week. It is something that you live with, and during that you want to enjoy a happy, healthy, in as much as possible life, and an enjoyable life, and traveling is for a lot of people a part of that within the country and across the border. And that the data sharing, that people are aware that your medical professional can share his findings with the colleagues, let's say, for example, my country, in Belgium. A colleague of mine is from Bulgaria. He has his medical records here. He works in Brussels for the moment. Well, the accessibility of that data, luckily, he is very young and he doesn't suffer cardiovascular disease, of course, but it's, that's the general idea, the traveling part, that you can share that, and then European initiatives of the European health data space come into play, and that's something that I wanted to discuss as well with you on the point that you've made. Yes.
Absolutely excellent point. In fact, our community, the medical community, we owe to big data several crucial therapies. For example, we know that beta blockers in heart failure, statins, we have this golden standard in the therapy nowadays because of the North Europe registries. Without these very important registries based on digital information gathering, we wouldn't have on time this kind of therapy. And digitalization and remote data sharing are absolutely important. And even now, Europe is like one country. So we have the chance to share between the countries the data, to put the data together and to take the right decisions, because it's definitely in interest of the European population. And it's extremely important to implement all these practices in the daily life.
If I may add something about registries, you are absolutely right. They started in the north and the Scandinavian countries, but now, and it is important to say that explicitly, because this is something that we can make use of. Now European Society of Cardiology has taken over this initiative into the EuroHeart registries. So they are easily accessible to each member state. So they're easily, we can share, we can take their experience, if you like, and implement it in a country. That's another point that has to be borne in mind, because registries are extremely important. And I think another very important point is the European Health Data Space. This would let us share the information and look into have one perspective on all the patients that we're treating, because people really nowadays they travel a lot. So I think this is very important. But registries are something that is easily achievable for us. We should think about it very strongly.
Absolutely. I will ask our local MedTech Bulgaria voice to be heard. Alec, please come on floor and share your intention. You are Young Society since yesterday.
Yeah, we are here since yesterday, thanks to my colleagues here again, and I'm really happy. We have been together with Kirill, if you remember, when we proposed this meeting, and now I'm really, really excited because the panel went in a very good direction. You discussed very sensitive topics, and I fully agree with Professor Velchev. Unfortunately, we don't have National Insurance Fund, we don't have a Ministry of Health, which is important part of the circle. We cannot succeed. Our main target here is to increase the awareness about the therapies and to increase the access of patients to the therapies. We will be supporting you. We are your voice to Europe, and we are the voice of Europe in help of you. That's it. Very simple.
By the way, if you agree and if you consent, it would be good to make a memorandum from this meeting and this panel, and to put the important points in which we had total consensus, and to send exactly this memorandum to the institutions. And because definitely we are together, professional organizations, European level institutions, patient organizations, and these are in fact the voices which the National Health Fund and the Ministry of Health have to hear. And if you agree, I'm taking the responsibility to put a summary, and to make a memorandum that to be signed by the stakeholders that are presented here.
I agree.
Okay, excellent. In case something different, a good idea, how to proceed. If no, thank you very much for your participation. It was a very fruitful communication and conversation. And thank you for your interest and thank you for being with us. Thank you. In fact, what Professor Criado mentioned is very important, to keep the time in order to have a real conference with very good ordered. And
in 10 minutes.
10 minutes.
10 minutes in Bulgaria is the same as 10 minutes in the US and other places?
It's a little longer. It's a little, but just a little. It just a little. It's just a little longer. Let's say it's 11 minutes. Okay, but yeah, it's important to keep the time, and we will start. In fact, we have to start. In case the technical stuff is ready, it would be nice. It would be nice to start. And Dr. Velchev. Okay, give me 1 minute to ask Dr. Velchev to come.
There's a red light in there. Yeah. Is that good? Yeah. Should I be green? No.
Frank, we are ready. Sorry about interrupting.
No.
Yeah, Dr. Velchev is coming.
So you want me to officially kind of get it started?
Let's go.
Okay, so this is the session 2 on the interventions on the branches of the abdominal aorta. And we'll be happy to co-moderate with my friend Hugo Londero and myself. Ivo Petrov is the first presenter on the first 2 topics, the first being how to perform efficient renal denervation.
Okay, thank you very much. In fact, it's more than honor to present before my teacher, Dr. Hugo Londero, who in fact gave me the, let's say, everything about endovascular treatment I have learned from him. Thank you. Thank you once again. No, in Buenos Aires, in Favaloro Foundation. Yeah. Okay. So I will speak about renal denervation as part of aortic branches intervention. Okay, what about renal denervation and what happened? Yes. Right button is clear. Okay. Okay. So, lifelong polypharmacy is failing as a therapy strategy for hypertension. It's more than clear in the trials. So, arterial hypertension is one of the biggest killer of our societies, and all the treatments can fail because of different reasons. But unfortunately, the uncontrolled hypertension is a huge problem all over the world. In fact, despite all the efforts, at least half of the hypertensive patients, despite the prescribed treatment, they are not controlled. And this investigation by Stefano Taddei showed very well that in case we put the resistant to uncontrolled hypertension, more than 50% of the patients that are hypertensive still remain hypertensive despite the treatment. And there, what happened? There are many reasons for that. But more than 7 decades ago, one of the first interventional approach to treat hypertension was radical sympathectomy. And in this, it's a simple matter to complete denervation. This is coming from gallbladder. From the gallbladder investigation, you know, the model of hypertension is created by gallbladder with ligation, step-by-step ligation of the renal arteries, and he presumed that the both afferent and efferent nerves stimulation is one of the reasons, is one of the mechanisms to have elevated hypertension, and he presumed that complete denervation, if possible, of both kidneys before the application of the clamps would give some clue to the existence of such impulses, and he presumed that the sympathectomy can be one of the methods to control the hypertension. In fact, in the 30s of the last century, of the previous century, the surgical sympathectomy showed, without any suspicion, a huge effect on the hypertension of hypertensive subjects, with very good control. Unfortunately, with the expense of big mortality and morbidity, and mortality was reaching between 6 and 10 millimeters of mercury. So this is, in fact, there are several different methods, technical methods, regarding the application of energy to the carotid or on the level of the kidneys. So the untreated control and compared to catheter-based denervation, this is, let's say, next step after the surgical sympathetic denervation that was put apart because of the high mortality. But in this situation, the efforts of the community, of the endovascular community, led to the invention of the sympathetic nerve denervation on endovascular method. So putting a catheter into the renal artery and blocking both efferent and afferent nerves has 4 mechanisms of controlling the high elevated blood pressure. And what next? What is happening? Could you please change for me the slides? It seems it's easier. What about the hypertension 3 trial? The hypertension 3 trial is very important for us. It was, let's say, negative trial, but in fact for me it's not negative. It's neutral. It's neutral trial. In fact, it didn't succeed to show statistically significant difference of sympathetic nerves denervation, or renal denervation, as a method of treatment compared to the placebo. And this is on top of the treatment. Next, please. So, but it resulted that in patients with initial higher elevated blood pressure, the result is higher, and also probably the next one is most important. Next, please. And it's very important then the number of points, denervated points, ablated points, is also very, very important. And it resulted that 60% of the patients in Simplicity 3 trial had between 0 and 1 point. So, more than obvious, they were not treated. And the reason for that, the operators in the trial were allowed to have between 1 and 5 denervation procedures done. They were not experienced. Next, please. And the Simplicity 3 was really not so successful, but this trial was the reason to learn a lot. We have learned about the points, and we have learned about the location of these points, and it resulted that the nerve terminations are more dense on the distal part of the renal artery and all the circumferential places. So the treating the all circumference and more distally would be more efficient. Next, please. So presumably this fact was checked in animal studies after the Simplicity trial. Next, and it resulted exactly that more quadrants you treat and more distal you treat, the effect on the arterial hypertension is bigger. Next, please. And the procedure itself, I already mentioned that it's important to treat more points and more distally to have a bigger effect. And also, it's important to have ambulatory pressure control, ABPM, and to have good control of medication without stopping the medication, without the control of a physician. Next, please. And this is the so-called Y pattern. So to treat not only the main vessel, but also the branches. And this Y pattern we checked in our trial, our proper trial. Next, please. We checked the idea to treat, to denervate not only the main branch of the renal artery, but also the secondary branches. And we have shown that both mean arterial blood pressure and also the systolic arterial blood pressure were better controlled in the ABPM, were better controlled compared to the group with only the main renal artery denervated. Next, please. And this is the Y pattern, one of the cases. Next, please. It's 53 one-year gentleman with high elevated pressure reaching to 200 millimeters of mercury systole during his hemodialysis session. It's a huge problem of the patients on hemodialysis, the bad control of the arterial hypertension. Next, please. And next, please. In fact, regarding the way of intervention, we are using in our case radial or brachial approach, absolutely by purpose, because in hypertensive subjects, the aorta is very tortuous and the trajectory of the renal arteries is downward. So it's quite difficult to go from femoral to reach the renal artery and to put a catheter there. And moreover, it was in the beginning, it was a 7 French catheter. And because of that, we are using upper approach, radial and brachial, in order to selectively, to go easier selectively into the renal artery. Next, please. And we are performing the maximum possible points. Next, please. You see it's upper. Next, please. Down. Next, please. Going to the branches. Next, please. And next. So it was in fact done with the flex catheter. The flex catheter was a catheter with only one ablation point on the tip of the catheter. Next. And after the animal trials, going next. And again next. This is the left side and the right side. Next. And this is the result. So having more than 12 points per artery, it reached a very good result on this particular patient. Next. And this is important, and this is the result, the objective result after the treatment. Next, please. And because of that, now the second generation, it's a spiral catheter with 4 points. So with one and only put into the artery, we ablate 4 points. And nowadays, our practice is to ablate at least 25 points per artery. So per side. Next. And this is in fact how is the protocol of renal denervation done nowadays all over the world. Next. And the procedural protocol is very important to be strictly followed. What I mentioned, the experience of the operator is important. Next. And the generator is allowing simultaneous activation of all these 4 points in any single session of the button. Next. Okay, this is example how the treatment is done with the spiral catheter. That is the second generation. Next. And there are several, 5, and nowadays there are already 7 randomized sham-controlled trials after the Simplicity 3, and all these trials have shown very good result. Next, regarding the control of the arterial hypertension with the utilization of sympathetic nerve denervation. And they appeared after these sham-control trials, several consensus documents, Taiwanese, Italian, Spanish, and now European. So European Society of Hypertension has a consensus document, next, advising us to perform in a special population of patients with arterial hypertension, with uncontrolled hypertension, to perform sympathetic denervation with 2B evidence. Let's say, next. And this is the trials. In fact, the 2 trials, spiral hypertension off-med, was very important, because the off-med trial, it means that it's a sympathetic denervation in patients without medication. In fact, it showed the biological effect of the treatment itself without medication, but also it was important to show the effect of the sympathetic denervation also in patients with uncontrolled hypertension with medication. And this group of trials, off-med and on-med, have shown, of course, they are sham controlled, so it's a full imitation of treatment also in the control group. Next, please. And these are the results. And next. And all these trials and the meta-analysis of trials have shown definitely that there is a huge role of well-done denervation, because it's always on effect on the sympathetic nerve denervation. It doesn't depend on the pills and so on. It's a treatment method that is 24 hours effective, including the early morning hours that are the most risky, the most vulnerable hours of the hypertensive patients regarding cardiovascular events. And these are the results, and it's very important that for some early patients we have nowadays 10 years of follow-up, and for the sham control trials we have 3 years follow-up, definitely showing in the meta-analysis that treating with sympathetic denervation is an efficient procedure. This is the radiance with what I was speaking to this moment was about radio frequency ablation. This is the result with ultrasound ablation, also very similar. So the most important is to denervate. It doesn't matter how. The most important to denervate the terminations of the sympathetic nerves. And what I'm showing here are the results of the trials and the registries. And it's very important, as I mentioned, that the way of doing it's very important. For example, in the on-med trial, the so-called escape phenomenon was more pronounced for the sham group. So the patients in the sham group had the trend to take additional medication because of the uncontrolled hypertension. And the other very convincing fact was that the crossover group, this is the sham control after the first year, when they received the sympathetic denervation, they had the same result like the treated group 1 year before. So it's repeatable, and it's definitely durable. And it's very good in line with the animal trials, showing that the sympathetic nerves, they don't grow. So after once denervated, the sympathetic nerves cannot grow. And now we are already on the phase of the reality. There was a huge enthusiasm in the beginning. After hypertension 3 trial, huge disappointment.
And now we are on the reality. So we have to decide in which group of patients we have to apply the second generation that is much more predictable on the proper way. So to treat Y pattern, main vessel plus branches, enough points, and the European Society of Hypertension had the consensus document in improving the level of evidence and the level of indication for this position. And of course, it's very important to have this treatment done in a excellence of hypertension center. And in order to have good control of the patients, good control of the medication, and good control of the follow-up on the proper way. Okay, I will skip several. So there are several algorithms that are very important. Several algorithms that are very important, and these algorithms have to be followed very strictly. And in our practice, we prefer to include patients who are with a proven high elevated sympathetic tone, like patients that are not only hypertensive, but also they have tachycardia, atrial fibrillation, sleep apnea, diabetes. So these are the patients that have the most effect. The biggest effect from the procedure. And what about the future perspectives? There are several trials about sleep apnea, about the combination in atrial fibrillation, combination with PVI, pulmonary vein isolation, together with sympathetic nerve denervation, with quite promising results. And thank you very much for your attention.
Ivo, how long does it take to do this procedure on the average?
Absolutely. It takes about 1 hour, 15 minutes with the upper approach. With the femoral approach, it's more complex. But with upper approach, it's much easier. And in some cases, in fact, nowadays, it's advised to treat also additional branches, the branches that are not branches of the main vessel, but also some accessory branches with 4 millimeter and more of diameter.
Essentially, you treat as many branches in as many arteries
as possible. Absolutely. And the second generation has a very big advantage because it's on wire. It's not so important to get selectively with the catheter.
It's over the wire.
It's over the wire, on wire. The first generation, the operator had to enter with the guiding catheter inside the renal artery. And nowadays, even from the ostium, without entering the renal artery, like in the coronaries, it's absolutely sufficient to go with a 0.14 wire, and after it to put the treatment catheter inside, and we are done.
Ivo, what to do with the polar arteries? Is
polar
it important
arteries,
to
yes, absolutely. Polar arteries, in case they are more than 4 millimeter, are also target for treatment. Yeah, because they are, in case they are big arteries, the 4 millimeter artery is absolutely sufficient to adopt the treatment catheter.
Okay, well, we can continue. Ivo, as you are my friend, I will give you 2 chances. One is to give the next talk in 5 minutes, and the other to do your live case in 5 minutes too.
in fact,
the next talk is when is renal artery stenting indicated and how to be performed.
I see that it was not, in fact, charged. In fact, I just will tell you, because it was not downloaded, unfortunately. It's 18 years old boy who was in fact sent by our colleagues from nephrology with critical stenosis of left renal artery, most probably fibromuscular dysplasia. It's rare to have atherosclerosis in this situation. And he was a typical, we have a publication about total and subtotal renal artery stenosis, and it resulted that in this situation, the kidney function, the depurification kidney function is practically 0 or 10%. It doesn't matter at all. But it resulted that even in total occlusion of a renal artery, there is a collateralization that is keeping live the juxtaglomerular apparatus, and we have proven that. And this is absolutely sufficient to produce renin. And in fact, nowadays, the guidelines say that the renal stenosis intervention is indicated in patients with proven secondary hypertension with elevated renin, bilateral critical stenosis, stenosis of the renal arteries, and also in patients with the so-called flash pulmonary edema, as part of the problem of patients with heart failure. And in this young boy, unfortunately, the colleagues, they have left him just alone without any treatment, and they told her mother that unfortunately this kidney will die. And at the moment in which the kidney will die, his arterial hypertension will improve. It was a tremendous strategy, and now it's 3 months after the intervention. His renin was 10 times higher than the normal, and now from 6 medication, now he's taking just only 1 ACE inhibitor. After the treatment, we opened with a simple balloon, non-compliant balloon angioplasty, the left kidney renal artery. By the way, the fibromuscular dysplasia is one of the indications not to stent, because the result in fibromuscular dysplasia with simple balloon, with a non-compliant balloon, is quite a beneficial procedure. And hopefully, after coming back from the live case, I will show the result. It was a simple procedure to cross a 99% stenosis, to dilate 2 times, and to treat the kidney artery of this boy. Okay, thank you for your attention. I will go for the live case and see you after that. Thank you.
Thank you, Ivo. So we continue. Next is Alexander Goreski on the topic of endovascular management of visceral artery aneurysms. Hopefully for 10 minutes.
Hopefully.
Or less.
Thank you, everyone, thank you for the organizers for having me here. I will speak about visceral artery aneurysms. I'm an interventional radiology coming from Skopje, North Macedonia. So, visceral artery aneurysms and pseudoaneurysms are rare conditions, accounting for 0.2%. Nowadays, they are mostly diagnosed on imaging as an incidental findings, and treatment options vary between surgery and endovascular treatment. Of course, nowadays endovascular treatment is preferred one. You will see why. This is a distribution from the literature regarding the distribution of by organ, by arteries, and we see that only in few cases surgery is better, or surgery is mainly proposed in terms of endovascular approach. We divide on true aneurysms and pseudoaneurysms, and the difference is substantial. Namely, in pseudoaneurysms, we don't have all the 3 typical anatomical layers of the vessel wall, and in true aneurysms, we have the 3-layer vessels, which is also different from the treatment approach and from the strategy before the treatment is decided. In today's presentation, I will focus on splenic aneurysms, renal aneurysms, and hepatic aneurysms. Splenic aneurysms are the most frequently diagnosed, mostly as an incidental findings, with 2,500 cases on 3 million in the literature. It is usually associated with some other aortic and other aneurysms in the body, and the rupture varies if there is a true aneurysm, or in the false aneurysm is up to 70%. They are usually asymptomatic and discovered incidentally. When we treat the splenic artery aneurysm, we decide to treat before it was if the aneurysm grows more than 3 centimeters. But nowadays, we even decide to treat in 2 centimeters if there is a patient which is young or pregnant women with high prevalence of high prevalence of rupture, and of course, if there is a bleeding aneurysm, we treat this immediately. We have different approaches, different devices to treat all the visceral aneurysms. So coils, this is almost always feasible. In more complex cases with wide neck aneurysms, we do stent-assisted coiling, like in the brain, or balloon-assisted coiling. We can combine plugs, coils, liquid embolic agents, and even flow diverters, or even micromesh stents you will see later on. This is a schematic picture on how this treatment, how these aneurysms can be treated according to the neck of the aneurysm and according to the position. Some cases for splenic artery aneurysm. This was a patient with acute bleeding, and we see that this was a distal pseudoaneurysm on the splenic artery regarding the pancreatitis affected the pancreatic tail. In these cases where there is a bleeding and patient is hemodynamically unstable, we don't choose our weapon, so we go distally as much as possible. And in this case, we coil the aneurysm proximally and distally, closing the front and the back door, and we sacrificed the artery. This is a case with so-called cold aneurysm in the mid portion of the splenic artery with a wide neck. We went with the guiding catheter and the diagnostic catheter because it was wide neck. The coiling alone would not be feasible, so we put first an open cell peripheral stent system, and then through the struts we went with the microcatheter filled with coils. In these cases, when we put a stent, we don't want to coil, we don't want to pack the aneurysm so densely, because we assume that in the near future it will thrombose, and this is the final result, that with the patent artery and the nicely placed coils and stent in the aneurysm. This was a case with non-ruptured, but case from the literature. It's not my case. When it is supposed to be mycotic aneurysm and very prone to rupture, we can combine coils plus liquid agents, and we can close the parent artery. Of course, not to damage the spleen. It's very difficult to damage because collateral vessel supply. This is our recent case, 67-year male patient, smoker, history of alcohol abuse and pancreatitis, chronic pancreatitis in this patient. He came to us with abdominal pain and some drops of hemoglobin level and chronic, I would say, anemia. We placed a flexor guiding along sheet in the proximal portion of the splenic artery. We see a nice pseudoaneurysm, partially thrombosed. Then we crossed with a wire and we decided to treat kind of off-label treatment with the placing of a dual layer micromesh stent, which can sometimes act as a flow modulator, flow diverter, like in the brain circulation. This is the opening across the aneurysm sac, and then the angiography right afterwards. So in the same session, you can appreciate that almost no filling of the aneurysm sac, and this is the 1-month control CT scan with complete exclusion of the aneurysm, full stent patency, and the nice parenchyma of the spleen. Hepatic artery aneurysms, they are more rare. You can appreciate 0.002 in 2 million patients. Male are slightly predominant than females. Etiology can be FMD, some rheumatological diseases, and usually we find in the hepatic artery pseudoaneurysms there after surgery or after iatrogenic injuries, biopsies, after radiofrequency or microwave ablation. This is an example that we treated a patient, typical patient, post-surgical patient. I think it was a Whipple's procedure. So he presented with bleeding. It was post-pancreatitic, sorry. But I see the clips, probably it was resected due to pancreatitis. Then we appreciate a large extravasation into the duodenum, and we put just one covered stent across the aneurysm, and we exclude it from the circulation. We see some distal stenosis and follow-up of the patient with slightly decreased lumen size. This is again a case with after Whipple redo surgery, and again excluded with, the aneurysm was excluded with putting a cover stent. After 1 month, stent was completely occluded. And we didn't appreciate any ischemic changes of the liver due to the, of course, we know there is a large collateral circulation, as we know 75% of the liver is supplied by the portal vein, not the hepatic artery. Renal artery aneurysms, they are more frequent than hepatic, but of course mainly increasingly diagnosed with non-invasive imaging as an incidental finding. Rupture are usually associated with high mortality rate, and if it grows more than 2 centimeters, we tend to treat them. If it's a true aneurysm, arteriosclerosis is the main cause. Of course, FMD and some other systemic connective tissue disorders can be cause of this aneurysm, but in this case, the treatment is completely different. Professor Petrov mentioned before, and if it's a pseudoaneurysm, of course, we tend to treat it immediately. Symptoms can be associated with abdominal pain, sometimes renal dysfunction due to consistent distal embolization, and there are some indications for these aneurysms that were acquired by the Society of Vascular Surgery, and they tend to say us if the aneurysm grows more than 3 centimeters, then we treat them. Treatment options more or less are divided to open surgery and endovascular approaches. Endovascular approaches are the same as the splenic and the hepatic artery. Some cases I will show you from our practice. It was a previously coiled aneurysm, but with regrowth and recanalization, it was stent-assisted coiling due to the wide neck. In this case, we just put one covered stent across and inside the previous stent, and we exclude the aneurysm from the circulation. Another isolated packing with coils with a very tight neck aneurysm, it is sufficient only to coil the aneurysm. If there is a wide neck, we can use balloon-assisted coiling. In this case, we use 2 guiding catheters from both femoral approaches. So first you inflate the balloon, and before that you put the microcatheter inside. You can coil the aneurysm nicely. I don't know why it happens. And this is the final result, complete exclusion. Flow diverters. In the brain circulation, we know so far that it is very, very popular to remodulate somehow the aneurysm. This approach can be proposed in the visceral aneurysms as well, but it's still under experimental use. And this is very recent case I will show you. I'm sorry for the pictures. It's sometimes done in our practice as an interventional radiologist. Unfortunately, we treat also non-vascular diseases, and this was a 63-year male patient, also alcohol abuser and severe abdominal pain with signs of infection. He was referred to us as a abscess formation for urgent drainage. I just saw the Viber images. You can see here is a large abscess formation in the left hemiabdomen, and also the doctor from another institution was asked for us to do a biopsy of the pancreatic head because he seems to have a tumor formation in the pancreatic head. This was one kind of our mistake. We immediately placed, due to the high frequency of patient, we placed the patient in the angiography suite, and this was done with my resident. He said, "Oh, I saw the abscess formation. Let's puncture. Dr. Gores can put a drainage catheter." And we did this puncture, of course, with an 18-gauge needle. And suddenly a blood came out from the needle, and the huge pulsatile arterial blood came out. And then we switched to fluoro. We performed how can I place this again? So we performed a direct angiography, and we see a large sac filling, and also we see in the late phase filling the superior mesenteric artery. At this stage, we stopped the procedure, and we kept some manual compression on the abdomen, and we put the probe, so we see a large pseudoaneurysm and the filling of this sac. So supposedly it was pseudoaneurysm of the superior mesenteric artery. We went intraarterially immediately. You can appreciate a large pseudoaneurysm on the right portion and displaced main stem of the superior mesenteric artery. Fortunately, with my colleague from neurointerventions, we just coiled the neck of the aneurysm. It's not very easy to perform this. And on the immediate control ultrasound, we see complete thrombosis with the contrast inside of the aneurysm, and this was then we performed the typical standard puncture and drainage of the real abscess in this case. So what I would like to say in this patient, this is the last slide, is a 1 month follow-up, complete resolution of the abscess and complete resolution of the aneurysm of the superior mesenteric artery. And to take home points, visceral artery aneurysms, both and pseudoaneurysm, are often asymptomatic and we find them incidentally. Endovascular management nowadays is the first treatment approach without any words. CT with CT angiography is the main stem essential pre-procedural imaging. Transfemoral approach is still the preferred one, but you can use radial, brachial, or some other approaches if in different and specific cases. And of course, we need to have full toolbox in our NGO suite in order to complete the treatment itself. Thank you. Sorry for the delay.
Comments, please. We have not much time, but if there is a quick question or from you, perhaps, no?
One question. Okay, so you're asking if there is a logic for us to do a covered stent, first to do the drug-eluting coronary or other type of stent, and then another stent. I must say there is no logic in this for me, because why to use drug-eluting stents in an artery which is not mainly atherosclerotic? We don't see a stenosis, and not always arteriosclerosis is the cause of aneurysm on one hand. On the other hand, you use too expensive materials, and I don't see any logic. Aha. Yeah, but this is only we find in a couple of cases with hepatic artery, because the distal artery, when the aneurysm is bleeding, is very the distal lumen is very slow. But still, this is I haven't seen this scenario. Maybe it works sometimes. For now, I don't see any logic. But thank you.
Thank you, Doctor. Well, the next speaker will be Dr. Victor Costache. Dr. Costache have to travel, no? Then we modify the order of the talk. His talk will be long-term results after endovascular treatment with multi-layer stents for thoracoabdominal aortic dissection.
Mr. Chairman, ladies and gentlemen, it's always a pleasure to be here in Sofia. I would like to thank Professor Petrov for his invitation. These are my disclosures. So, while the gold standard treatment for type A aortic dissection is open surgery, there is no consensus for the best treatment for type B aortic dissection. Thoracic endovascular aortic repair is indicated for complicated high-risk acute or subacute type B aortic dissection, and reasonable in high-risk chronic type B aortic dissection. The device we have used is the multi-layer stent from Intresta, Belgium, which is an open mesh self-expanding stent technology designed to provide extensive coverage of the dissected aorta. Actually, this stent was initially used in thoracoabdominal aneurysm, and we've seen excellent patency results of the aortic branches. So the Dragon study, which is a multicentric prospective international single-arm study, which included patients of myself and Professor Petrov, investigated the long-term safety and performance of this multi-layer stent in patients with type B aortic dissection. So what's very important, so after baseline assessment, the patients were implanted with multi-layer stent covering the entire dissected aorta and not only a segment of the aorta. So we had 27 patients which were enrolled in the study, both by Professor Petrov and myself, between January 2016 and September 2019. 3 patients were excluded, and then the protocol was amended in 2022 to extend this follow-up period up to 10 years. So what's important, in the 23 discharged patients which were treated, we implanted a total of 2.3 aortic stents per patient, and we covered an exceptional number of total 143 aortic branches. So here is one of the longest follow-up, an exceptional case report. 56 years hypertensive male patients of mine with complicated type B aortic dissection. Here is the CT scan, and you can see a typical type B aortic dissection with a false aneurysm extending up to the arch. And during the procedure, we implanted 2 multilayer stents, one in the thoracoabdominal aorta and one in the arch up to the segment 0 of the ascending aorta. These are the follow-ups. And what's very important is to look at the plane of maximal compression, which was at the level of T5 in this patient. And you can see the differences between pre-op, post-op, 1 month, 1 year, and 2 years, and up to 3 years follow-up. And what's interesting, you can see the remodeling, the maximum remodeling took place somewhere between 1 year and 2 years follow-up. So here is the computational fluid dynamic data with gradual increase in true lumen in green and decrease in volume of the false lumen. And these are the velocity curves showing lamination and remodeling at 3 years. So we published this case with 3 years data in GAVT in 2018. And this is this year's CT scan up to 8 years. So first time someone is seeing in a congress this CT scan. Complete remodeling of the type B aortic dissection, no false aneurysm, no more false lumen, excellent expansion of the graft and of the true lumen, and all the branches, both spinal arteries, renal arteries, mesenteric arteries are patent, and the patient is doing great 8 years after this procedure, longest follow-up in the world. So in the study, we have very few adverse events. No myocardial infarction, no renal insufficiency, no bowel ischemia, no paraplegia. And we, at 5 years follow-up, we had no device migration, kinking or loss of integrity, no neurological complication, or no aortic dissection related intervention. The overall survival at 5 years is estimated at 85.5%. So we have published in 2020, so like 3 years ago, the 1 year data of the Dragon study with my patients in GAVT. And what's important to see at this, that at 12 months, the mortality was 95.7%. So if we look back of the figures we have right now at 5 years, where we have an 87.5 5-year survival rate, so this means that only 8% of the patients were lost on a 5 years follow-up, which is an excellent mortality for such a procedure for type B aortic dissection. With high technical and procedure success rates, no neurological complication, and no aortic-related reintervention. So very important, no paraplegia, no loss of branch pathology, no rupture, no device failure. And outside the Dragon, we treated also type B aortic patients. So like this 56 years old female with type A aortic dissection, which was operating in 2018. Of course, for type A aortic dissection, we have to replace the ascending aorta, but she remained with the dissection of the thoracoabdominal aorta. So you can see the Dacron and the Bental procedure with the rebranching, and then we performed the endovascular procedure, which is a very easy procedure once you have replaced the ascending aorta and the arch. So you have to find the true lumen, and then you have to expand the multilayer stent starting from the Dacron, which replaces the ascending aorta, like you can see in these pictures, and finishing in the abdominal aorta. So these are some of the CT scans and follow-ups, 1 year follow-up, 2 years follow-up for this lady with type A aortic dissection, 3 years follow-up, and right now we have computational fluid dynamic studies on her, and this is the 7 years follow-up. This is the CT scan. I will, for the sake of time, I will go fast on this, but the disease is stable, like in the previous session, like in the previous patient with excellent side branches patency and complete remodeling of the thoraco-abdominal aorta. So this, our series of type A was published in Annals of Vascular Surgery. We call this technique kinetic elephant trunk technique, as opposed to the frozen elephant trunk technique. So what are the perspectives with this technology? So we combine multilayer stent with stent graft. So that's a 47 years patient with type B aortic dissection, complicated, typical type B, which is a nightmare to treat. So a obese patient, drug abuse with type B aortic dissection. And you can see a very big false lumen, compressed true lumen, and branches coming out of the false lumen. And the true lumen in the same time, and also the patient is unable to walk because both iliacs are compressed and dissected. So I'm showing you just the final results. So you can see a stent graft in the upper part, then multilayer stent from the mid thoracic aorta, and like a syrup with multilayer stent in the iliacs, and this is the CT scan. So we call it like a composite kinetic elephant trunk. At 2 years, we've published this case this month in Annals of Vascular Surgery. So you can see on the CT scan of the stent graft, and now you see the junction between the stent graft and the multilayer stent. Excellent remodeling of the thoracic aorta. We go down to the abdomen, and there is excellent remodeling. The patient is doing fine and is walking again. So, ladies and gentlemen, these are our conclusions. TEVAR with multilayer stent is associated with minimal operative trauma, also with a short endovascular intervention and reduced hospitalization period. Long-term clinical and computational fluid dynamic data confirm the durability of this new form of endovascular treatment. Of course, further studies are needed to confirm the role of these new generation flow modulating devices in the management of aortic dissection. Thank you very much.
Thank you. Thank you, Victor. Any questions or comments about this very interesting topic?
If initial time.
The what?
Do you use this device in acute dissection or in chronic dissections?
Well, actually, I don't like going right away, even if it's a complicated dissection. I like to wait at least 1 week to keep the tension down with drugs, and then we can safely go for the endovascular procedure. So, for example, the last case where with mixed stent graft and with multilayer stent, we actually received the patient, which he was acute. He was in pain, uncontrolled hypertensive, and we just kept him on IV drugs, and then after a week we performed the endovascular procedure.
So you think this composite strategy of standard stent graft proximally and then most of the aorta distally with this device is better than trying to cover it all with the stent?
Well, actually, we're covering it all, but I think it's better looking at all the data we have, like where nearly 30 cases of aortic dissection. It's better to, in some patients have a really big entry tear right after the subclavian artery, so it's better to close it with a stent graft and then just expand the true lumen with the multilayer stent up to the iliac arteries is needed. So you, Ivo has this nice term of publication of here to centralize the flow. So actually we centralize the flow, and you expand the true lumen, and you achieve remodeling, and it's nothing new. Actually, if we talk to our colleagues, interventional cardiologists, when they have to treat a dissected coronary, they treat all the dissection, not just a segment of the dissection. It doesn't make sense.
Very interesting. Okay, Victor, thank you very much.
Thank you.
Safe travels. So on the program there is the live case next. Are we ready to go live, or somebody going to tell us? So Yeah, they'll be ready for the live case in just a few more minutes, so perhaps we can go to the and do another presentation first, if the presenter is here. Where am I here in the program?
Maybe
Yeah.
this one, because this is a satellite symposium.
Yeah, is Dr. Janewska here and ready to present? Okay, Julubinka Janewska. The topic is visceral arteries interventions. Thank you.
Yeah, yeah. The visceral arteries interventions. Echo Doppler diagnostic of visceral arteries. Normal Doppler findings of visceral arteries, proximal abdominal aorta, and inferior vena cava in cardiovascular disease. Stenosis and occlusion on visceral arteries, arterial aneurysm, arterial pseudoaneurysm, and arterial dissection, compression syndrome of visceral artery, and anterior venosis fistulas. Conditional leading to difficult visualization of the visceral artery are obesitas, dyspnea, shadows of arterial calcification, and elongations, arrhythmias, stenosis of celiac trunk. The stenosis of celiac trunk may be asymptomatic thanks to the collaterals created by mesenteric superior artery or the congenital anastomosis of the visceral circulation. Stenosis of celiac trunk can be formed by atherosclerotic plaques, aortoarteritis, compression syndrome from malignant and benign formation, and Dunbar syndrome. Different type of stenosis of celiac trunk, atherosclerosis, fibromuscular dysplasia, and Mal's syndrome. Stenosis of mesenteric artery. The stenosis of mesenteric artery in the ratio woman-man is 3:1. Symptoms are pain after eating, weight loss, bloating, diarrhea, and gastroparesis. The stenosis of mesenteric artery are often asymptomatic. Significant stenosis are found in 14 to 24% of patients after abdominal angiography. Progression on symptomatic intestinal ischemia is about 15%. Visceral or mesenteric ischemia are acute and chronic, most caused by most often embolism, most commonly affect superior mesenteric artery, thrombotic occlusion, previous symptoms of chronic myocardial infarction, or other atherosclerotic manifestation. Powerful collaterals in the mesenteric circulation, celiac trunk and lower mesenteric artery, reduce the risk of intestinal infarction. Immediately life-saving recanalization. Complication is peritonitis and septal shock. Early signs and symptoms of acute mesenteric ischemia is 80% of cause include several abdominal pain, nausea and vomiting, melena, history of chronic and arterial fibrillation and cardiovascular disease, and peripheral atherosclerosis. Chronic ischemia, stenosis or chronic occlusion of the celiac trunk and mesenteric artery, atherosclerosis of the aortoiliac segment around 20%, aortoarteritis, in young patients fibromuscular dysplasia and compression syndrome, and AAA. Paraclinic studies, anemia, leukopenia, electrolyte abnormalities, hypoalbuminemia secondary to malnutrition, and symptoms of chronic mesenteric ischemia are abdominal pain after eating, weight loss, loss of appetite, fear of eating or changing eating habits due to pain, nausea and vomiting, constipation or diarrhea, history of cardiovascular disease. Treatment are endovascular treatment and stent implantation, and/or intra-arterial fibrinolysis, thrombectomy, bypass surgery, anticoagulant therapy, and antiplatel therapy. Protocol for visceral interventions: 6 French right brachial approach, 6 French right guiding Jatkin guiding catheter, 0.014 coronary wires for predilatation coronary balloons, and balloon expandable peripheral stent. Endovascular treatment of visceral ischemia, acute and chronic in the cardiovascular center for a period of 6 years are 202. Of celiac trunk is 104. Superior mesenteric artery 89, and inferior mesenteric artery 9. Primary patency for 1 year is 80%. Secondary patency is in 19%. First clinical case is male, 61 years old, after successful isolate aneurysm of AAA with wall stent implantation. Clinical presentation is abdominal pain, heaviness, reduction of body weight 7 kg in 3 months, and the risk factor for atherosclerosis, dyslipidemia, arterial hypertension, and smoking. This is the result of color Doppler ultrasound, critical stenosis of celiac trunk, and 70% stenosis of superior mesenteric artery. The CT aortography. This is the intervention, crossing with hydrophil coronary wire of the celiac trunk, and predilatation with coronary balloon. Predilatation with NC balloon using guide catheter extension, and after balloon dilatation, stent implantation, and final result. Stenting of superior mesenteric artery and predilatation. This is a stenting. And predilatation with coronary balloon. And final result. The second clinical case is male, 49 years old, with comorbidities diabetes, dyslipidemia, arterial hypertension, and chronic gastroduodenitis, and smoker. Clinical case with abdominal pain, postprandial heaviness, reduction of body weight 30 kilograms for 6 months, nausea, diarrhea, and pelvic claudication pains, 200-meter walking distance. Ultrasound diagnostic is with occlusion and critical stenosis. Occlusions in left superior femoral artery in distal segment, celiac trunk, and superior mesenteric artery. Critical stenosis in left external iliac artery, inferior mesenteric artery, and renal arteries left plus right. Ankle brachial index in left one is 0.5. This is a diagnostic of visceral artery, celiac trunk, and superior mesenteric artery, and diagnostic of inferior mesenteric artery. Diagnostic of inferior mesenteric artery with predilatation. Stent implantation, Herculic in inferior mesenteric artery, and after stent implantation. The second step is stenosis of left renal artery with stent implantation. Final result in left renal artery. Stent implantation in the right renal artery. After stent implantation. And conclusion is diagnostic and treatment of chronic and acute mesenteric ischemia, prevent dangerous life-threatening conditions. The highly specialized diagnostic methods, color, Doppler, ultrasound, and CT angio, are affordable and highly effective. And the effectiveness of endovascular treatment is life-saving with low % risk of and good long-term result.
Do you know which is the diameter of the struts of the multi-layer stent, or Dr. Kostas? Do you know? Can you tell us?
It's around
Yeah.
Because in this case, we can observe that the stent that you use in the superior mesenteric artery have a lesion at the origin, produce compression, yes.
Yeah.
Actually, Professor Petrov and his team have done several cases, and we have done a couple of cases, and there is a publication in the JCC,
Yeah, yeah.
which is going a paper which is going to be published, and so our colleague has presented this very nice technique. You just have to dilate the lot and then implant your stent, and it's and the patients are doing great. Our longest follow-up for such cases is 3 years, and the patient are doing fine.
But obviously you have to stent. I mean, balloon alone wouldn't do it.
Yeah, you have to stent.
Yeah,
We are ready for live
Okay,
case.
thank you so
Yeah.
much.
Thank you.
So we're ready for the live case?
Yeah,
Okay, good.
yeah. Female, 75 years old, presented with resistant arterial hypertension with maximum medical therapy, with risk factors of for atherosclerosis, dyslipidemia, arterial hypertension, smoker, medical history after PTA at stent implantation of celiac trunk and superior mesenteric artery and right renal artery before 3 years, aneurysm of abdominal aorta with diameter 34 millimeters in juxtarenal segment. In the regular last ultrasound Doppler, with result critical stent restenosis of right renal artery and progression of the diameter of aneurysm to 50 millimeters, more than 15 millimeter progressive for 6 months. This is the ultrasound Doppler pictures, critical restenosis of right renal artery. This is a CT angiography. And therapeutic method is double brachial and femoral approach after recanalization of right renal artery and predilatation from brachial approach, Chever, with 2 balloon expandable stent graft in both renal artery and stent graft implantation of abdominal aorta below superior mesenteric artery. Now, let's start the live case if colleagues is ready.
Hello, do you hear us?
Yes, we can hear you and see you.
Hello. So it's it's our pleasure to show a not very ordinary case. So as you have heard, it's a patient with a history of stenting of the celiac trunk, the mesenteric, the right renal artery, and extremely fast growing aneurysm from 3 centimeters had grown to 5.2 in less than 1 year. And in fact, this is the reason to think about isolation of the aneurysm. Unfortunately, there is no clear infrarenal neck,
and in fact it's juxtarenal. It's juxtarenal aneurysm, and because of that we decided, okay, you probably see on the screen, and I have Dr. Stankov, my main collaborator for endovascular intervention at all, Kate, the nurse, Lydia, the technician, Danny, the helper, and okay, this is in fact the CT. You can probably see the CT rotation. It's a and you I see that you see also the angio.
Yes, we do.
Yes. And we can start from the beginning. We can start from the beginning in order to show some comment or questions from the audience or from you, Frank, and Dr. Lundero.
How far is the superior mesenteric artery from the renal arteries? Which is the distance?
15 millimeter. 15 millimeter.
1.5 centimeters above the renal, the upper renal. And you probably saw on the presentation that there is a critical in-stent restenosis of the right renal and de novo stenosis of the left renal artery. So this juxtarenal aneurysm, our plan is to make a chimney technique for both renal artery and to use, like Dr. Lundero mentioned, to use as a neck the distance between the renals and the superior mesenteric artery. But more than obvious, we have to put the two chimneys above the superior mesenteric in order to have.
And Ivo, the aortic wall between the uppermost renal and the superior mesenteric is pretty good.
Yes, it's better. Let's say
better. Yeah, okay.
It's not excellent. It's not excellent. There are some irregularities, but it's much better, and definitely it's not aneurysmatic.
Okay.
And because
so
of that,
that's where
yes.
you plan to or intend to achieve a seal, right there.
Exactly. We intend to achieve a seal with very good oversizing. And because of that, we are planning to have 20% of oversizing of the main body in order to accommodate the two chimneys and to cover the not extremely healthy zone. So to have, there are two reasons for oversizing.
Ivo?
Yes?
Do you think that the strength of the stent graft for the chimney is enough, or will you use another stent inside the stent graft?
You mean the radial force or the distance, the length?
No, for the radial force at the level of the lesions of the renal arteries, restenosis and...
Yes. Okay, in fact, we are using quite a good big graft, Bentley stent graft. It's with a very good radial force, and the plan is after making a predilation of the in-stent restenosis of the right renal and the correcting the de novo stenosis of the left renal, to put the two chimneys, and after that to accommodate the main body. Up to date, we didn't have problem, at least at abdominal level. We have to date 64 abdominal chimney ever, and we didn't need to put additional bare stent in order to support the radial force of the big graft. The big graft is a very good radial force stent. Yes, Frank, you want to ask me something?
No.
Okay, and in case you agree with this strategy, Dr. Stankov will let you know what he did in the meantime between my going off the room and coming here. So this is the this is the last, and this is and this is the first. So this is ordinary both femoral abscess. Dr. Stankov mentioned that he had a problem on the right side because of stenosis of the
Femoral artery.
The femoral distal iliac, yes. And we have upper approach. Our usual strategy is to have upper approach, radial or brachial, in order to have the pigtail just above the renal arteries. But in this case, not only that. In fact, in this case, we are using both brachial in order to put two long sheets going inside the renals. So this is the situation. Now you see one sheet coming from the right and the other sheet coming from the left.
What's the size of those sheaths?
6 French sheet. The big graft is accommodating. The 6 French is accommodating the big graft without any problem. Absolutely smooth. No any obstacles. And it's a hydrophilic Cook shuttle sheet. It's quite easy to go down to the renals.
And it's transbrachial, right?
It's transbrachial.
Yes.
Transbrachial, we have a publication with more than 1,200 brachial accesses for all kinds of peripheral vascular interventions with very good results, extremely low complication rate, and much lower compared to femoral. And because of that, we are so happy with the brachial and the hydrophilic 6 French sheet.
Right.
And this is in fact, the present situation, but it would be interesting for you to listen to Dr. Stankov. He will tell you about the progress from here, from having both femoral, and he shared with me it was very difficult. Dr. Stankov?
Yes. In this case, it's very difficult to the crossing in the restenosis of the stent of renal artery. We know everybody in the case with restenosis, when it's implanted of the renal artery, the 2 or 3 millimeters of the strut of the stent going to the aorta. And very important in this case to the not crossing from the first strut to the distal part of the stent. We must to go in the middle of the stent, and this is very challenging. Yes, we do this with coronary device, run-through wire. After that, predilatation with coronary balloon on the 20 millimeters. After that, we put 0.35 wire Stork. And after that, I use the peripheral balloon 4 millimeter put the sheet on the stent for the have enough.
In fact, it's anchor.
Anchor, yes.
Anchor. So it's putting the sheet over the balloon.
Right.
It's a typical anchor technique. And Dr. Stankov shared with me that on the right side, where the restenosis was more than 90%, it was easier compared to the left side, where the stenosis is de novo.
Really?
Yes. So
because angulation on the left side, it's very huge.
You see, it's a really critical osteostenosis of the left kidney artery. And how did you proceed on this?
With the same maneuver, I take a different catheter, coronary guiding catheter, IMA.
Internal mammary.
Internal mammary, yes. Let the show. And after the crossing, more of predilatation of the lesion.
Yes.
We see the balloon going.
Slipping, slipping in there. There was a slip on the stenosis of the balloon, and finally, excellent.
Yes, and finally I put 0.35 But
So
I
that-
think advantage, not torque,
So that
or
lesion,
more support.
that lesion is probably calcified, I bet.
Oh, definitely.
Definitely.
Definitely. It's a calcific lesion. And it took, in fact, it was more difficult to go there. And I think we have filmed the anchoring. Okay, this is the ballooning.
Ballooning.
Next, again, ballooning. This is a balloon inside in the middle segment, and this is the sheet already there. So you see, this is the one of the Bentley coming, the left side Bentley coming. Next. Okay. Next. Now you are going. This is already the main body, positioned more or less on place, but it seems like let me see. Everything is fine. So we are going to proceed. Sorry, Litka. Sorry. Okay. No, we didn't film. In fact, now you have the two Bentleys. The two Bentleys crossed absolutely smoothly after having the sheet inside the both renal arteries. It was absolutely smooth movement of the Bentley big grafts to enter the renal artery. And like Dr. Lundero mentioned, we intend to put as an upper level of the Bentleys to be on the level, at least on the level of the superior mesenteric artery, even a little higher, a little more proximal, because there is advice to have several millimeters extension, so protrusion of the chimneys over the proximal part of the aortic graft. And in order to avoid compression, because of definitely it's more than clear, the radial force of the aortic graft is higher. And in order to avoid compression of the ostium of the Bentley, it's better to be several millimeters above, beyond the proximal part, just in the level of the free flow, above the covered part, but inside the free flow level.
Right.
Okay, and we are, in case you or the audience have some questions, comments, to do something differently.
Anybody has a question or comment right now in the audience? No? No, I think we're okay. Go ahead.
Yes, in fact, I wanted to show you that we did, in fact, both sides completely, you see, totally percutaneous. The lady is under conscious sedation. There is no cutting. We measured with the MANTA measurement device the depth of both common femoral arteries, and we are proceeding. And she's feeling quite well. Всичко наред ли е? Да, super. She's fine. She's doing fine, the lady. And you see the pressure is excellent. Even it's a little high, but it's okay. And okay. Now we are removing slightly. We are exposing the Bentley because they were covered up to that moment. They were covered by the distal part of the sheet. Now we are exposing the Bentleys. Like we have commented, in an almost lateral projection, we even don't need roadmap because we have the stent into the mesenteric arteries, excellent metallic roadmap. And можеш ли още малко дясна? And it's very well seen the aneurysm, the calcium inside the wall of the aneurysm. Okay. Now we are positioning the two. Okay.
Okay.
Not bad. I can move slightly the main body like that in order. Yeah, it's okay. It's excellent. The level of the Bentleys. Did you see the level of the Bentleys? It's excellent. It's just above the mesenteric.
Yeah.
Yes, and we can.
We are ready to start.
Yeah, we can proceed. Just a second. Yeah.
It's gently going down.
No, it's okay.
It's okay.
The other one, we can just a little too. It's this one is okay. And
this one. Little up.
Little. High.
Yes. It's too much.
Too much.
It's okay now.
I think this position is excellent. Дай на нормална графия. We are going to film it without subtraction in order to. Okay, дай фас за малко. Anteroposterior. Okay.
It's okay.
We are going to film. Excellent. Go lateral, if possible. Yeah. Closer possible to lateral projection. Okay. What do you think? I think we are fine. Just below the stent into the mesenteric. And we can, in case you agree, do you allow me to open it?
Yes, yes.
Yeah, it looks
we are
good.
going.
Very big graft.
Okay, we are going to open the big grafts. Okay, the big grafts
It's open.
are opened. And I'm proceeding with the main body opening. Okay.
Okay.
The contralateral is open. We can film now. Моля те, не диши за малко. Good. Absolutely. On such a way we can open the free flow. Yeah, the free flow is open. Записваме го това. Disinflate the balloons.
Ivo,
Yes,
which stent graft are you using?
We are using Endurant Medtronic bifurcational graft. Already we opened the free flow. The ipsilateral leg is still not open, and we can cannulate now the contralateral. In fact, we have used, the left side for the main body. It's extremely compressed. You see, the contralateral is extremely compressed.
Maybe it's better to go from the up.
I will ask you now what to do. To try at all or to go from above and to snare it. In fact, you see the contralateral, gate, the contralateral gate of the main body is extremely compressed. It's quite improbable to successfully. I think to try just for a minute, but probably it will be not successful to cannulate the contralateral. And in this case, we are going to remove the balloon of the Bentley of one of the catheters, one of the sheets. And we are going, okay, I'm removing the pigtail from the femoral. And we are taking, let's go with the right or directly with amplats. Go amplats. Yeah, Yes, Dr. Stanko?
Maybe
What do you think?
we open all main body because now the wire and the delivery system, it's put the contralateral iliac extension to the.
Yeah, we can.
Maybe it can open more.
Ivo?
Yes, yes.
Why do you think that the contralateral is compressed? The bifurcation is not not good diameter, or
no.
We are in the sac aneurysm.
It's a good question. Why the contralateral gate is compressed?
I think
strange, but it seems I'm inside.
Yes, you are inside.
It's unbelievable. Okay, let's go left. Запомни го това. Let's go left to right, and we will see the trajectory of the catheter. Okay, so it's one side compression. Let's say go right, go. Interesting. Okay, let's go AP fast. It's eccentric compression. You see it moves. Увеличи веднъж. It moves without any resistance, even on the level of the main body opened already. So I think I'm inside. I think I'm inside. This was the first maneuver. Запомняме го. And now with the second maneuver, we are putting the supportive wire, Lunderquist, and also we watch very carefully the movement of the gate, what is happening with the movement of the gate during the supportive wire. Not any big movement.
It moved.
It moved.
Yeah.
Yeah, it opened.
Okay, it's open.
Did you see? The gate opened a little.
Yeah, it opened a bit, yeah.
Definitely.
Okay.
So it's a second sign.
Let us see now.
It's a second sign that I'm inside. Yeah, already the ipsilateral is open now. Dr. Stanko finished that. This is very important.
Yes.
He's going up.
Very up.
Yeah, beyond the free flow. Yeah.
And not forget we have to.
In order to keep the nose.
Agora.
Go.
Excellent. Yeah.
Okay, now the nose is kept.
And now push-pull technique.
Push-pull in order to... Yeah, because we have chimneys there.
Stand.
Excellent. Push-pull is the best technique in the endovascular therapy. Push-pull. So in order to elongate and to, let's say, to keep apart of the okay, we stay on the left side. You see probably on the left side we don't have any problem here. Yeah, you see. Yeah, you see we are implanting everything sheetless. So this is our practice. This is our strategy both for thoracic and abdominal aorta. We are implanting all the devices sheetless in order to have smaller holes. And now we are ready to go. We are ready. Very interesting. It opened quite nicely.
Because we remove
during the time. Yeah,
delivery system.
The contralateral gate opened very nicely. So we are ready to proceed with the contralateral iliac.
yeah, we are going to put a 12 French sheet first in order to open a little the hole, and after that we are going to go again sheetless with the contralateral iliac extension. Лекичко натискам, няма страшно. Това беше. Супер. Идеално. Много добре се държиш.
Do you use percutaneous suture for the access?
Definitely, we are using in our practice. We are using for the main body. We are using manta, mainly manta, and since long time ago. And for the contralateral, because it's a 12 French, we are using off-label Angiosio 8 French. We have probably used, I don't know, we don't have exact statistic, but probably more than 212 French femoral sheets we closed with Angiosio 8 French. And absolutely without any problem.
And why not with a manta?
Because it's more expensive. so simple, yeah.
Great.
Yeah. Unfortunately, yeah, in our country, yeah, and unfortunately, part of the devices that were implanted also are partially paid, so the patient co-pay a little, but it's affordable. It's affordable.
It's a good observation for Argentinian people. We have the same problem.
Yeah, we are not rich country, so, and having in mind not only some other people in another building, you know what I mean.
And which is the relation of the manta with the proglide sutures?
Yes, we are using also proglide sometimes, but I don't know, mainly for patients that are not suitable for manta. We are using also proglide. We have experience both with the proglide and manta, and the two proglides strategy is also good. We had during certain time some problem with a series of proglide with a tear of the stitch. It was probably problem of the supply. But nowadays we are using mainly manta, and sometimes we are using also proglide. Okay, we opened the contralateral, and we are ready now to
ipsilateral iliac
proceed
extension.
To proceed the ipsilateral iliac. And following the measurements, we are going to. What about the internal iliac?
We have enough place.
So
it's not necessary to prevent.
I'm asking Dr. Stankov because he did the measurements. And because the iliacs on the level of the internal of the hypogastric are not aneurysmatic, we are going to finish above the internal iliacs. So without any additional need for sandwich or whatever.
Parallel stenting.
Parallel stenting or. Okay, I'm wetting. Okay, this is the good level. Open it. Yes. Excellent. And after opening the ipsilateral, that is already done, we are going to put back the 12 and 14 French sheets.
Are you ready?
Yeah, go. I'm compressing. We are putting back the 14 French on the main ipsilateral in order to have kissing maneuver with the Bentleys. And okay, let's put here the 12. Go. Само лекичко натискам тонка. Да. You see, I'm communicating with the patient, so I don't want to consolidate the sedation because we are going quite well. I mean by time. Okay. You go with the balloons. Remove the dilator of the 14 French. And we are going to inflate both chimneys, the Bentleys, and the main proximal part of the aortic bifurcation body. Okay. Going quite smoothly. Okay, there. Yes, the sheets are over. Yes, this is over. And this is over.
Okay.
So nothing that can do a problem for the inflations. And where is this one? This one is below the barbs of the free flow. This is very important to inflate the balloon below the barbs. Ready? Go. We're inflating the Bentleys.
Yes.
Okay, disinflated. One of the balloons ruptured, but it did the job. One of the Bentley balloon ruptured, but we don't have any more inflation there. So it has to be good. Okay. We are putting a second compliant reliant balloon in order to have some molding of the aortic graft. Gently.
Yes.
Like that. Okay.
Okay.
Just a touch.
Yes.
Go.
Go.
Excellent. It's like a palpation. It's not a real inflation. It's just to oppose. I don't know if you routinely post-dilate. It's our practice to, not to post-dilate, but exactly that, to oppose the graft over the artery. Okay, we are done. We are going to remove.
Okay.
Okay, and also the other one.
Okay.
Okay, good.
You like to remove the balloon of the big graft?
Okay, we are going to remove one of the balloons in order to put a pigtail.
Yes.
Let's remove this one.
Okay.
Because it's easier. So we are going to put in fact, we can even inject a contrast from the sheet without losing the access to the. This is better. Yeah.
Okay.
I'm sure you understand what we are going to do. We are going to keep the wire inside the Bentley, and we are going to inject contrast through the sheet. Let me see.
It's okay.
It's okay.
Yes.
It's excellent.
Yes.
We see all the set. Тонка, моля те, за секунда не дишай. Не дишай нормално. Да. We increase. Моля те пак за секунда не дишай. Не дишай, сега ще те затопли.
We still have balloon on the left side.
Okay, we have...
Let's remove.
Okay, let's remove the balloon from the Bentley. Excellent.
Okay.
Now we are... let's go one zoom in order to see better everything. Тонка, моля те за секунда, не дишай, не дишай. I think it's not bad. What's your opinion? Both chimneys are patent. There is no even late filling of the sac.
No stenosis of the renal artery.
No stenosis of the chimneys. What do you think?
At the right chimney, are there a little stenosis or no? At the
Let's
ostium.
see, we have still, you mean just at the ostium?
Yes, at the
We can, yeah, we can do one more injection in a slightly different
Selective.
projection. And let me see. Висок кръв. Дай малко нитро. Нитро. We are going to reduce slightly the pressure. Как е, момичето? Всичко наред ли е? Сега ще мине малко, ти е височко кръвното, сега го оправихме. Добре. Yeah, she agreed with our strategy. Okay, we are going to check with one zoom what is happening there. Моля те, не дишай, Тонка, не дишай. Не дишай.
It looks a little narrow.
I think it's fine.
Yeah, not too bad.
Yeah.
You have the wire in, you can inflate the balloon at
We
at this
have the
level.
wire in. Okay, but otherwise the aneurysm is excellent. Okay,
Yes.
let's go 5 millimeter balloon.
What about the internals, the internal iliacs? Can you see those?
We during they reach me the balloon, we are going to check the iliacs. Pass. Anteroposteri. Окей, супер. Пак ще те затопли за малко. Не дишай. Inject. Yes.
It's there.
In fact, we didn't do the trick of flow, so now we are going to do that. And we are going to see not only the internal, but also the external iliac arteries to create flow. So we are going to create flow now through the sheets. Ready? Inject.
Yep.
Yeah. Everything is fine.
Yeah,
The aneurysm is definitely isolated.
It's good. Yeah.
The aneurysm is okay, you have no leaks, you preserve the hypogastric, then
Yes, definitely. Everything is there.
Yeah.
Yeah, we are going to just to touch the ostium of the right chimney, and we are going to make the manta closure. Okay. The pressure is much better.
1 сантиметър нагоре. Да не върви импланта, нали? Така е, супер. Okay, slowly. Little the sheet down. Any resistance? Okay. Yeah, we are inside. Okay. We are ready to inflate. Okay, doc? She said. Just a second. Yes. Go. No. Inflate. Okay. 12. 12. Disinflate. That's it. Okay. Okay. Keep the sheet in order to remove the balloon. And you see both kidneys are working. There is a contrast in the pelvis, in the... Okay, ready? Ne dishai. Inject. Yeah. Okay. What do you think? I think we finished. In case, yeah, there is nothing else. Okay, let's go proceed with the manta. We are proceeding with manta. In case you want to observe the manta implantation, it could be interesting for the audience. I think the following session is a symposium of Pfizer, and in fact, out very good job of our operators showing the groin, and with the manta localizer already inside. Okay, now we are putting the plug. Now we are putting the plug inside. We have measured 3 centimeters, so at 4, I'm going up. Also up with the lever. Slowly but steadily. Going to the first click. Waiting a little, 10 seconds in order the sponge to moisture with blood and to activate. And this is the second. Let's see. You see? That's it.
Excellent.
We are
Great.
ready. Yeah. Cut. Now here, cut. Okay, super. And now the angio-seal on the 12 French.
There is a question, Ivo.
Yes.
Can you hear me? Yes.
Yes.
Okay, regarding the brachial puncture site, you use closure device for this or manual compression usually?
No, for 6 French we are using manual compression.
And because you said the huge experience is
absolutely
sometimes local hematomas, complications, compartment.
Exactly. You said it. Sometimes. This sometimes is less than 3%. With good manual compression, it's absolutely enough. And you probably see the 8 French angio-seal on the 12 French side sheet, 12 French sheet. Let's see. You see? This is the 12 French
Yeah, we can see
sheet site. Yeah, with the simple angiosio. Cut. Леко те заболя, разбрах. Няма страшно. Това е. Свършихме. The lady had some minor pain, and it means she is absolutely conscious. So that's it. Thank you very much. Thank you very much.
Excellent job, you and the whole team.
Thank you. Thank you, guys.
Ivo, will you give us your talk from there?
Yes, but I will ask Dr. Velchev to start.
Yes, he will start.
Order, I to have time to prepare my presentation.
Yeah, he's right here.
Okay.
Okay, excellent. Thank you once again.
Thank you, Ivo. Sorry, can I have my slides, please? Obviously, Ivo is using a fellow stop to stop the bleeding from the brachial. Very, very cheap device. You have a fellow, you tell him to stop the bleeding, and it works.
You mean the fellow is a cheap device?
Yeah.
Zero.
Zero cost. Okay. Okay, I don't really want to have a real discussion, but I just want to point out a few arguments about how to balance the thrombotic benefit and risk in AFib patient with acute coronary syndrome. Unfortunately, as you know, there's something like 15 to 20% of the guys we have in the cath lab with the acute coronary settings, and we have a number of trials which want to elucidate what's the best treatment for these people. We want to prevent stent occlusion, coronary syndrome, and thrombosis, embolization to the brain at the same time. As you know, we have 4 trials with the main NOACs on the market. Each of them have a slightly different design, but they all want to challenge the old-fashioned syndrome to the NOACs. Okay, so those are the short schemes of all the 4 trials, Rivaroxa, Pixaban, Dabigatran, and Trust trial. The slight difference is that 2 trials have different dosages. For Rivaroxa and Dabigatran, we have high and low dose. And for specifically for Pixaban and for Augustus, that's the trial we are going to concentrate in a few slides after. We have additionally hypotheses trying to show whether the aspirin on top of the double antiplatelet therapy is beneficial or it's only a harm. So that's the trial design of the Augustus. We have a little bit complicated design. We have this patient randomized apixaban compared to vitamin K antagonist, and then we again have randomization aspirin against placebo. It's quite a big trial, roughly 5,000 patients. And in this trial, we're going to concentrate on the safety point, which is the bleeding. And those are the main results of the trial, that apixaban is definitely better compared to vitamin K antagonist. And this benefit is widening over time. And aspirin from the other side is not safe. It's worse than placebo if you consider bleeding. Of course, it's something we expected, because more anti-aggregation you have, the more the risk of the trial. Those are 3 predefined groups. We have acute coronary syndrome and intervention, acute coronary syndrome, no intervention, and people with elective PCI. And you can appreciate that the biggest benefit is actually in the group with the patient acute coronary syndrome and PCI. And probably this is why this is the most morbid group. Elective patient, the difference doesn't reach statistical significance. On the other point, considering the major bleeding, aspirin leads to more bleeding in all the layers of the trial. So graphically, if you look at these graphs, of course, you have much more bleeding when you combine vitamin K antagonist plus aspirin, and less bleeding if you have only apixaban. plus clopidogrel but without aspirin, and other combinations are in between. And then the question, shall we do based on this trial go for double antiplatelet therapy instead of triple antiplatelet therapy? If you go look in the safety points, for sure, yeah, safety points is better with double therapy, but we have some signal on the efficacy point that if you skip aspirins or whatsoever, maybe you have more stent thrombosis, especially in the first week. So that's why it's not wise to go directly and skip the aspirin straight after the intervention. Let's challenge with an example of a patient. It should be a female, slightly obese, with a relatively low creatinine, but still in the good range, with an AFib for 4 years now, controlled hypertension, and treated with warfarin, lisinopril, and some diuretics. She is admitted with the crescendo of stable angina, so we in the setting of the acute coronary syndrome, high-risk patient, high troponin, and Gracie score of 120. If you take this patient and according to the Augusto sub-analysis, that means that the risk of major bleeding and intracranial is much higher if you continue keep her on the vitamin K and anticoagulation. On the other hand, you may see here on the right that definitely if we skip out aspirin altogether, the risk of stent thrombosis is greater, especially in the first week. If we try to put the graft to align them after the day 30, then again the benefit for the safety is still there, but no more benefit of the point of efficacy. So after the early period, the risk of thrombosis goes down, but the risk of bleeding persists. So that's why probably the recommendation of the European Society says that it's probably wise to consider a triple therapy, including aspirin, up to 1 week after the implantation of the stent, just to be on the safe side with the stent thrombosis. And then according to the risk of bleeding, most of the time we go to double anticoagulation therapy. That means 1 anticoagulant, 1 NOAC, and prasugrel. That's the graphically selling the same thing. 1 week of triple therapy, and then we go double for the rest of the year. And after the end of the year, we leave only anticoagulation. We skip anti-aggregation altogether. What if make analysis according to the renal function? You see that analysis according to the renal function is very consistent. If you only count on the safe side, irrespective of the renal function, it's safer to have a NOACs. Death hospitalization is also in the same, but if you count a death and ischemic event, then somehow you are coming to the equipoise. So for the ischemic endpoint, it's all the same whether you have a Pixaban or a VK antagonist. And if you consider impact on the renal function at interaction with the aspirin, of course, aspirin makes your bleeding points worse, but especially with a patient with a very poor renal function, when the risk of thrombosis is very high, you have definitely a signal that having aspirin early on board will have less ischemic events. That leads to this specific recommendation, as we commented. Straight after the implantation, especially in the acute setting, we go for triple therapy for 1 week, then we go up to 1 year for double therapy, and then we can skip anti-aggregation whatsoever. We have a specific recommendation for continuing aspirin up to 1 week. It's a class 1. And with the case of rivaroxaban and dabigatran, we have specific recommendation to go for the lower dose, especially with a high bleeding patient. In case with apixaban, we don't have the specific recommendation. So as usual, with this fragile patient, we have to weight the risk of ischemic event and risk of bleeding events and make a wise decision about how much medication for how long. So the summary, We have already well-documented advances of using novel anticoagulation drugs, which are much safer compared to the VK antagonist. Specifically, Augustus show very reassuring and nice results about apixaban, with or without an aspirin, but especially following the acute coronary syndrome, it's probably wiser to have anti-ischemic therapy on board for at least 10 days before you skip and go to double therapy, just to be on the safe side with both efficacy and safety. Well, thank you, that was from me. And I hope that Ivo is already prepared with his speech. But do we have a connection with City Clinic? No?
I think Ivo intends to come here.
So he intends to come here?
I'm ready.
Uh-huh.
Do you hear me?
Yes.
Yeah. Okay. Unfortunately, hopefully you see my screen.
Yes, yes.
Excellent. So, my task now is to speak about what is the evidence about anticoagulation therapy used in patients with atrial fibrillation requiring TAVI, requiring transcatheter aortic valve implantation. Speaking about aortic stenosis, this is nowadays the most frequent degenerative valvular heart disease, taking into the account of the aging population, both in Europe, America, and many other countries. The aortic stenosis prevalence is higher and higher. The problem is that in many of the patients with aortic stenosis, because the aging population, they have also atrial fibrillation. So aortic stenosis is part of the problem, and the aging population, for the aging population, in fact, the TAVI, the transcatheter implantation of aortic valve, was, let's say, invented as alternative of the patients with high surgical risk. But during the time and with the optimization of the technology and second and third generation transcatheter aortic valves, the high peri-procedural risk and advanced age, in fact, were not anymore the only indications for TAVI, because the trials have shown not only intermediate but even lower risk, excellent results of TAVI implantation compared to surgical, classical surgical procedure. And because of that, during the time and the excellent results, both the American and the European guidelines advocate, in fact, indicate the TAVI as a class 1 indication, and even more. There is the advice, the method of treatment to be discussed with the patient and the family. It's a real, let's say, expanded heart team. The heart team expanded together with the family and the patient, and to discuss with them, what is the best procedure, surgical or transcatheter procedure. And because of that, this is the reason that after the first implantation of TAVI by Alain Cribier, the number of TAVI procedures grow dramatically. In fact, the TAVI is considered the 21st century medical success story. And the key issues after TAVI are related to thrombotic and thromboembolic events. A little less problematic during the implantation itself, with very low incidence of stroke and other thromboembolic events. But unfortunately, I mentioned already that this group of patients, this cohort of patients, are sharing also the risk factors for atrial fibrillation, aging population, coronary artery disease, comorbidities, sympathetic tone elevation. So in this population, it's quite a matter of discussion. What is the proper treatment for antithrombotic?
And moreover, not only the atrial fibrillation, but the biological structure of the valve itself, both TAVI or surgical, it's also one of the predisposing factors for some microthrombotic findings. And I have read a very interesting investigation by Renu Virmani showing that preceding the degeneration is the microthrombotic tissue. So all the degeneration of the tissue valve is starting with microthrombosis. So the so-called subclinical leaflet thrombosis and also the hypoattenuated leaflet thickening that is also part of the problem are one of the predictors, two of the predictors for late events and early degeneration. And having in mind these initial trials, many teams and many practices started to advocate the utilization not only of simple antiplatelets, but also to use anticoagulants like vitamin K antagonists. There are some early investigations showing that both in surgical and TAVI valves, the HALT incidence is lower in vitamin K antagonist group. And what about the new oral anticoagulants, the so-called already direct oral anticoagulants? There are some investigation also. There are some registries. There are some registries like the American registry, the biggest one in the world, with more than 21,000 patients. It was shown non-inferiority of DOAC, of direct anticoagulants, compared to the vitamin K antagonist. There are several additional registries showing similar results, and this was the reason several randomized trials to be conducted with different direct oral anticoagulants like Envisage with edoxaban, apixaban, Atlantis, and also others. So the popular TAVI cohort B, this slide is answering the question to stay with oral anticoagulant only, or the oral anticoagulant to be added additionally to the antiplatelet in this trial clopidogrel. Unfortunately, it resulted that the combination with oral anticoagulant and clopidogrel has higher bleeding risk, and because of that, this idea was not confirmed. And because of that, probably this is one of the reasons in the present guideline, the indication is only antiplatelet in patients without atrial fibrillation, with previous stent implantation or acute coronary syndrome. But for patients without coronary implant or other indication for antiplatelet, it's better to stay on only oral anticoagulation. What about the Envisage? The Envisage with edoxaban was one of the trials showing older atrial fibrillation patients with TAVI, with multiple comorbidities, frailty, like the majority of our patients are like that. In fact, the Envisage compared edoxaban 60 milligrams a day with vitamin K antagonist. This was the randomization, and all cause death, mitral infarction, ischemic stroke, valve thrombosis were followed during this trial. No any difference in the baseline characteristics between the two groups. And this was in fact the patient's INR. We know that the INR is very problematic in the vitamin K antagonist usage. So this is very important. This is one of the biggest problem of the vitamin K antagonist. And let's see about the results. the primary outcome was met. Edoxaban is non-inferior to vitamin K for the composite primary outcome, the composite of death, myocardial infarction, stroke, and systemic thromboembolism. But edoxaban did show a numerically lower rate of all-cause death without reaching significance. Let's take a look at Atlantis. Atlantis was the trial comparing apixaban with vitamin K antagonist and also double antiplatelet compared to double antiplatelet or single antiplatelet. The primary endpoint results were definitely in favor of apixaban, showing non-inferiority compared to the vitamin K antagonist with very, very good results without any signal about safety. So it was absolutely, the safety endpoint was absolutely equal without any concern regarding bleeding, minor bleeding, measured bleeding, with excellent results. And also the secondary outcomes in the ITT population, and independently of what kind of specific features of the patients, we have patients with stroke, with previous myocardial infarction, and bioprosthetic valve thrombosis. All these features were without any problem, with definitely with the trend of lower probability of bioprosthetic valve thrombosis in the group with apixaban. You see, probably in case the cohort was bigger, probably this difference would have been significant, because numerically is quite impressive in favor of apixaban. And coming back to the European Society of Cardiology and the combined guideline, as I mentioned, the oral anticoagulation is long-term class 1 indicated for patients that mainly atrial fibrillation indicated for anticoagulation, and in case there is no other reason for antithrombotics, antiplatelets, the only oral anticoagulation is absolutely enough to treat our patients. Regarding our experience, of course, we are following the guidelines. It's a clinical case of a 84-year-old male. He's also with paroxysmal atrial fibrillation with critical aortic stenosis, and it's interesting to see that he's coming on treatment with apixaban 2 times 5 milligrams. He had a TAVI procedure on 7th of August, and he was with high risk of stroke, definitely with high Hasbled score. And the patient had no bleeding accidents, staying after the TAVI procedure. 1 year follow-up showed no signs of acute bleeding and no TIA or strokes in this particular case. In summary, randomized controlled trials to date in TAVI patients with atrial fibrillation showed primary efficacy and safety endpoints do not significantly differ with direct oral anticoagulant compared to vitamin K antagonist. While there is no specific guidance for DOAC use with TAVI, there have been no new safety signals. There is a need for robust real-world data set with substantial sample size to explore DOAC use in atrial fibrillation undergoing TAVI, but at that point, it seems quite a reasonable strategy to be applied in this kind of patients. And thank you very much for your attention.
Okay, Dr. Iveta Tasheva is in the room? Yes. Okay. Can you give us your talk, please?
So, just to see where's the cable.
So, hello everyone. As you can see, I'm not Iveta Tasheva, but I'm Damian Bojchev, and on behalf of Associate Professor Tasheva, I'm going to present you a short presentation of endovascular treatment of Takayasu arteritis. So, what is Takayasu arteritis? It's an inflammatory disease of the large vessels, and its etiology is unknown. It was thought that it's seen only in Asian or Indian descent, but in the years it has proven that the Asian and Indian descent actually have only slightly more frequent Takayasu arteritis, and it is, you can see it in every ethnos and population. It is seen in around 2 to 6 people in a million of population, and it's actually a granulomatous inflammation of the aorta. And why is it a problem? Because it's often leading to either stenosis, which is the more frequent, occlusions, and the most rare aneurysms. And what are the affected vessels? The affected vessels is the aorta as a whole and its branches. Most frequently, the supra-aortic vessels by truncus brachiocephalicus, carotid arteries, and subclavian arteries. What is the treatment? The mainstream of treatment is the medical therapy, the immunosuppressive therapy, and the second one is surgical or endovascular revascularizations. The survival of those patients is, satisfying. Its overall survival is around 90% in 10 years. What are the symptoms and morbidity of those patients? The symptoms start as unspecific symptoms. There is weight loss, fever, myalgia, malaise, headaches, a lot of stuff that nor the patients or the doctors think about Takayasu arteritis at the beginning, but afterwards the most frequent thing that leads the patient to the diagnosis is the upper or lower limbs claudication. And what is the morbidity? Actually, around 1/4 of the patients are unable to work due to their arteritis, and about 60% experience problems in their daily life. So a serious morbidity. The first criteria for putting the diagnosis of Takayasu arteritis were the Ishikawa criteria, and then a bit later on they were modified by Sharma in 1950. So what was changed? Only slightly they were changed. The obligatory criteria in the original Ishikawa criteria, the patients to be 40 years of age or younger, was removed. So as in infective endocarditis and the dual criteria, we should have 2 major criteria, 1 major and 2 minor criteria, or just 4 minor criteria, and they all include either carotid tenderness, the subclavian artery lesion, or stenosis, or Vruh, or we know them all, the criteria. So the newer ones, actually last year, the American College of Rheumatology published new Takayasu arteritis criteria. What was the need for Takayasu arteritis? It was said that due to the improvement in the imaging techniques, nowadays with the novel and more improved imaging techniques, there is problem with giant cell arteritis and Takayasu arteritis. And sometimes there is also involvement of the carotid arteries in giant cell arteritis. So what they did, they took a sample of 350 patients for developing the criteria of Takayasu arteritis, and they validated it in the same size cohort. So that are the criteria. They're pretty similar to the Ishikawa, but the difference is that we have a selection of symptoms, let's say, and we have a score for each and every symptom, and we should reach a certain score for we to have the diagnosis of Takayasu arteritis. Something important, those criteria and the patient are only in America, so it's not validated or neither Asian nor European population. Probably it's going to be the same, but still it's not validated. After we have put the diagnosis of Takayasu arteritis, we have to classify it. As in other aortic disease, we have a classification of the vessels involved in the arteritis. Type 1, we have only supraortic vessels involved. Type 2A, we have ascending aorta and supraortic vessels. Type 2B, we have also the descending aorta. Type 3, descending abdominal and abdominal vessels. Type 4, only abdominal aorta and vessels. And type 5, we have the whole aorta involved. So what about the medical treatment? We said that it's the mainstream of therapy. The mainstream of medical treatment is immunosuppressive treatment. We have pretty much the basics of immunosuppressive therapy: methotrexate, corticosteroids, then azathioprine, and nowadays we have also tocilizumab and trials with tocilizumab and or Humira, it's more known as Humira, for patients with Takayasu arteritis. As you can see, the study cohorts are very small and they also involve children. And as you can see, the children have better remission percentage and better results. And the last cohort with Humira in adults has, how to say, not so good results. But we definitely need bigger cohorts and randomized trials for sure. But we'll see if we will get there. So, about the revascularization, we have, as usually, surgical versus endovascular. What are the pros and cons? Surgical revascularization has better long-term patency, higher operative risk, and it's sometimes difficult to do because of extensive fibrosis or adhesions due to the inflammation. What about endovascular? It's lower risk procedures, and it's usually better suited for shorter lesions, and it has better results when a stent is implanted rather than just plain angioplasty. What is the common between the two things? It is preferred the revascularization to be done when the Takayasu arteritis is inactive. We should have a remission of the main disease when we do the revascularization, because otherwise we have a very fast restenosis. Also, something characteristic of Takayasu arteritis is that the restenosis rate is faster than in atherosclerotic disease. Also, the long-term immunosuppressive therapy is key, and we should have it gradually reduced if it is possible. So about our experience, 8 patients, 7 women, usually, as I think I told you, that it's mainly in women, but not only, it's not mandatory, and 1 man. 7 of them were under age of 40, as the initial criteria of Ishikawa required. The Numeno classification, most frequently there were with only involvement of the supraortic vessels, and frequency of stenosis versus occlusion and aneurysms, that is just a total number of vessels involved in those 8 patients. So the most frequent one is stenosis, followed by occlusions, and finally aneurysms, which is the most rare one. The clinical case of endovascular treatment, it's a 36-year-old female with known Takayasu arteritis, but she hasn't been treated till now. She has multiple syncopes, dizziness, headaches, weakness, and the ultrasound showed there is a thrombosis of the leak artery, the left subclavian artery, and there is probable thrombosis of truncus brachiocephalicus. There is greatly reduced pulse and pressure in both brachial arteries. So about the angio, you can see on the left, you can see the truncus brachiocephalicus, and it's, as you can see, it's a critical stenosis in the proximal segment. And on the right, you can see the left carotid artery, and it is occluded. So practically, the subclavian artery, as I told you, there were both occluded, so we have the only artery supplying the brain, the truncus brachiocephalicus. So what we did, a stent, self-expanding stent was implanted, followed by a few balloon dilations, and on the right you can see the final result. And as you can see on the far right angio, it is the artery that is supplying both ipsilateral and contralateral parts of the brain. So because of symptoms of claudications, upper limb claudications, the left subclavian artery was also stented a month after. It was stented with a balloon expanding stent. The first one is the initial projection, and the final, after numerous balloon dilations and the final implantation, followed by a few balloon dilations again, it is the final result. So the more interesting thing, the follow-up at 12 months follow-up, 1 year, we had 2 balloon dilations due to the restenosis of the subclavian artery, which led to symptoms. After intervention, there were no symptoms, and there were patent both arteries at the follow-up. What was the treatment, the medical treatment? She received double antiplatelet therapy with clopidogrel, acetylsalicylic acid, bisoprolol for hypertension, pentoxifenone for vasodilation, and double immunosuppressive therapy of methylprednisolone and imuran. So we have even longer follow-up of 60 months, which is actually 5 years. And in the meantime, we had several, I think, 4 or 5 balloon dilations due to restenosis of the left subclavian artery, which led to, again, claudication, again, asymptomatic after the intervention. And as you can see right now, the patient is on single immunosuppressive therapy, only with corticosteroid, and there is the addition of statin. Those patients should have maximum risk reduction because they have a main disease which is very high risk with great risk of restenosis. So we should minimize other factors: hypertension, smoking, statins, dyslipidemia, and all the stuff. And I'm going to show you, this is the CT scan at the 5th year. You can see that there is some restenosis, but actually a pretty impressive result for 5 years with endovascular treatment with Takayasu arteritis. And what is the take-home message? Actually, Takayasu arteritis is a rare disease, and it was thought to be only in young females, but that is actually not so. Not always young and not always females, so we should think about that. The medical therapy is crucial for the treatment of the disease, and we should suppress the autoimmune disease. After that, if there is no critical ischemia, we should revascularize after that. Stenting is better than angioplasty, and according to the literature, surgery gives better patency in the long term. As I told you, Takayasu is more prone to restenosis than atherosclerotic disease, and the strict control of risk factor is crucial. Thank you.
Doctor, we are on time or on Bulgarian time. Then we will finish the session. Thank you very much to the audience, to the speakers, and to Dr. Frank Criado, que be my friend.
Okay. Dear chairpersons, I'm about to start my short exposition about when and how to position tips. So tips is a procedure which is done on semi-emergency cases. And most of the time when you see some storm, maybe there is some rainbow some there. First, just to remind you that deranged hepatic microcirculation and cirrhosis actually means high resistance to flow. And usually you have a typical changes with changes in the sinusoids and relative enlargement of the contribution of the arterial flow, and the portal flow is steadily diminishing as the disease is progressing. So transjugular interhepatic port systemic shunt, that's TIPS, is a main reason to do it is to decompress a portal vein. So you want to have a low pressure in the portal vein at the end of the procedure, and usually we achieve this by connecting artificially the portal vein with the systematic circulation using a specific stent. So it's a very simple concept. In cirrhotic liver you have forward flow. Because of the high resistance it is slow and the pressure is rising, and when we bypass the hepatic circulation you have a very quick flow, but it is antegrade in the graft and retrograde in the pulmonary vein because it's not the normal way the portal vein functions. You can reconstruct the flow in the portal vein through the left or right hepatic vein. Both are doable and feasible. It depends on the anatomy of the specific patient. And the main proved indication is variceal bleeding and refractory ascites. Actually, now we're having quite good data that in these two populations, TIPS is prolonging life. But Chiari syndrome is a good indication, but it's rare disease and technically difficult. We don't have too much expertise in this. The emerging indication is the partial portal vein thrombosis, because reestablishing the flow can dissolve the thrombus. If the patient is foreseeing major abdominal surgery, we have some data that having a TIPS in place can increase the chances of survival. And hepatorenal syndrome 2 is also a good indication to put a TIPS. No absolute contraindication, but if the patient have a severe liver disease, that means that the prognosis is mostly dependent on the severity of the liver disease and not on the part of hypertension. Infection is considered contraindication because you can also infect the shunt. Pulmonary hypertension is not a good indication because after you put a shunt, usually we increase the flow in the right atrium and you can worsen the pulmonary hypertension. Of course, if you have occlusion of the portal vein, technically it's very difficult. I think encephalopathy and tumor which is giving a bad prognosis is making the TIPS obsolete. What kind of stents can we use for TIPS? What is approved now in most of the world is covered polyfluorourethane stent, and the specific stent at gourd, which having a portion which is not covered and is protruding in the portal vein, and covered portion for the other parts of the tract is a kind of a standard. But in many parts of the world, when these stents are too expensive, we are still operating with bare metal expandable and self-expandable stent. The position is very important. It can be problematic. If too angulated, you may have a turbulence and epileptic luminance, and it decreases the flow of the TIPS. If too deep in the right atrium, you can expect some arrhythmia and maybe thrombosis in the right atrium. But if too deep in the pulmonary vein, then the surgeons may have specific problems if they want to transplant the patient. So we have to observe some hygiene. Of course, TIPS can be done on an emergency basis. That's a patient with a Blackmore sonda, and it's very effective. These guys are also a good indication to put the TIPS on an emergency basis. So how do we do it? First of all, we access the internal jugular. You can do it blindly or on the ultrasound. It's up to you. And then you have to cannulate the right hepatic vein, and you have to be pretty sure that it's right and not the middle, because the the tract is very different. And in this situation, you may appreciate that we have a wire in the hepatic artery, which is just kind of a marker where the hepatic vein, usually hepatic vein, is in front of the hepatic artery. Sorry. Okay. Then, of course, there are specific needle, which is very different from the transeptal needle, but it's kind of a needle nevertheless. And you puncture more or less blindly from the hepatic vein to the portal vein. And after a few attempts, usually if you are happy, you can get the injection in the portal vein, which is the blind point of this procedure. And after having an access to the portal vein, next step is to reorient the catheter into the main trunk of the portal. And on the angio, you can appreciate your point of puncture and plan your tract. Of course, before you put a stent, it's important to measure the pressure and to see the so-called portal hepatic gradient to be just sure what we are doing. Then, of course, we put a stent. It's usually, in our experience, the self-expandable stent. We post-dilate the stent. And that's a final angio. On the final angio, you want to see antegrade flow in the stent and retrograde flow in the contralateral portal venous branch. And you want to have a gradient somewhere between 4 and 12 millimeters of mercury, and the procedure is over. Then you have to follow these guys, and you follow them on echo. Liver is very accessible for echo examination. Usually we have very specific spots, and we have to measure the velocity of the blood in all of them. And usually if the velocity is too low or too high, you can suspect the stent malfunction. Very important to have the velocity in the portal vein, and usually it should be quite high. It have to be above 30 centimeters per second, otherwise you can suspect again the dysfunction. Of course, you can do endoscopy, and you expect your varices to go away, and that's something. And the second thing, you expect in a matter of a few months the ascites to go away. That's also a good sign that your TIPS is functioning. Of course, on the dark side, you may have an early or late occlusion, and 1 year patency rate without assistance is something like 66%, with assisted is something 85%. We have an experience with something like 100 TIPS placed for 9 years. Nothing atypical. Most of the patients are bleeders. Half of them are ascites and few unusual indication. Etiology is mostly alcohol, but also virus and some other etiologies. And in our experience too, TIPS is very effective in decompressing the portal. Encephalopathy is the main complication in the long run, and you may see that the black bars is patients who dies, and the bars with these checkmate pattern is the patients who are alive but have bouts of encephalopathy. Of course, we face some late occlusion and stenosis, but usually those are managed successfully by percutaneous intervention. This is just one case. This is a patient implanted with a stent, but having a few months later bleeding, and the echo clearly shows that the stent is not patent. And that's why you see we have a problem here. The first stent is quite angulated, and probably the flow was not perfect. So we needed to put the second stent. We re-establish the flow, and the second stent is patent, 6 months, and the patient is okay, no more bleeding. So that's the game of TIPS. And if you want to do it successfully, you need to have a team. It includes a number of people, both interventional and not interventional. But without having a good gastroenterology to take care of this patient before and after, it's actually impossible to do this, for me, fascinating procedure. So thank you very much for your attention.
Dear colleagues, questions? I have a question for you. Which kind of stent do you use?
Most of the time we're using Protégé of Medtronic, but we have a few patients implanted with some other stents like Cook stent, Z stent, and also you can implant a sandwich. If you don't have enough radial strength, you can implant a balloon expandable inside the self-expandable. So it depends. Finally, you want to have a good gradient and good flow. The stent doesn't matter. But now we have this it's kind of trendy to implant stent graft inside the self-expanding stent, because we don't have self-expanding of Gore. We have balloon expanding stent grafts from two companies, Big Graft and iCover. Both are doing good, they're suitable for this, but of course it depends on your imagination.
In this situation, you first implant the bare metal stent, and after that the balloon expandable in the...
So we first implant the self-expandable,
yes,
just to be sure that we are having the hepatic vein and the portal vein connected and stented, and then inside the tract we are covering only the tract with the PTFE cover stent. Okay, thank you.
Thank you. So the next presentation, is portal vein and visceral vein thrombosis and vascular options for thrombus management. Dr. Zoran Stankov and Dr. Vasilev. The floor is yours.
Thank you. So the portal vein thrombosis is defined as a clot formation within the portal venous system, which is leading to a complete or incomplete portal venous obstruction. It can manifest under some conditions as hypercoagulable state, liver cirrhosis, malignancy, acquired prothrombotic diseases, or some inflammatory conditions. As you can see here on the picture. Sure how. The etiology, most of the cases of the portal vein thrombosis have pretty clear identifiable cause, and most of the time it is hypercoagulability with some inflammation or malignancy. Less than 20% of the cases are considered idiopathic. In order to better understanding of the multiple causes of hypercoagulability, we should recognize the multiple coexistent risk factors which are present in more than 40% of the affected patients. Infection, most often umbilical vein sepsis, is the main cause of portal vein thrombosis in children. Of course, portal vein thrombosis is documented after neonatal umbilical vein catheterization. And in adults, cirrhosis or abdominal malignancy and liver malignancy are responsible for more than 1/2 of the cases of portal vein thrombosis. Here you can see the different kinds, the acute, the chronic, and the tumor-related portal vein thrombosis. In order to diagnose this condition, we can use Doppler imaging. This is the first line diagnostic tool in patients with abdominal pain and patients with suspicion of portal vein thrombosis. Then, of course, is the CT and MRI, which are also helpful in order to evaluate the portal vein thrombosis, especially in cases of extension of thrombus into the superior mesenteric vein or the splenic vein. And a new thrombus may appear with increased attenuation on the CT, as you can see on the pictures, and with lack of enhancement in the presence of intravenous contrast when there is a tumor in the liver. Here are some pictures of different imaging techniques. Although many patients may be asymptomatic, the consequences of the thrombosis can be severe. By interrupting the flow in the portal vein system, the thrombosis most often leads to portal hypertension. that can cause bleeding with a mortality rate of 5 to 37%, and even more in some cases. Mesenteric vein thrombosis is responsible for mesenteric ischemia, which can be lethal, and acute mesenteric ischemia and infarction have an overall mortality rate up to 50%. And risk factors for mesenteric and pulmonary and portal vein thrombosis, as I said, hypercoagulable state and liver transplantation also. So how we treat this condition? Some of the guidelines say that anticoagulation is the first line treatment and can be sufficient in some of the cases, but in other cases we should go with thrombolysis and thrombectomy, or even TIPS, as we already saw in the first presentation. So there is no standardized approach, and we should manage it with a multidisciplinary manner and on a patient-by-patient basis. Here is a graphic of when we have pulmonary portal vein thrombosis or in liver cirrhosis. The treatment with thrombolysis, here is a catheter-directed thrombolysis combined with anticoagulation. Direct intrathrombotic instillation of thrombolytic agent achieves a high local drug concentration with a more focused and efficient treatment. And as an adjunctive therapy, techniques of mechanical thrombectomy can be used. Here is some study according to thrombolytic therapy for acute mesenteric and portal vein thrombosis. The tips, I will not talk too much about it because we already heard from Dr. Vasil Velchev. And I will show you, a case of our hospital. Here we have 11 cases, 4 patients with liver cirrhosis and 6 patients with malignancy, acute thrombosis in 5 with 100% recanalization, 5 with chronic thrombosis, and you can see we have reintervention in only one of these patients. The clinical case is a male patient, she's 67 years old. He was admitted to the clinic of gastroenterology, and he had abdominal pain and discomfort. His body weight was reduced with 10 kilograms for the past 1 month. He has loss of appetite, leukocytosis, and comorbidities, of course, tumor of the pancreas, steatosis, and pangastritis. And from the CT, he has portal vein thrombosis. Here you can see the CT of the visceral and hepatic vein. Here the angio. Sorry, I think we have one more slide. Can you go back one slide, please? Because after the thrombolytic agent, we have an MRI 3 months after that. Oh, here it is. The MRI, the follow-up of the procedure, and you can see that there is no thrombosis anymore. That's it. Thank you.
So you do thrombolytic agents through the arterial bed and expect this to go venous circulation?
It's very simple procedure, you see, and can be do it in any cath lab in the country, but the result is not better. It's better result from the only anticoagulation in this patient, and in the acute phase of this patient we have 100% recanalization, and for that we want to show this procedure, this type of procedure. Very simple but very effective, and it's not necessary some education like the education for the tips, not necessary so big team, and can be do it everywhere.
Do you have any bleeding complications?
No.
Okay.
Because the dose of Actilisa is 10 milliliter bolus, and after that we going with the infusion of the 20 milliliters for 5 hours.
So only 5 hours of thrombolysis.
Yes.
Okay. And
yes.
Yeah.
In this case, when show you the hepatic artery coming from the superior mesenteric artery, and this is the big change for the patient.
And this is concomitant with anticoagulation?
Yes.
Heparin?
Yes, heparin, or if patient coming on the NOAC or fractional heparin,
They
stay
can
on.
continue.
Yes.
They can continue on
Yes.
DUAC. Okay. Because that's interesting. Thrombolysis with DUAC is very interesting.
Yes, the dose of Actilisa is not so big. For that, we don't have any problem with the bleeding. And you can do it from the radial approach to reduce the complication of the access.
So, colleagues,
Any other
any other
question?
questions? Thank you. Thank you. Now, colleagues, we have some rearrangement in order to give enough time for Professor Velchev for the live case. So the next presentation will be endovascular interventions for failed AV fistulas by Dr. Pavel Unikov. Okay, he's not here.
Okay, the next.
The live case, is it okay? Okay.
Stoyanov is not here. Okay, we're waiting for the live case.
Да. Няма ги.
Нещото няма нищо. Нещо...
Hello, can you hear us?
Yes. And you? Yes.
Yeah, excellent.
Great, great. Hello, everyone. Good afternoon. Once again from our cath lab in St. Anna Hospital with our second procedure. And we are waiting a bit for Professor Velchev, and during this time Dr. Kamburu will present you the case because it's a kind of complicated case. And please, Dinko, show us the patient's history.
Good afternoon, everyone. I would like to please you to the next case from St. Anna University Hospital. It's another case of transjugular intrahepatic portosystemic shunt. So it's a 68 years old gentleman who had liver cirrhosis for nearly 2 decades, which is with hepatitis B in nature. He's in stable child B with no encephalopathy. The reason for the TIPS implantation in the first place was because he had refractory to medical treatment ascites and history of bleeding from the esophageal varices. And the first TIPS implantation, it was in 2018. So the striking abnormalities are low platelets and low hemoglobin with a little bit of elevated bilirubin. So this is the first TIPS implantation back in February of 2018. We then put a self-expanding stent, and everything was fine until 3 days later when the TIPS when we had a TIPS thrombosis, acute thrombosis, and then we put one balloon expandable stent. So this was 3 days later. In the last 6 years, we had a few interventions due to thrombosis, and we also did one drug-eluting balloon, also one covered stent, with a total of 3 stents in the graft. And the last procedure, it was last year of December 2022, when we had again thrombosis, and we put another stent in the graft, which was self-expanding, and we also did extension of the tract to the right atrium. I don't know if you can see the pictures.
Yes, excellent.
Okay, so in the last 2 months, he had recurrent ascites, and we did abdominal ultrasound, and what we saw was a decreased velocity in the tips on a post-wave Doppler. So the patient was scheduled for a new revision of the tips, and now I'll be back to Dr. Stoyanov, and he will present to you the what we've done so far.
Okay. As you see, we have a quite long history with this patient, and we had several procedures with 4 stent implantation. The first stent was self-expandable stent in the tract. After that, bare metal stent, balloon expandable. After that, we had opportunity to use a covered stent in the tract. And the last stent is this extension stent almost to the right atrium. And you can see the angiogram. We have occlusion of the stent. We advance a bit. Let me introduce you our settings. We had ultrasound guided puncture of the jugular vein. After that, we have inserted in the vein 8 French regular sheet, short one, and with diagnostic 5 French Amplatz right 2 catheter. We manipulate a bit with Terumo wire, and we were able to pass through the stents. We struggle a bit to have the right spot, but finally we were able to reach the portal vein. We insert a pigtail catheter. Finally, we measure the pressure, and now the gradient between the right atrium and the portal vein is about 20. We have an angiogram with subtraction, and as you can see, at the point between the WAST stent, the extension stent, self-expandable, and the other stents, we have a tight lesion that narrowing the tract. Our plan is to redilate the tract with regular balloon, peripheral balloon. We choose balloon 8 by 60, and after that we have a discussion with Professor Velchev about the strategy after that, to implant a cover stent and another stent, or to leave it with plain balloon angioplasty. Do you have any questions about the situation till now? Any technical questions?
Can I ask you some questions?
Yep,
it's clear that multiple interventions are needed in these patients. How you follow them? Is it based on Doppler, the indications for interventions, or some deterioration of symptoms?
Yes.
How this happens?
The bolt, he has a regular ultrasound checkup with abdominal ultrasound for the velocity into the port, and also the patient now has a CTs, and that's the reason why we had an additional ultrasound, and we were able to measure wall velocity into the tips, and we decided to redilate the tract. But the checkup is it's non-invasive with ultrasound.
I have a question too.
Yeah.
I saw
We'll
in the
proceed
history.
with the procedure.
Okay.
in
Yes. Of course. I saw in the history that you used a DCB for the stents. Is there any evidence for that?
No.
So you presume that it's like in the arteries?
Yeah.
Yeah. Okay.
We tried because the patient has now is the 6th intervention, and we are not able to solve the problem with the repeated restenosis in the tract, and we are at 10 atmospheres with our balloon.
Can we see picture of the angio? Oh, okay.
Yeah. We are waiting a bit, and Professor Velchev is here.
Okay.
Fortunately.
Come on, everyone. Hello. I think the case is quite advanced already. So probably I missed part of the discussion.
We discussed the strategy. We already ballooned with the plain balloon in the tract. We have a narrow lesion in the joint point between the last stent, the self-expandable stent, and the other stents. And now we dilate the tract, and the discussion is open for next step.
What the panel thinks, what shall we do? We just balloon it and leave it alone, or we stent it?
Do you have idea if this is acute thrombotic occlusion or it is more
No.
chronic stenotic?
It's actually chronic. There is no thrombosis there. And our gastroenterology department have a large experience with follow-up of this patient. So they just told us that we have steadily diminishing velocities across the stent.
Yeah.
So, but probably we have a mechanical problem somewhere.
Yeah. We have a rupture of the balloon.
Balloon is
At the-
ruptured.
Yeah.
So
At 10 atmospheres.
Okay. So what we think we shall do, we would like to cover the whole length of the tract and the and the hepatic vein with the cover stent, because we think that we will not protrude it in the portal vein for sure, but we know that covering inside the hepatic vein does not increase the risk of thrombosis. On the contrary, it gives us a better long-term result. And I don't know whether it was discussed, but the first indication was bleeding. So we have a severe bleeding, and this patient was coming from the military hospital actually after the episode of life-threatening bleeding. And since then, it is 5 years from now, there is no bleeding any longer, and we are doing the secondary interventions to keep the stent open.
After the rupture of the balloon is attached to the proximal.
Is it stuck?
Yeah.
Can we came with the sheet?
We have a short sheet.
Short sheet. Okay, let's see what we can do.
It's easy to advance it. It's easy to advance it, but it's stuck in the proximal part of the stent. We can inflate it one more time.
Yeah. So we can try.
No.
Reinflate.
Try it.
Try to have it out.
Inflation.
We try to inflate even the balloon is ruptured. It doesn't inflate too much, no? So please try to have it back.
Yep.
Partially inflated.
Not possible.
Is it back? No? Let me try.
Yep.
Good.
Inflation.
Just keep the wire inside. It's probably stuck on the this is something very peculiar.
Yeah.
Okay.
Great.
We are probably partially through the struts of the stent.
Yes.
But I passed.
That's why it catch on the.
But
on the
I
strut.
passed with Terumo J.
Yeah, but we see now that.
Yeah. Okay. No.
All right, but we may not try now to go once again, and this time we'll try to go through the stent. Let's try.
Okay. This what?
Do we have angio after dipole dilatation?
No.
We will do the angio after dipole dilatation. First, I think it's safe. No, we take a picture first. We'll make an angio, then we decide. Because this is a big stent, actually, it's not very difficult to go through the struts of the stent. You know, protégé is an open cell stent. It obviously it's protruding a bit. You see the catheter goes very easily. Може ли да дадеш малко субтракции?
Тук ще я махнах.
Георги, поеми въздух дълбоко сега. Задръж и не дишай. Дишай спокойно. Okay, we see the stent, the tract is patent now.
Yep.
Yes, but we still have some antegrade flow, which is not diverted, so we're going to measure pressure now, just to see what will happen.
The gradient was about 20 before.
Before.
Yeah.
Okay. The gradient is still the same.
Yeah.
So I think we will have to do something about this, and we will have to put a stent graft inside. Okay. Can I have the, what kind of, is it 6, 8?
This, no,
Oh,
8.
8. Okay, we'll leave only the wire inside, a regular wire, and we will need a multi-purpose catheter. A short multi-purpose, yes.
Изнизу. Ама не виждам нищо бъчо.
Да. Okay. So we left the wire as a marker, and we will try now to rewire again the stent. So please, if you have other presentation, you can watch us doing or go with the other presentations. Up to you.
We have no presentation, so we are all yours.
Right.
I have a question, Professor Velchev, for you. Do you think it will be helpful in some cases to, if we have, of course, if to use a debulking device?
In this situation, we never did that, and I don't know what we're going to debulk. It's not a real vessel, you know.
Yeah, I don't know the material inside the stent.
So, at least in the literature, there is no debulking
of these stents.
With this kind of stent.
Because really, we do not know what's inside. Maybe blood, maybe something else. I don't know.
We have some pathology studies showing that what you have inside is actually a tissue. And it is organized thrombus, which lately goes fibrotic.
So it's the same in the arteries.
No, we are not. We are again through the struts of the stent.
You can use also on pots. The choice of the catheter to select the vein and the tract, it's always between the multi-purpose catheter or Amplatz right. When I selected first of all, the tract and the stent was with the Amplatz right 2 catheter. And this is short 5 French Amplatz multi-purpose catheter. Diagnostic 1.
Can we go in the other projection?
Да. Да, смени на проекцията. Да.
No.
For safety reasons, sometimes we are using the small J Terumo. Long one, it's supportive. We can.
Do we have Amplatz catheter on the table?
Yes. Yes.
And now, what kind of wire are you using?
It's regular one Terumo.
Regular Terumo.
That looks better.
It looks the same. But
yeah, it's same.
Yeah, the same.
Same spot.
no, but we are not pushing the stand down when we do this maneuver, so I think we're not catched. May I have the LEO and TEREO?
Yes.
Okay. I think we're better now. Go to LEO.
Yeah, absolutely.
Okay. So we are going to put Amplatz super stiff now. We are thinking about putting inside the stent graft eye cover, so-called eye cover. It's a PTFE graft, very similar to the B stent, to the B graft. Just again for the safety reason, we are going to balloon it first. So we need a big balloon, something like 9 centimeters balloon.
What size of stent graft are you going to use?
10 by 40.
10 by 40, okay.
No, the stent graft is I think 9 by 37. But we are going to use balloon, the larger balloon.
Okay, have an LEO.
Да. Сега РЕО.
LEO.
Краката. Да махна субтракцията.
Yeah. 7.
Mm-hmm.
It looks like we are free because the dots are not moving. But we'll try with the balloon now.
Yep.
And what is the diameter of the previous stent graft?
The same.
The
9.
diameter of the self-expandable of the stent graft. The stent graft is diameter, I think, 8.
8 by 37.
8 by, yeah, by 37. Милевски, може ли малко да дадеш дясна коса да виждаме? Те опора?
Да.
Okay. We're dilating now slowly. Mm-hmm. I don't think we are through the struts. I think we are free. What do you think?
Looks better, yeah. Definitely.
Okay, take
It's
it out.
okay.
Yeah.
So I'm going to put a stent graft now.
To advance the balloon a bit? To advance the balloon, or it's done?
Yeah, we're going to advance the balloon
Yeah.
just to see how free it is moving. Yeah, just give me some backup, please. More backup. Yeah, okay.
Давайте, that's awesome. 8 atmospheres.
Okay. Go back.
Yeah. Pull it back.
It's easier now.
Yes, much easier. I cover stent graft.
Колко? 9 на 57.
9 на 57.
Are you going to protect the stent graft with a sheath? Aren't you afraid that when passing through the old stent, maybe the stent graft will be dislodged from the balloon? Or you have no such...
Usually don't, but we will do it this way because it's definitely safer. We exchange for the longer sheet, it's not a problem.
Да, ще ни трябва.
Има ли дълга седмица? 45 см 7 или 8? Destination.
Имаме 60 см.
Или 60, нещо.
Ще ги сменим.
Now, we have a few patients which were transplanted after TIPS, a few years after TIPS. And we have this feedback from the surgeons that when the stent is protruding in the inferior vena cava, it's a problem for them to make anastomosis. So nowadays we are trying to select the patients who are candidates for transplantation before, and we try not to go. But otherwise, for the regular patient, we always try to go a little bit inside the confluence, the vena cava, because we have an experience that it gives us less restenosis. Otherwise, what we plan to do, we try to cover partially the previous stent graft and to extend into the hepatic vein. And because we think that the real problem is the junction when the balloon expandable graft is having this self-expandable inside, and maybe there's some junction. We'll try to cover this area very precisely.
So you're looking for an overlap?
Yes.
Of the two stent grafts, okay.
Precious.
Колко е наш дизле?
8 French, we are waiting for
Okay, 6 in 8, probably will go. Може да сложим това. Без да малко да
7 French.
Да?
Stent 7.
Това значи ни трябва 7.
Okay. We are going to use destination 8 French long sheet to use a shuttle sheet technique.
Do you have some heparin?
No.
We need to put a little bit.
Yeah, that's a very interesting point about anticoagulation during the procedure. How much heparin do you give?
We are now going to put a little bit, so something like 3,000, small amount of heparin, because we are not fearing of the thrombosis, but we are fearing to having a thrombus inside the sheet during this manipulation. Това колко френче?
Awesome.
Супер.
Не.
Ники, махни го това от...
Да, окей. 60, вземам. Дай го 60. Вземаме 60. We are going to use a 60 centimeters 8 French sheet.
Ели, 3000 хепарин. Хепарин 3000.
Клапата.
Дай ми клапата. На ница има ли?
Дай го без клапа. После да сложиме. Okay, now. Oh, it looks like we are collapsing the stent once again.
Imagine what will happen with the stent graft if put it like that.
То няма мине и стент сигурно през него.
Не. Клапса. Що да не мине? Не? Дай ми го, да? Okay. When I'm waiting for the stent graft. The 10 graph is coming. So we have to start here, somewhere here. So we want to cover the all stand graph through and through, and to go for mechanical problem, which we foresee here. So what do you think about the position?
It's looking okay.
Yeah.
Yes, I think that's the position.
Okay.
Yeah.
I'm opening the stand.
Mm-hmm. Okay.
6, 8.
6, 8. Right, we stay for a while. We give it something like 20 seconds. A little bit more. 8 atmospheres, so that's fine. Okay, go back.
Mm-hmm.
Okay, we're going to do a little bit of pulse dilation. Okay, good. We are now pulse dilating the inflow tract. Hmm?
8.
8, 9. Perfect. Go back. The outflow tract. Now you again.
Eight.
9.
9.
Good, go back. In this situation, we don't want to go to a big stent graft because we don't want to risk to have an encephalopathy and...
Pull it back.
Yes. And now we're going to remeasure the gradient.
What do you think of postulate the upper part with bigger balloon to be better adapted to the self-expandable stent and even for future interventions to be easier to go in?
I think part of this self-expandable is kind of a protruding, so it's not supported by tissues. I don't think post-dilating will give us something. But now we will see the gradients and we'll decide. Okay, so let's have some zeroing. 0 is 0. So the pressure in the left atrium is quite low. Okay, something like 4 millimeters of mercury. And we are going to measure it in the proto-vein. Now definitely something like 20, so it went down. 4 by 19, we have something like 50 millimeters of mercury, which I think is acceptable. And now we are going to do a angio just to see the flow. Имаме ли субтракция? Поеми въздух, Георги, не дишай, не дишай. Okay, now we see this, the contralateral is already in the right direction. It's towards the hepatic vein, so we reverse it. And I'm happy with this gradient. So I think we leave it alone for a time being. And I suggest that will be the end point. What do you think?
Absolutely. Great job.
Okay, thank you guys.
Thank you.
So
Thank you.
We're finishing just by compressing the jugular like usual. There's nothing fancy about compressing jugular veins, so bye from us.
Okay, thank you once again. Bye bye. Dr. Stoyanov, can you hear us?
Yes.
You have a presentation about endovascular interventions for failed central venous catheter.
Yes, I know, but do you prefer to be in person there, or I can deliver the presentation from St. Anna Hospital? It's up to you. What's your suggestion?
Maybe you should give the presentation from your hospital, because
Okay, I need only 2-3 minutes to prepare my laptop and to start.
Okay, thank you very much.
Okay. see my slides? No, you can't.
Okay, we can see your presentation.
Great. And you hear me well, bro?
Absolutely,
I hope.
absolutely. Yeah.
Great. Okay. I'll deliver the next talk. It's going to be about the endovascular intervention for failed central venous catheters, in particular for the dialysis patients. Why this topic is so important? Because now we have a data that the using of the central catheters for dialysis, the numbers of the patient is increasing over the years, and this is completely opposite to the guidelines and in international guidelines in the years. And these international guidelines, it's recommend to use a fistula first in this kind of patients. But we have an explanation why this is the reality, because it's much easier to have a permanent or temporary central venous catheter for dialysis. It's relatively easy to insert in the venous system. We don't need to wait for maturation of the fistula, and quite a lot of the patients prefer to have this therapy as soon as possible. And also the problem is that we have our patient in the really end stage of their renal failure, and they need dialysis almost immediately. The problem is that we have a strong data that mortality rate when we use the dialysis catheters compared to the patients using fistulas is much higher, almost threefold increasing of mortality rate, and that's a big problem. What does it mean, dialysis catheter dysfunction? That means that the patient cannot have a good dialysis, and the machine increase the blood flow, and the patient cannot have good dialysis and cleaning of the blood. We can separate the dysfunction to early dysfunction and late dysfunction. Usually early dysfunction is due to some mechanical issues. What I mean, in our country, most of the physicians they don't use X-ray machine to insert the temporary or permanent dialysis catheters, and we should deal with this kind of problems, kinking of the catheters, the catheter tip is in front to the wall of the venous system, or completely in the wrong direction. We had a few patients with catheter inserted in the contralateral jugular vein, and this is kind of problem that can be really easily solved if you use X-ray machine and just to check the position, the final position of the catheter. The other issue can be the physician or the staff forgot to fulfill the catheter with anticoagulants, but that's by mistake, and it's really rare. What about the late dysfunction? It's most common, and we can separate the late dysfunction to intrinsic and extrinsic. And the problem here is with the thrombosis. We can see on the slide the different types of thrombus inside of the catheter, outside of the catheters, and these cause the late dysfunction. The fibrin sheet formation. This process is starting really early after the implantation. We have data that fibrin sheet formation is starting extremely early, 24 hours after the insertion of the catheter. And in the different patients is different, of course, but some of the patients develop a fibrin sheet in a really short terms after a few months. fibrin sheet formation, it's a reason for dysfunction of the late dysfunction of the catheter in between the 40 and 50% of the cases. What's the issue here? We have a thrombus and endothelial cells formation around the catheter, and the fibrin sheet, it's working like a one-way valve. What I mean, we can inject through the catheter, but we cannot aspirate, and that's a big issue for dialysis. This is an example for one of our patients. We have, this is how the fibrin sheet looks like when we inject through the catheter, and how we can deal with this kind of problem. There are a few different approaches, but one of the approaches to dilate with balloon, as you can see on the right part of the screen. Unfortunately, this approach it's not extremely useful, because this effect is lasting only a few months, and we can increase the patency of the catheter if we use a high pressure dilatation, bigger balloons, but in general this is temporary effect, and it's not a good idea to repeat the intervention every 2 to 6 months for your patient. We had another approach. Usually we have a patient with inserted catheters with the posterior approach in the jugular vein, and we are inserting the regular 0.35 wire and removing the catheter. After that, we are using anterior wall puncture, and with this maneuver, we insert the new permanent catheter next to the fibrin sheet, and we solve the issue. Why we're using this approach? Because with this approach, we are solving the problem of the patient, and also keep the dialysis of the patient the same shoulder and the same place, and we postpone the using of the contralateral jugular vein, because if we repeat the intervention between the both jugular veins and left and right, we can easily have a failed access, and this is a huge problem for the patient. The other technique, endovascular technique, is relatively easy, and it's to snaring the fibrin sheet. You need to insert into the catheter a regular 0.35 wire, and through the femoral approach, we should grab the wire and to snare the fibrin sheet all the way down. Usually, the fibrin sheet is stripped fibrin sheet is going in the pulmonary circulation, but in general that's not a problem, because usually we don't have a hemodynamic disturbance in our patient. The other issue is the central venous stenosis. This condition is relatively often when we have a different type of central venous catheters, also PICC lines or temporary catheters, and as you can see on the left side of the slide, it's in about 38% of the patients with temporary central vein catheters, we have such a problem. They develop a central venous stenosis. And how we can solve this kind of problem, and we are dealing in our daily practice with a lot of patients with such a problem. We are using plain balloon dilatation, and this approach it's with not extremely good result if you use wall pressure balloons or smaller balloons. You should measure, if you can, by CT the real diameter of superior vena cava, or the place in nominic vein where the central venous stenosis is, and and to use the proper balloon, high pressure dilatation, because with high pressure dilatation you can increase the patency up to 60% at the 6th month. The problem here is with immediate elastic recovery, and we cannot solve this problem with plain balloon angioplasty, and the implantation of the stent in such cases is mandatory. If you use bare metal stents, the patency is not so impressive, up to 50 to 60% at 1 year, and we should be really careful because your stent can migrate easily, and we need to implant longer stents and to be really careful. Mandatory here is advisable here is to implant stent grafts, but they have some limitations, anatomical limitations when we have a stenosis through the bifurcation of the both dynamic vein. There's a kind of limitation, and here there is a technique, as the screen is shown. We can use kissing stents, but this is the advanced technique and should be prepared for this. Otherwise you can compromise one of the both dynamic veins. And the patency here, it's really good. We have data that we have more than 90% of patency at the 1 year of follow-up. In conclusions, I want to say that we will see more and more patients with central venous stenosis, and we should deal with them. We need to be prepared for this and to have the right tools. And endovascular treatment for this kind of patient is a fourth-line treatment. And we as endovascular specialists should be prepared for their problems. Thank you. That's for me.
Thank you for the excellent presentation. If you have some questions, colleagues? Okay, thank you once again. And
Thank you, and have a nice evening. See you later.
Thank you.
Bye.
We continue with the next presentation, endovascular interventions for failed AV fistulas by Dr. Pavel Nikolov.
Hello everyone. So I will show you two cases of failed AV fistula which were intervened interventionally. So the first case is of the 65-year-old male with end-stage kidney disease with AV fistula from 2021, and 2 years later this AV fistula is failed. So from the echo we saw a critical stenosis of the arterial part of the fistula. So I'll show you the images. Here you can see maybe this is cool. Okay, here you can see no, the green spot doesn't go. Okay, here you can see very well the stenosis of the anastomosis right away, and the thrombosis in the venous part of the fistula. Most of these fistulas we made with brachial approach, with V18, and we start with this balloon 2.5 to 100. Many dilatations, but the result wasn't as suspected. So we took a bigger balloon, and you can see that this critical stenosis of the anastomosis part doesn't fix. So we decided to take the OPNNC on high pressure atmosphere, and the final result after, of course, of depth explantation was very, very good. So there is a residual stenosis, of course, but at this point the dialysis was possible. The second case is again a male with end stage. His fistula was okay for 5 years, but 5 years later again failed. So now you can see the thrombosis in the venous part, very high, and also there is there is a stenosis on the fistula time. So this was a little bit tougher with guide cut V8, with long wire, with bigger balloons. Again, the result wasn't okay. Maybe a little bit better, but sorry, just a second. Yes, again we made a dilatation of the anastomosis, and that's the final result after the dilatation of the anastomosis. I'm pretty sure by this case we didn't make any nitro or integrin or something, but in a couple of cases we did this. So our experience is not so big. We have almost 40 patients with around 60% of the patients was with post-procedure successful dialysis, but sadly this percent is lower after a couple of years. So the key message, our key message, of course, you know this, sooner better. Thank you.
Okay. Do you routinely use arterial access or the other ways to go through the fistula in retrograde direction for these kind of interventions? And the other question is, are all these cases for stenosis, or you have also thrombosed fistulas, and how you deal with this?
The approach is, so we made a diagnostic almost from the femoral artery, and when the AV fistula is down here, we almost use the brachial approach because of the length of the catheters and the wires. And when the AV fistula is over the elbow, we made also retrograde approach. About the second question, one more time, sorry.
Thrombosis.
Yes, thrombosis. With the thrombosis, the success it's not so high. We tried also with McNamara with fibrinolysis for 12 hours. Not the same result. Sadly, not the same result as by the cases with stenosis.
Yeah, I have a question for you too. Do you routinely use DCB for failed fistulas or just plain balloon angioplasty?
In 90% of the cases, almost
DCB.
DCB, yes.
DCB. Okay. Questions from the audience? Do not hurry. Okay, thank you very much.
Thank you.
Okay, we're waiting for the last presentation of Professor Petrov back from the hospital and present very interesting cases with venous pathology. Maybe every moment it can be here. Waiting for you.
Waiting for me?
Yes.
It has to be pelvic congestion, the name of the presentation. Yes, pelvic congestion. The name of the presentation is... So, did you do the radial approach for carotids on the room 1?
No.
You can. There is still. They are still there. Okay, pelvic congestion syndromes. In fact, it's a very interesting entity. Има ли някой, който не говори български? Is there some people not speaking Bulgarian? No. Окей. Значи продължавам на български. Значи този синдром за стаза в областта на малкия таз наистина представлява понякога един съществен проблем, особено за нежната част от човешката популация. И всъщност той горе-долу така и се и означава като дефиниция, т.е. болки в извънцикловия период и вижда, че около 40% от жените в някой момент имат проблем с този болезнен синдром, като посещават най-различни специалности колеги лекари, които са описани тук, гинеколози, гастроентеролози и така нататък. Всъщност става въпрос, колегите съдови хирурзи много често се срещат с такива пациенти и всъщност може да имитира различни патологии. Най-важното е, че много често се влияе от няколко механизма. Този pelvic congestion може да е по причина поради разликата в дренирането на лявата и дясната ренална вена. Знаете, че и съответно и superior mesenteric артерията и конфликта с лявата ренална артерия, която лявата ренална вена, която всъщност пресича зоната, където излиза мезентериката супериор и минава отдолу. Това е така наречения nutcracker синдром. И освен това може да има конфликт между дясната илячна артерия и лявата илячна вена, което пък произвежда така наречения Мей-Търнър. И в един и в другия случай, и в други компресионни синдроми имаме забавяне на кръвотока, затруднение на оттока, т.е. имаме стаза, а на всичкото отгоре можем да имаме и обратен ток. Може да имаме ретрофлоу. И касае се най-често за вродена предиспозиция и относително късна изява. Не винаги, понякога и в млада възраст, но така или иначе допълнителни клапи, обърнати клапи, както при CCSVI също така. И може да имаме различна анатомия, която да предизвиква стаза в областта на малкия таз, в областта на малките и големите вулварни устни, в областта на пубиса, в областта на глутеуса и тъй нататък. Понякога е много досаден, включително може да предизвиква и много сериозни състояния, включително и психологически, а дори може да предизвиква и задух при някои от пациентите. Тоест много е типично посткоиталната болка, която разбира се е още по-неприятна и влошава съществено качеството на живота на пациентките. Изобразяването на съответната анатомия и на съответните потенциални причини и доказването на много често и почти винаги колатерален кръвоток или на ретрограден венозен ток е една от най-честите находки. Така, т.е. когато се наблюдава увеличение на диаметъра, неочаквано увеличение на диаметъра на някои от вените, или пък се доказва такъв масивен колатерален кръвоток, както в този случай, или се изявяват колатерали по коремната стена по типа на кап от медуза, което сме виждали между другото. Може да се подозират такива патологични състояния, които са анатомично обусловени, както и конституционално обусловени. Някои, съм чувал, че колеги казват на някоя жена, която страда, казва: напълне и малко и ще ти мине. Един вид липсата на масна тъкан, издължаването на органите, издължаването на съдовете, всичко това може да са предразполагащи фактори. Вече споменах за nutcracker синдром. Това всъщност е ефекта, при който мезентерика супериор мачка минаващата трансверзално лява ренална вена и съответно се затруднява дренирането и на овариалните венозни съдове, което води съответно до ако греша, някъде ще ме поправите. В смисъл, ние не сме експерти и въпреки всичко, тъй като се занимаваме доста с така патология. И това е този nutcracker феномен, който аз след малко ще ви покажа един случай, който беше свързан с изключително драматични оплаквания, които много малко можеха да повярват, че е предизвикано от такава ситуация, но се оказа, че до голяма степен това е така. Ето още веднъж схематичното показване на тази картинка. Както споменах, често е при жени, но не е изключено и при мъже, както Мей-Търнър, така и nutcracker, макар че те са около 15% от всички симптоматични, т.е. най-често е при жени и въпреки всичко при мъже може също да предизвиква варикоцеле, съответно хематурия, намаляване на фертилитета, способността за осеменяване, влошено състояние на популацията от сперматозоидите и така. В миналото това всъщност диапазона на симптомите и съответно находките, както виждате, на pelvic congestion. и съответно става въпрос за тези връзки, relationship между артерията и вената. И както виждате, дори и тук е споменат астеничния хабитус. Това, което аз вече ви споменах, че някои колеги препоръчват на жените, и не само на жените, на мъжете, които страдат, препоръчват напълняване. Ето ги тези масивни колатерали, за които говорихме, които са един от белезите за наличие на такъв синдром. Как могат да бъдат лекувани? Подобрява се оттока, т.е. циркулацията се подобрява. Тръгнах да споменавам, ама се спрях и все пак ще ви кажа. Значи в миналото хирургически интервенции са били препоръчвани, включително за транспозиция на артериални съдове, така че да се отстрани компресията, махане от ортотопното положение на бъбрек и неговото транслоциране в илячната зона, само и само да имаме промяна на ситуацията и премахване на конфликта, на артериално-венозния конфликт. Всъщност, голяма част от тези синдроми са предизвикани именно от артериално-венозен конфликт. И какво може да се направи извън контекста на хирургията, т.е. като модерни начини на лечение, са много популярни, но знаете, сигурен съм, че знаете, за варикоцелето са емболизациите, тъй като варикоцелето до голяма степен е предизвикано от рефлукс, така че когато става въпрос за надкракер, както е показано тук, може да се преодолее, т.е. да се прекрати рефлукса с емболизиране на вена сперматика и съответно лявата овариална вена може да бъде емболизирана и съответно да бъде подобрен кръвотокът чрез имплантирането на self-expandable stent, който да запази проходимостта на вената въпреки конфликта, артериално-венозния конфликт. Виждате една поредица от койлове, които са наредени. Ето тук. И той не работи. Няма значение. Много често, поне в нашия случай, ние използваме много често, колкото и да е парадоксално, ама на нас ни е много удобно брахиокубитална вена. И някои казват, звучи ужасно, минаваш през предсърдието. Да, минаваме през предсърдието. Едно време при всяка дясна сърдечна катетеризация минавахме през дясно предсърдие, така че не е нищо драматично да се мине през дясно предсърдие. Т.е. от кубиталната вена е много удобно, особено за емболизация, тъй като аз вече споменах, че анатомията при тия хора много често е странна. И поради тази причина феморалният достъп понякога е изключително затруднен, тъй като катетърът трябва да отиде нагоре и след това да се обърне наопаки. Понякога този достъп не е много възможен, тъй като, разбира се, има тенденция за пролабиране на катетъра по посоката на по-малкото съпротивление, така че кубиталният достъп е възможен. А ние имаме един трик, тъй като в България кардиолозите са радиалисти. 97% от коронарните интервенции в България се правят с радиален достъп. Та ние, когато не можем или сестрите са затруднени, или е много голяма ръката на някоя пациентка или пациент и сестрите не могат да хванат голяма кубитална вена, ние правим всъщност радиален достъп 4 френча, пръскаме, чакаме късната венозна фаза и будеме под ангиографски контрол, будеме голяма вена. Така че да може вената да приеме, ето виждате тук пише 7 френча, примерно 6 или 7 френча, за да можем да свършим работата. И така, това са и искам и се да... Ето един пример за емболизация на овариални вени. Мей Търнър е сходна история, вече споменах, когато дясната илячна артерия притиска върху гръбначния стълб дясната илячна вена, като тази компресия може да стигне до екстремни стойности и до екстремни патологии, включително до пълна облитерация на лявата илячна вена, което, разбира се, е рядко и въпреки всичко след малко ще видите до какви екстремни моменти може да се достигне. И пак споменах, тук се вижда много добре, че набелязва се леко избледняване в зоната, там където дясната илячна артерия пресича лявата илячна вена. Наистина има избледняване, но е показателно, повече е показателно колатерала, който се вижда. Тоест този колатерал е доста по-показателен от всичко друго. И ето тук на MRI също може да се види, виждате, че right common iliac artery, виждате ли, и компримира лявата обща илячна вена. Това е също един от примерите. И съответно на Доплера също виждате този конфликт също тук още по-добре. И най-вече се доказва с IVUS, с интраваскуляр ултрасаунд е най-честата, най-голяма вероятност да докажете абсолютно с пълна сигурност, че става въпрос именно за такъв конфликт. Виждате тук даже има един такъв премостващ колатерал. Виждате как имаме компресия и премостващ колатерал. И нашия опит, 10 пациента с Мей Търнър в последните 5 години и 2 пациентки с надкракер. И всъщност сега ви показвам при една и съща пациентка двете състояния. Тоест, въпреки че не е чак толкова често, но горе-долу 30% от тях имат и надкракер и Мей Търнър. Това е една наша млада пациентка, тя при първата интервенция беше на 19 години. И ето това беше момента, ще го изчакам пак да се върне, това е EVUS, разбира се. Това е преди интервенцията, сега ще видите като тръгна наново, аз съм го сложил да се повтаря. Това вече е нормалната вена горе над мястото на компресията. И сега ще видите как буквално една силна сянка започва да се стеснява и в един момент се вижда, че около катетъра имаме две паралелни стени и съответно компресията от страната на артерията. Ето го. Да. И всъщност това ни, ето, чудесно се вижда как е между двете компримирано. Това ни убеди и всъщност на първи етап ние направихме на първи етап направихме стентиране по повод ето го колатерала. Виждате ли, леко избледнява на мястото, където се очаква, че мезентерика супериор минава върху реналната вена, но е много убедителен факта, че има колатерал, който отива нагоре към азикус. Тоест това е и това всъщност е стента, виждате, че не само, че се подобрява кръвотока, но и колатерал изчезва. Ето го. Влиза венозния контраст вътре и се връща обратно. Т.е. колатерала вече не функционира. Тая колатерална вена не може да изчезне, обаче престава да функционира като колатерал. И ето това е, много добре се вижда, че колатерала няколко минути след възстановяване на това, всъщност преодоляване на това притискане, това е протеже 14 мм, което беше имплантирано съответно в зависимост от измерения диаметър от айвуса. Така и това е същата пациентка. Този маркирания катетър е катетър, който идва от дясната радиална артерия, маркирания катетър. Всъщност маркирания катетър е айвуса, а другия, който е леко кривнат надолу, пак не можах да покажа, защото не работи поинтера, обаче така или иначе този катетър, който идва отгоре и е леко насочен към зоната на компресия, ето това е. Това всъщност е радиален катетър, отцветяваме илиачната артерия и съответно се вижда и компресията, това е оразмеряване на референтния диаметър, а това е което споменах, че виждате, че на фона на пръскането, което сме направили преди малко, очакваме да се отцвети кубитална вена и всъщност будем директно образа. Един вид будем нещо, което е дълбоко и то, разбира се, не може да се палпира, защото не пулсира вената. И всъщност сега не бяхме много убедени за компресията на илячната вена, обаче го доказахме и след като имплантирахме стента, виждате, че това е точно зоната, където имаше тези две стени, които буквално се събираха една към друга, там където притискаше артерията, притискаше вената. И така, всъщност, горе-долу ги казах тия неща, колкото и да са редки тези синдроми, те са понякога изключително влошаващи качеството на живота на пациентките. И ендоваскуларните методи до голяма степен в момента вече се превърнали в златен стандарт за тяхното лечение. И така, благодаря за вашето внимание. А доктор Васева ще покаже на постер, нали? На постер, да, няколкото случаи, при които имаме пълна облитерация на вена кава инфериор и съответно ендоваскуларно лечение, което е така, горе-долу в контекста на същата тематика. Някакви ваш опит? Да, това е много добре, много добре. Всъщност има няколко стента, които са с венозна индикация. Един от тях е лоу стент, който има много добра радиална сила. Има един... По-трудно се позиционира, да. Но до сега не сме имали много големи. Както видяхте, между другото, втората графия на лявата ренална вена беше 3 месеца след корекцията на надкракера и нямаше грам рецидив на компресията. Т.е. един вид протежето е издържал.
Рядко се виждат стенози или тромбози на тези стентове.
Да, не е изключено. Това между другото е много интересен въпрос. На каква антикоагулация вие ги оставяте или антиагрегация?
Задължително антикоагулация с...
Да.
Вече тук зависи блак. Вече най-често е...
Да, това е и нашия опит при това момиче също.
Долу за 3 до 6 месеца и след това само на антиагрегат.
Да.
Но който знаем със сигурност, че не действа, но нещо да пие пациент.
Тогава давайте натаспин. Да. Имаше един лав, че хирурзите много обичали плакек, защото не им хърви.
Така че не са много, че не са чак толкова редки.
Не са, особено за хора, които се занимават с съдова патология. Мейтърнър е чест. Мейтърнър е чест, да.
Лошото е, че от така наречените dedicated венозни стентове няма такива къси размери, които стават за надкръка, защото там трябва обикновено 4.
Така е. Да, 40 мм най-често е напълно достатъчно.
Други въпроси? Може и на английски. Благодаря.
Аз благодаря.
Ами с това, мисля, че сесията...
Браво.
Приключи.
Но много сте експедитивни.